Good morning, Dr. Sosh. Welcome to our meeting. Dr. Paul Gibson, good morning to you. Dr. Prakash Mehta here. Okay, now we are all set to start the meeting. To our delegates who are both on site as well as online, we have got delegates from across the world for this program. Welcome you on this program, and without much ado, let us start with the program. I request Dr. Ritu to come over on the dais and go ahead with the introduction of Dr. Sosh Rana.
Yeah. Great.
Well, as Revati is coming, I think I take this opportunity to thank both Dr. Sosh Rana and Dr. Paul Gibson because I think that time is, we are on a good Indian time, but the time across the Atlantic and Pacific is something that's different. And I thank you all very much for staying awake late to be with us.
Not too bad. It's only 9:30 in the evening here.
9:30. Okay. Okay, till we are just some technical issue, we are sorting it out. Till then, we should say our book on hypertensive disorders of pregnancy has come out extremely well, and we are going to release it today. I would request both of you to continue staying with us even after your talks, so that you are available for the book release as well as our inauguration. Because, of course, especially Dr. Sosh Rana has been like a pillar for us all the time, supporting us, doing things for us. And we are going to use Dr. Paul Gibson more and more in our future programs. Dr. Gibson?
Okay.
Yeah, now I request Dr. Revati to introduce Dr. Sosh Rana.
Thank you so much, all. And I hope I'm audible. I would take the privilege to be introducing our international advisor, Dr. Sosh Rana, who is the current secretary of the International Society of Study of Hypertension in Pregnancy. Welcome you, Dr. Sosh. She is the professor of Obstetrics and Gynecology, section chief, Maternal Fetal Medicine. She is the chief obstetrical transformation officer, Urban Health Initiative, the University of Chicago Medicine, Department of Obstetrics and Gynecology, Chicago, Illinois, USA. She has several awards and achievements. She has actually been awarded the Castle Connolly Top Doctors Chicago, Illinois Award, Castle Connolly Exceptional Women in Medicine Award, America's Most Honored Doctors, Bernard J. Tyson National Award for Excellence in Pursuit of Healthcare Equity. And more than anything, she has been our very strong collaborator for the Society for Maternal Fetal Medicine, and she's been our international advisor. Welcome you, Dr. Sosh, and she's talking on a very novel concept, translational research. Thank you. We welcome the chairpersons for the talk. Dr. Jyotika Desai, she's been the past president of the Bangalore Society of Obstetrics and Gynecology. Dr. Prakash K. Mehta, who is the president of the Society for Maternal Fetal Medicine, India. Dr. Rekha Gurumurthy, who is the HOD, Head of Department of Obstetrics and Gynecology from Sridevi Medical College.
Okay, I cannot hear you guys. I'm not sure if you guys can hear me. Your screen is mute.
I can hear you for what it's worth.
I know. I think their screen is mute. I see Revati. The screen where Revati is standing, that mic in front of you. Yeah. Now speak. You should be fine now.
You're able to hear Dr. Sosh?
Yeah, now we can. Yeah, I can. Yes.
So I just briefly introduced you, and we have the chairpersons on the dais. So we have Dr.
Should I
Sosh
share my
Mehta.
screen?
Yes, you can start your talk.
Let's see. You can see this? Yeah. I can hear me as well. Okay, great. Revati, you guys can hear me?
Yeah, we can hear you, Dr. Sarosh.
Okay, that's great. All right, guys, thank you so much for having me here. I can hear my own echo. Do you want to mute yourself, this doctor person on the podium? If you mute, maybe mute yourself.
Dr. Sarosh, could you see? You can hear us now very clearly?
I can, but I'm having an echo. But that's okay. You guys can hear me, right?
We can see your slides, we can hear you.
Okay, that's fine. Sounds great. Okay, everyone, good morning there in India. It's 10:30 at night here, 10:40 to be precise, but it's all good. I was watching TV. So this is good. All right, so we are going to talk about this topic of utilization of angiogenic biomarkers in women with hypertensive disorders of pregnancy. Revati, thank you so much for introducing me. I do have some conflicts. I work for some of these companies which have since developed the biomarkers and for their use in the US. So very quickly, I know I only got 25 minutes, so we'll perhaps go through some of the stuff fast because you guys probably already know a lot of this stuff. But we will talk about the biomarkers as it pertains to preeclampsia, but mostly about, I hope I can get to the clinical utility of biomarkers. And I don't promise, Doctor, that I'll stay back for the book reveal, but I will look forward to actually getting a copy of the book. So we all know this. Preeclampsia is a common hypertensive disorder of pregnancy. You guys probably have more cases of preeclampsia and obviously adverse outcomes, but it is responsible for a lot of maternal deaths and fetal deaths worldwide, and a lot of complications of preeclampsia, which is mostly hemorrhage and seizures, can lead to maternal death, and it's a common cause of prematurity as it pertains to really all across the world, but also in the developed countries. So one slide about what we're talking about here. So in general, what we are saying is that preeclampsia is an anti-angiogenic state. What that means is that if you look in the maternal plasma or maternal serum, the level of this anti-angiogenic protein, sFlt1, is high, and the levels of this pro-angiogenic PLGF is low. So if you actually just very simply, if you look in the serum of a patient, the ratio of sFlt1 PLGF is high. And essentially, there have been lots and lots of studies, hundreds of them done across the world, where these biomarkers, the ratio of sFlt1 PLGF, has been associated with diagnosis of preeclampsia and has been associated with adverse outcomes. We're going to talk about a couple of studies that we did here and how kind of led to the FDA approval of the biomarkers. So this is one of the very early studies that we did in Boston. And essentially what we did, we took patients who were coming to triage, which is a unit where you evaluate patients with preeclampsia. And we collected these samples, and at that time we didn't have access in real time. So this was all, the analysis of the biomarkers was done retrospectively. Essentially what we were trying to do is we were trying to see if the biomarkers measured in triage, how, you guys can still see my slides, right?
Yes.
Okay, I don't know if the team there can see. I can see the screen. Sahiti, can you guys see and hear me? Mm. Yeah, now they can.
No, yeah, okay.
Can you guys hear me? I don't see my slides on your screen.
Sarosh Rana ma'am, it will take 2 more minutes, ma'am, to sort it out in the conference room.
Yeah, what? Yeah. Are they trying to hook to like YouTube or what?
Not in YouTube, ma'am. In the conference room, there was a small issue, so they were trying to sort it out.
Yeah, I can see the screen.
Yes, ma'am. We've got you all back. Sahiti, we've got the line back. Sorry for the.
Yeah, I can hear you guys. Can you hear me?
Are you able to hear us?
Yes. Yes, I can. Can you hear me?
Oh, great, clear.
Yes, ma'am. We can hear you.
Okay, and can I share my slide again?
Yeah,
Yes,
please.
ma'am. We apologize for
Okay.
the small technical glitch and thanks for everybody for cooperating.
Do you guys see the slides? I don't see the screen anymore.
We can hear you. No
We
issue.
can see the slides, ma'am.
Okay, so should I start?
Yes, ma'am.
Okay, great. So I don't know where we were last time when we got disconnected, but essentially we are saying that preeclampsia is an anti-angiogenic state, which means if you look at the serum of patients with preeclampsia or who are at high risk to have preeclampsia in the near future, the ratio of sFlt1 PLGF is high. So the levels of sFlt1 is high and the levels of PLGF is low. And we'll talk about what levels have been shown in kind of clinical utility in pregnancy. So there have been several studies done regarding association of biomarkers to adverse pregnancy outcomes, but also in terms of prognostication as well as kind of diagnosing preeclampsia in near future. So this is one of the studies that we did a while ago, actually now almost a decade ago. So this was a study that was conducted. It was a prospective cohort study of patients who came to a Boston hospital between 2009 and 2012. And essentially, we took patients who were referred to triage for evaluation of preeclampsia. And we took their serum samples, and at that time, plasma samples. At that time, we did not have obviously the biomarkers in real time. So we stored these and we sent them later for analysis of the biomarker levels. And essentially, what we were trying to look at the outcomes and diagnosis of these patients within 2 weeks of their visit to triage. And we obviously were also looking for final outcomes of the pregnancy beyond the 2 weeks. So what we found was this paper was published in Circulation in 2012. And if you look here on the left side, I don't know if you guys can see my arrow, but on the left side is an ROC curve. So the way the ROC curve works is its sensitivity, and then on the bottom is 1 minus specificity. So the higher it is and more toward the left, that means the better is the test. So here, this dark blue line is the sFlt1 PLGF ratio, and we're trying to predict development of adverse outcomes within 2 weeks of their arrival. So sFlt1 PLGF was actually better in predicting adverse outcomes than all the currently available tests that we typically use. So it was better than uric acid, ALT, AST, even systolic blood pressure. And then when we looked at the levels of sFlt1 PLGF, it's a log ratio on the top graph on the right. And if you look at that, so the no is patients who did not have an adverse outcomes, and yes is the patients who had an adverse outcome. And if you can see here, the ratios of sFlt1 PLGF is so much higher in patients who ultimately had an adverse outcome within 2 weeks. And then we kind of looked at the latency, because obviously we don't want our patients to have adverse outcomes, and the patients who are at risk or are going to develop adverse outcomes get delivered. So here what we found was that this is just a Kaplan-Meier curve. And on the y-axis, the probability of remaining undelivered. So if you look at the blue line, those are the patients who had a low ratio. And if you look at the red line, those are the patients who have a high ratio. And it seems like patients who had a high ratio, a large proportion of them got delivered within 2 weeks, compared to the patients who had a low ratio. Those were not delivered and obviously continued their pregnancy. So moving along, this was another kind of study we did kind of on a separate group of patients, but still the same patients. So what happened is in about 2000 and I think it was 16 or 17, when the ACOG came up with a new definition of preeclampsia. And here, the way that they call preeclampsia with severe features was slightly different than before. So they kind of took out presence of proteinuria as like an obligated for diagnosis of severe disease. And in fact, they just said that if you have hypertension plus any of the end organ damage, you could be diagnosed with preeclampsia. So we wanted to see how these biomarkers predict or are associated with risk of developing preeclampsia with severe features. And a lot of things that we did here, in fact, in terms of analysis, was then later used to design this bigger trial that we just finished and published. So this was an analysis of 402 patients. And then out of those, 66% develop preeclampsia with severe features. So pretty significant proportion. Again, these patients are coming to triage for evaluation of preeclampsia. So they are not asymptomatic patients. They're patients already, all of them had some feature that they were being evaluated for any kind of HTP. So here what we did was we also looked at patients who were actually admitted to the hospital. So if you look at the top chart, so it is a ratio of 38 and a ratio of 85. And we looked at all patients for prediction of severe preeclampsia, 167 patients. And if you see here, the positive predictive value of 38 was 58 and the negative predictive value was 93. It's actually quite good. But then when we looked at patients who were less than 34 weeks, and here these are only admitted patients, like I said, even if you look at a ratio of 38, the PPV was quite high. It was 73 and the NPV was very reasonable, 92.7. So these are kind of some good numbers to remember in terms of when we did a larger study in terms of for the FDA for us to tell them what should be kind of our mark for having a PPV and NPV. And for people to understand a PPV of a blood pressure, for example, for prediction of severe pre-E or prediction of adverse outcomes is very poor. Traditionally, all of these tests that we currently use outside of biomarkers have quite a poor PPV. In fact, in some studies, the PPV is as low as 20%. So having a PPV in the 60s and 70s is actually a very, very kind of a good test for the biomarker. So I'm just going to quickly bring you guys why we even talking about it. So the problem, the reason we're talking about it is that this is the problem that we're dealing with. Very common scenario. So this is just made up scenario. The 38-year-old woman comes to triage. She's 33 weeks and 6 days. She's a G2P0101. She had a prior history of preeclampsia that she got delivered at 34 weeks. She has no history of chronic hypertension. We'll assume she has GDM. She's mildly obese, a BMI of 32. And she comes to triage with a blood pressure of 158/92. So mild hypertension. She fits the diagnosis of preeclampsia. PC ratio is 0.3. All of the other labs are normal. So the question that should come to our mind is, okay, she comes to triage and we're trying to evaluate her. So really what we're trying to do is we're trying to figure out what is her risk to develop any of the complications in the next 1 to 2 weeks, right? Because then based on that, you can make some decisions about should we admit her, should we discharge her, should we give her betamethasone, how frequently we should repeat the labs, should we just follow her outpatient? So essentially what we're trying to figure out is what is her risk to have any of these severe adverse outcomes, risk of developing HELLP syndrome, FGR, abruption, eclampsia, and frankly, what is the risk to have delivery within 2 weeks because of a preeclampsia? So the quick answer is I don't know. I don't know how many of you can tell me, but really it's very, very difficult to stratify patients unless they have frank signs of severe disease. So these are the decisions that we have to make, whether we admit her or discharge her. And obviously in the US and in a lot of the countries, we are kind of assessing the whole set of preeclampsia labs. So we get a CBC and we get a CMP. But if you don't have frequent access to labs, you also have to wonder whether you have to get all the labs all the time. And we frequently actually keep repeating the labs till they become abnormal. We should think about betamethasone because she's GDMA1. So that's going to obviously not be helpful for her glucose control. Should we counsel her about preterm delivery? Her prior delivery was also at 34 weeks, so perhaps she's at increased risk. If we discharge her, should we follow her closely in the clinic? If we are sitting in a smaller hospital where she's showing up in triage, should we transfer her to a higher level of care where she can get like adequate NICU care? And then also if we discharge her or even when you keep her in the hospital, what should be the frequency of monitoring? Should we monitor her like once a week, twice a week? What kind of monitoring we should do? So there is a good rationale for stratification of patients who come in with some symptoms and signs of preeclampsia, right? Because what you can do is if you can stratify them, essentially we are trying to stratify them in patients who are at high risk and patients who are at low risk. So you would ask the question, what should we do with patients who are at high risk? So like we're talking about, perhaps we can transfer patients to a higher level of NICU care if the patient is at increases to have preterm delivery, higher level of MFM care. We can definitely optimize betamethasone for fetal lung maturity. So only give it to patients who are at high risk. We can appropriately counsel our patients for anticipated preterm delivery. And then I'll show you some in the couple of slides that we can perhaps come up with a frequency, some sort of a frequency of monitoring. So increased frequency of monitoring in patients who are deemed to have increased risk based on ultrasound as well as biochemical tests that we do for assessment if the patient is getting HELLP syndrome or not. On the other hand, a large majority of patients are actually at low risk. So in those patients, what we can do, we can perhaps just do expectant management of whatever HDP she gets diagnosed with per ACOG. So if she gets diagnosed with chronic hypertension, you can do weekly monitoring in the third trimester. If she has gestational hypertension, you can do weekly monitoring and labs. And obviously, if she has preeclampsia without severe features, you can also manage them outpatient. Here, you can reassure your patients and family that the risk to have adverse outcomes and diagnosis of preeclampsia with severe features is low. And in some cases, I'll show you some examples. You can actually even prevent iatrogenic preterm delivery, which can happen anywhere between 35 and 37 weeks, sometimes with strong suspicion of preeclampsia. And then you can appropriately utilize your resources and you can appropriately admit and discharge patients. So based on some of the data that we had generated, and obviously lots of data came out from Europe and other countries, and we did this a recently study published now in 2022. It was called PRACES. So it was essentially for, it stands for, it was essentially a study done for risk stratification of patients with HDP. It was a multi-site study done across 18 different sites in the United States, and we were in Chicago, so we also participated in it. And essentially, what we did, we took patients who were admitted with any kind of HDP. So we were trying to predict development of preeclampsia with severe features within 2 weeks. So we obviously, at enrollment, if you already had preeclampsia with severe features, those patients were excluded. But if you had a suspicion for severe features or you had any of the preeclampsia without severe feature, gestational, chronic, any kind of HDP, and you were admitted, we collected the blood sample. Again, the analysis of the samples was done retrospectively. So the sample data itself, the level of the biomarkers had no effect on the clinical management of patients, and all clinicians who were managing the patients were blinded to the assessment of SRIT1 PLGF. It wasn't even done in real time. All the outcomes are obtained, and then SRIT1 PLGF was done retrospectively. And essentially what we were trying to do is within 2 weeks, we were ruling in and ruling out development of severe features, which was essentially defined by ACOG criteria. And what we found was very similar to our several previous studies that we had done here. As you can see here, if you look at the similar ROC curve, here the SRIT1 PLGF actually performed better than all other tests in this scenario. So the AUC for SRIT1 PLGF ratio was 0.92 compared to, for example, systolic and diastolic blood pressure, much poor, 0.67, 0.79. It was better than all the other tests that were collected at the time of the enrollment. And not only that, we had similar analysis as done before. And here, what I didn't have that slide, but essentially the SRIT1 PLGF of 40 gave us the best sensitivity and the best specificity, and had a positive predictive value of more than 65 and a negative predictive value of over 90. And those were essentially the criteria to be met for the FDA study. And here, as shown previously, the blue line are the patients who had a low ratio, red line are the patients who had a high ratio. And as you can see here, in 2 weeks, 74% of the patients with a low ratio are still undelivered, so large majority of them are still pregnant, while only 32% of the patients with a high ratio were undelivered. So large majority of patients who had a high ratio actually got delivered within 2 weeks. So based on this study, essentially PRACES, FDA did approve the biomarker use in May of 2023, and then I'm going to talk to you about the study that we did very quickly to implement the biomarkers. So when we implemented the biomarkers at the University of Chicago, one of the first hospitals in the US to do this was, and again, I'm just showing this for anybody. I know you guys are using it already, but if you're actually wanting to use biomarkers at a systems level, you need to do several things, such as in our hospital, we identified key stakeholders. So you have to identify your MFM type doctors. Obviously, in our institution, we had to talk to our chairperson, our chemistry lab director. So this is a test that is actually a send out test too. A lot of clinics now and a lot of hospitals in the US are actually sending it out. But I feel like there's a gap between you send it out and then it comes back like in a day or two. I think it does kind of the patient management, I think, is different. So in our hospital, we actually do it in-house. And then obviously we had to talk to our L&D director and nursing leadership. A lot of this obviously is done by the, it's drawn by the nurses, but also the nurses needs to know what the test actually represents. We did a lot of education to providers, such as I did lots of grand rounds, section meetings. We have residents and fellows, so we had to teach them what the biomarkers mean that we did a lot of lunch and learn. And then we, at least for the simplicity of using the test on patients and not everybody trying to figure out what to document, we actually created a lot of dot phrases. These are like if you use an electronic medical record, you can create like a standard language around using the biomarkers. Then we provided in that dot phrases some guidance to patient counseling, as well as obviously as the results started coming up, we went back to the physicians and said, hey, you're using the biomarkers X, Y, and Z happened to your patient. And then obviously we published our findings too. So our workflow for biomarker implementation in our clinical practice was actually very simple. It just had simple 4 steps. So if anybody who was admitted to the hospital with a diagnosis of an HTP between 23 weeks and 34.6 with a singleton gestation. So that's how the FDA approved it. FDA approved it as a test for singleton pregnancy in a gestational age window of 23 and 34.6 and with an SRIT1 PLGF ratio of 40. Essentially, if the patient was admitted, we sent out SRIT1 PLGF ratio and it came back. And it came back as a number. So the number is less than 40. We said that the risk of having adverse outcomes and severe preeclampsia within 2 weeks is very low. So the NPV in the PRACES study was 95. So it's less than 5% chance that you'll develop severe preeclampsia if you have a low ratio. Your risk to have adverse maternal as well as fetal outcomes was also low. So in these patients, we recommended routine care per ACOG. And then if the patient was still pregnant and there was still suspicion of preeclampsia or she was being tested for any preeclampsia type labs, we would repeat the SPRIT1 PLGF. And we were not really that much interested in the delta or what happened, but if it was again, just use that number as a kind of the clock starts again and your ratio is negative, or it can become positive, whatever it is, we kind of use the last number on the ratio. But you could repeat the test in 2 weeks. If the ratio was high, we told the patient that you're at high risk for developing preeclampsia with severe features. The PPV, like I said, in the PRACES study was 65. And you're also at increases to have adverse maternal and fetal adverse outcomes besides just the diagnosis of preeclampsia. So in that case, we recommended that we increase maternal and fetal surveillance. And essentially what it was is that here it is, and this is exactly what we were doing. So if it was less than 40, we will discuss the results with the patient. We will just manage them per ACOG. In most of the cases, we'll continue the pregnancy because her risk to have severe disease was low. If the patient, the FDA was very, very clear in saying that you cannot make decisions to discharge and admit the patients entirely based on biomarkers. Obviously, that's foolish because you have to also look, the patient may be in labor, maybe she's having maybe her baby doesn't look good. So all those criteria, your clinical criteria has to be kind of more important in terms of when you're making the decisions to admit and discharge. But essentially, you can just kind of, follow them expectantly, and then you can repeat the test in 2 weeks. And then if the ratio was high, you will discuss the risk with the patient. In these patients, actually, they were all obviously admitted. We continued admission, and I'll show you some examples of some patients who we continued admission and we were like, oh, what's going on? We don't really know. But these patients, we kind of increased the surveillance of their tests. So we continued them to be in the hospital. But even if they left the hospital, we increased the frequency of their blood work. So if they were in the hospital, we were testing them Monday, Wednesday, Friday for the health labs. And then we'll do twice daily NSTs, twice weekly BPPs, and we'll do growth ultrasound every 3 weeks. Sorry, there's a typo here. Here it says, I guess the double star was discharge if clinically indicated. It's a triple star. So we were saying if your ratio is high, we were advocating for growth every 3 weeks, even if the growth was normal, because a lot of patients who have a high ratio actually also have concurrent FGR. And then in these patients, we were recommending betamethasone. A lot of patients do get betamethasone if they get admitted to the hospital less than 34 weeks, but in some patients who were far beyond below 34 weeks, and they didn't get delivered within 2 weeks with a high ratio, we were actually recommending rescue steroids. Because if you look at the data, the proportion of patients who are pregnant 4 weeks after a high ratio is actually very, very small. And then a lot of these patients had severe hypertension, so we were advocating magnesium sulfate for them. And like I said, if a high-risk patient gets delivered, you can always consider them to be followed up with MFM. In our group, we have lots of midwives and lots of generalist doctors who did not want to follow patients who were being managed on biomarkers. So a lot of these patients were actually seen in my clinic with a high biomarker ratio if they got discharged. So again, so the biomarker got approved in May of 2023. In June of 2024, ACOG actually just updated it's called a CPU, it's a clinical practice update. It's not the whole document, but they updated the biomarker, added a section in the diagnosis of preeclampsia, and they said that you can use biomarkers, so biomarker prediction of preeclampsia with severe features. And then they were kind of very careful in saying if you don't have to use it, but if you use it, you should use it for hospitalized patients who are already, so these patients are already admitted to the hospital within a gestational age window of 23 weeks and 35 weeks. They have to be single-term pregnancy. The women have to have some sort of hypertensive disorder pregnancy, so you can't just like start testing asymptomatic patient. And the test is really a complementary risk stratification tool to add to the diagnostic workup. So you can't just only use the test. And they were also, if you read further along, they say that the test should not be used for diagnosis of preeclampsia. So just for risk stratification of patients who are at high risk to have preeclampsia with severe features. So once we used the biomarkers at the University of Chicago, we did evaluation of first few patients. I was just like personally very interested to see how do these tests actually perform in real time. So now that we could order the test, so we have it in our Epic system, you can order a CBC, CMP, and you can check off SRIT1 PLGF, and then you get the results back. And the clinicians are managing, there's a chat thing here. What are they saying? Oh, that was an old chat. Sorry. So the clinicians are getting these results of the biomarker. So we were very interested to see how did the biomarker actually perform. So patient samples were collected as part of routine clinical care. Anybody who got admitted to HDP. This first study the results that I'm going to present here were actually we did not have our own system set up at that time. So this was I used to send these samples overnight to Cedars-Sinai Hospital to be evaluated. It's the same platform. For SPRIT1 PLGF ratio. So the first sample was sent in June of 2023. If you remember, the FDA approved the test in May of 2023. So very quickly, as soon as the FDA approved it, we started using the test here at our institution. And this is the data for about 6 months from June of 2023 to January 2024. And essentially, we had 65 encounters. So encounters are because you can repeat the test. So the encounters are larger number than actual number of patients. And you can see here that there were 65 encounters. 36 of those encounters had a ratio of less than 40. 29 of those encounters had a ratio of higher than 40. Important to point out that it's still it's not 50-50. Slightly over 50% of the people will have a low biomarker. It's always been proven that a large majority of patients will have a low biomarker. So here, if you look at the levels of the biomarker, patients who had a low biomarker had a median value of 4, very, very low, compared to patients who had a high biomarker had a median value of 176, so very, very high. The gestational age of when the sample was drawn at our institution was pretty consistent with how the FDA was saying. So it should be done between 23 weeks and 35 weeks. So the median was 31 weeks. The gestational age of delivery was very remarkably different in patients who had a low ratio, 37 weeks, versus patients who had a high ratio. So what this means is, and I'll show you some examples, what we were doing is if we were confused about a diagnosis or there was a diagnostic conundrum we didn't know and the ratio was low, we are not recommending delivery, for example, in somebody with chronic hypertension, with severe hypertension. We'll say, well, it's probably like worsening chronic hypertension. What we found was that there were only 2 indicated deliveries so far, and I'll tell you who they were. They were just developed headache. You can't really get out of the headache for preeclampsia. Deliveries, anyway, 2 people in this 36 people had a headache and got delivered, while 72% of the people in the high ratio got delivered for some indication for HDP. And then other interesting thing was not that I told people not to give corticosteroids, but in our group, patients who had a low ratio actually got much lower proportion of corticosteroids compared to patients who had a high ratio to 22% compared to 86%. And similarly, magnesium use was much lower in patients who had a low ratio. And then when you looked at adverse outcomes, pretty much what we found was that adverse outcomes were really happening. They were rare. Again, I have to say that these adverse outcomes are not very common, but again, they were most of the time happening in patients who had a high ratio. And then when we looked at some of this, previously we've already documented what is the PPV of NPV of the test. And what we found here was very, very nice that the PPV and NPV was actually even slightly better. The PPV was slightly better than even the PRACES studies of 0.79, and the NPV was really good at 94%. And then we looked at the timing of delivery. It was very similar. 92% of the patients within 2 weeks with a low ratio were undelivered. So large majority of them were still pregnant at the end of 2 weeks, while only 26% of the patients in a high ratio were undelivered. So this was very consistent with previous data. And then we looked at the latency of pregnancy. In patients who had a low ratio, it was 33 days compared to patients with a high ratio was 7 days. What that means is that if you have a low ratio, you are at low risk to have adverse outcomes. You can actually prolong your pregnancy much longer. And while you prolong your pregnancy, it can be safely prolonged because nothing really bad happened to them when they were still pregnant with a low ratio. So I don't know what I'm doing on time, but I'm going to hopefully very, very fast tell you about these two cases, which will, for all of us clinicians, it just kind of brings it home. So these are both my patients. So this lady is a 31-year-old. She's a primate. She has this history of renal transplant several years ago because she developed glomerulonephritis. And then during this pregnancy, she was also on steroids. So she had a kidney transplant done about 3 years ago. And then I take care of a lot of patients who have transplants and patients of chronic hypertension. So she started her care with me. At about 28 weeks, there was like some question. She was always on chronic steroids, but there was some question that there was some rejection. So her creatinine starting to rise. And then they were like, oh, maybe we can give her some more steroids. But at about 30 weeks, she presented to labor and delivery with elevated blood pressures at home. So all our patients who have chronic hypertension or at risk to have preeclampsia, we do home blood pressure monitoring. So then she was ultimately admitted to our antepartum service because we were unclear whether she is developing severe preeclampsia or maybe she's just having steroid-induced changes or she's having worsening chronic hypertension. But it was really interesting that on her admission, her LFTs were elevated. They were 56 and 137, and she also had a high creatinine. So we consulted hepatology, nephrology, and obviously if you don't have the biomarkers, you can just make a diagnosis of preeclampsia because that's what it says. You can develop severe preeclampsia based on diagnosis can be done based on elevated LFTs and transaminitis in the context of hypertension. So our lady has a BMI of 29. Like I said, she has chronic kidney disease. So what I find most usefulness of the biomarkers are really in these patients who have alternate something else going on. So patients who have chronic hypertension, patients who have lupus, patients who have kidney disease. So like I said, she was admitted, her blood pressure was not really high on admission, 146/91. Platelet count was fine, hemoglobin is fine, but then her creatinine is 1.2. Her baseline creatinine was actually quite low. It was like, 0.7, 0.8. And here her AST, LT are also high. So anybody in this world, and then also her PC ratio went up from 0.1 to 1.6. So if you were to really strictly follow the ACAR criteria, you would say that she has hypertension, but now she has new onset proteinuria because her baseline proteinuria is normal. And now she also had elevated creatinine and her AST, LT is high. So she likely has preeclampsia and she could be delivered. She's only 30 weeks. So, but we were, obviously we sent the biomarkers and the biomarker level came back at 3. Obviously very, very low, much lower than your cutoff of 40. So we said, fine. I said, no, she cannot have preeclampsia. This is something else going on. So ultimately what happened was that her transaminitis was ultimately thought to be due to cholestasis. I ended up discharging her home. Her creatinine kind of was the same, 1.1, 1.2. I didn't think it was worsening because of her preeclampsia because her ratio was very low. And then ultimately she got to 35 weeks. And obviously she's at risk for having adverse pregnancy outcome because she has kidney transplant. She had IUGR and then she got delivered at about 35 weeks because she had a very bad bio. Her baby was at the 8th percentile, but essentially the baby stayed in the NICU for about 3-4 hours and then was out of the NICU. So essentially she had a pregnancy prolongation of about 5 weeks based on the biomarkers that we were able to expectantly manage her. This is just one more case. It's the opposite of the case that I showed you. So here is a lady who's 49 years old. She was also my patient. She was a professor actually here at the University of Chicago. She was a G5P0. She had all these first trimester losses and mid-trimester losses, BMI of 30. She presents to my clinic at 24.5 weeks. Her past medical history, she's AMA. She's 49 years old. But she also has some mild chronic hypertension. She has this factor V Leiden deficiency. She was an IVF pregnancy. She had a history of DVT, so she was actually in Lovinax. And then she was kind of a little bit paranoid about her pregnancy. She was continuing to checking her blood pressures at home. And then she said that at home, she had 1 mild range blood pressure. And I was like, okay. And then in clinic, her blood pressure was normal, 132/83. But she has so many risk factors for developing preeclampsia. I said, fine, I'll admit you. So she gets admitted, but on admission, her blood pressure is mild. She has a history of chronic hypertension, 132/92, so nothing to write home about. Platelet count is fine. Hemoglobin is fine. Creatinine is fine. ALT/AST is fine. UPC is negative. So technically, you can just send her home. She has a diagnosis of chronic hypertension, but she has mild hypertension to say the least. She does not require antihypertensive. Her labs are fine. She has no symptoms. She should go home. But before I sent her home, I said, well, let's get you an ultrasound. So she gets an ultrasound. The baby's a little bit small. EFW at the 7th percentile, AC at the 14th percentile. So fine, she's mild FGR. She's 24 weeks. But I also got an S1 PLGF because that's why I admitted her. And her ratio came back at 362. That's a very high ratio. And I was like, okay, something is going to happen to you. Let's just keep you in the hospital. So then she stays in the hospital. We give her betamethasone. She was also FGR. So I gave her betamethasone for more than one reason. We said, you're going to continue admission. We did frequent labs. We did ultrasound for Dopplers. We got her consulted by NICU and she stayed in the hospital. And then 10 days went by with nothing happened. Her blood pressures were mild. Nothing was going on. And then one fine day, I was just going to discharge her. I said, I don't know what's going on. It does have some false positives too. But then on day 10, her blood pressure suddenly became 190, 110. Her AST, ALT went up to 600s. She developed Frank-Halp syndrome. And then also her ultrasound showed independent absent and diastolic flow. The baby looked really bad on the monitor. And then she had a classical C-section for all those indications. The baby was actually born alive and was discharged from NICU after day 133. So such a save, because if I had sent her home, I don't know, maybe she'll come back in with like a really bad baby or even an IUFT. So this is all published. We published this in AJOG, and here the story was that we found a lot of encounters where the SFRT1 PLGF ratio was low. So like the first patient, whether they were either equivocal, clinical, or lab criteria, so headache, transaminitis, worsening hypertension, worsening creatinine, worsening proteinuria, but then they were expectedly managed based on the biomarkers, and none of them developed adverse outcomes within 2 weeks, and none of them developed preeclampsia with severe features, and their pregnancy were prolonged. So very quickly, this is kind of the timeline of how we got here. So this was the first time Dr. Karamanchi published the SFRT1 story in JCI in 2003, and 20 years later, the FDA approved the biomarkers in 2023. We're actually just about ready to do this other study called Bridge, where we are collecting data from across five different sites in the United States, and just like doing a biomarker registry in terms of like the real life data, the real world data. And this is just the biomarker map in the US. Lots of institutions are actually using it, and I give lots of grand rounds around the country to kind of send them out implementation protocols as well. I do work with a very large team. That's Dr. Karmanji, who first found these biomarkers, and all my funding sources. And just a little plug in here is that the ISSHP, which is the International Hypertension meeting, is going to happen in Chicago in September 20 to 24. So please, all of you should make an attempt to come and send you posters and abstracts. And I'm hosting it, so I'll be very, very happy to see some of you guys in person. I think that is my last slide. Thank you very much.
Thank you, Dr. Sosh. On behalf of the audience that is present here, and we have a huge audience online, and of course, this will be played on YouTube in the next few days. So your message is going to reach across a large number of audience. But thank you for that brilliant exposition, and the topic is open for questioning. Any questions from anyone?
Dr. Aishwarya, do you want to ask a question?
But I'm just wondering, so since we don't do as much basic science research as you've done first, but we do have a very rich clinical background. So do you think there's any way that we can collaborate with you to translate this into something that we can do for our community here?
Revati, can you repeat the question? I couldn't hear it correctly.
Dr. Sosh, what Aishwarya is asking you is, in the West, there's a lot of basic science research that's going on as compared to what it is being done here. But we have a lot of clinical work that's going on here. So the whole idea is to integrate basic science, to translate it to clinical implementation and extrapolate it to public health initiatives. So what we are asking you is, there's a wealth of information that's going on there. So can we do more collaborations so that we can probably test it out clinically and make the best use of whatever's being researched on the basic science to the public health communities?
Yes, that is a great suggestion. I would be happy to talk more later. Yeah, absolutely. I think I personally feel is that biomarkers actually have much more relevance in developing countries where you really have to be sure, more than your blood pressures or more than your labs. And I published several papers. In fact, we looked at the association of biomarkers with labs, other labs. And turns out if you have a low S1 PLGF ratio, you are at low risk to have DIC, low risk to have, any of these HELP syndrome. So essentially you can maybe check lab once and you don't have to like keep repeating this a whole cadre of labs over and over again. So I feel like definitely there is and then I feel like the NICU is so critical in developing countries more than here, just to make sure that the right baby goes to the NICU at the right time. I think that itself to me is like transferring the patients up and down, higher up if your risk ratio is high, and kind of stay in a local hospital if your ratio is low. I think to me that just like such a great use of the test.
Thank you so much, Dr. Sosh. And hope you've given us that valuable time in the middle of the night, and sorry for all the Thank you.
Dr. Sarosh, if you could stay back, would like you to stay back for inauguration and book release, if possible.
Fine.
And
I'll stay back. Okay.
Sure. Please do try if you could.
we have 5 countries collaborating, 18 chapters,
We have
18 sections.
people from across 5 countries joining for that, and we would definitely like you to have here. I mean,
It's in 30 minutes, right?
Yes.
Yeah, another half an
Yeah.
hour now.
Yeah. Okay.
Thank you.
After that wonderful session by Dr. Professor Sosh Rana, we move on to our next session, which is by Dr. Paul Gibson. He's the Associate Professor of Medicine, University of Calgary, Canada. He's also the current Secretary, ISOM, and he has numerous awards and accolades into his name. So we welcome you, sir, and over to his talk on pregnancy-associated myocardial infarction. Over to you, sir.
Yeah, I hope you guys can hear me. I'm seeing the slides on my own screen, so hopefully you see them as well.
Yes,
So,
sir.
You're absolutely clear, no issue.
okay, so good morning, everyone. Of course, it's late evening here. It's an honor and privilege to be addressing this important Congress from halfway around the world. Thank you very much to the organizers for extending the invitation and including me. I truly hope that you, the audience, find this meeting to be highly educational and that it meets all your expectations. Just a very brief little bit about me. So I'm a Canadian obstetric medicine physician and internal medicine physician, and I'm currently the secretary of the International Society of Obstetric Medicine. I trained in another Canadian city and province in Winnipeg, and then did my obstetric medicine fellowship in Providence, Rhode Island, USA back about 20 years ago. I currently work at the Foothills Medical Center in Calgary, Canada. I do work in general internal medicine and obstetric medicine. And I perform medical consultation in pregnancy for conditions including hypertension, venous thromboembolism, cardiac disease, and many others. One disclaimer, I am not a cardiologist, I'm an internist, so I don't work in the CCU, although I do see patients there, and I do not cath anyone. So some of the things I'll be talking about are things that I see and hear about and read about that don't necessarily do myself, but I wanted to include them. I do participate in research in obstetric medicine, including cardiac disease, thrombosis, hypertension, and medical education. I'll be sharing a little bit of my original research today. And I have also been a contributor to the biannual cardiac problems in pregnancy meetings since back in 2012. So I've got that perspective to bring forward as well. So I'll start with a case to sort of set the table. So this case is a 35-year-old woman, a real patient who I saw a number of years ago. She's in her first pregnancy at 22 weeks gestation and was transferred to my site from a rural emergency room where she had presented with persistent chest pain. She had a past history of chronic hypertension, hypothyroidism, some mood disturbances, and mild asthma. She was a smoker, half pack per day, and had a concerning family history of her father having had a myocardial infarction at a young age, at age 40. She was taking a calcium channel blocker, some thyroid hormone replacement, and some psychotropic meds, as well as Ventolin as needed for her asthma. When I saw her, she had been complaining of several hours of retrosternal squeezing chest pain with radiation to the left arm and back, and she was feeling diaphoretic and nauseous. Blood pressure was stable, but she was breathing quickly at 24, a bit tachycardic with equal pulses in both arms. Saturations were 95% on room air. She had normal heart sounds, clear lungs, no calf swelling or tenderness, and the fetal heart rate was normal at 145 beats per minute. This was her ECG, and we won't belabor it other than to say it's quite abnormal. There's no discrete major ST elevation, but there's minor ST elevation in the anterior leads, some reduction in the anterior forces, and some lateral T-wave inversions. Quite an abnormal looking ECG for a healthy young woman. Her electrolytes and creatinine were normal by SI units. Her coagulation parameters were normal, and her D-dimer was negative. And she had a clear chest X-ray, including no widening of the mediastinum. But her high sensitivity troponin T was markedly elevated at 425, with normal being less than 5. So questions that you might be asking yourself if you saw this patient are, what is the most likely cause of her chest pain? What are the causes of elevated troponin in pregnancy? Which investigations to pursue cardiac ischemia are safe to pursue? Can she and should she have a coronary angiogram? And if necessary, would stenting be an option, or coronary interventions? Which medications are recommended and which ones are to be avoided? What do we need to do for her ongoing antepartum and peripartum management? And lastly, what about future pregnancies? So there's a number of sources of guidance here, and people can look these up afterwards. There's the Canadian Cardiovascular Society guidelines, there's the AHA, the ACC, and American College of Obstetrics and Gynecology, and these guidelines, I think, are generalizable on an international basis. But first, why is this a topic of importance? And the reason why is because cardiovascular disease is a prominent cause of maternal mortality. In the best data from Canada, diseases of the circulatory system were the leading cause of maternal mortality in Canada. In the most recent data from the UK, cardiac disease was tied for the leading cause of maternal mortality in the UK. And so it's evident that cardiac disease is a leading cause of maternal mortality. What about on a worldwide basis? Well, indirect causes have gained predominance, and indirect causes increased significantly up until 2014, and subsequently due to a reduction in direct causes of maternal mortality on a worldwide basis. About 15% of maternal deaths on a worldwide basis were due to pre-existing medical conditions, including cardiovascular disease. So it's apparent that cardiac disease is an important and increasing global cause of maternal morbidity and mortality. In terms of low and middle income countries, this report is published in 2020, looking at maternal mortality due to cardiac disease. And the authors report that there is a substantial incidence of maternal deaths due to cardiac disease in low and middle income countries, that cardiac maternal mortality rate is highest in countries with a higher maternal mortality rate, but it becomes proportionally greater in countries with lower maternal mortality rates. So it sort of rises to the top in countries that have got a bit better handle on things like hemorrhage and hypertension and that sort of thing. Cardiac disease has been rising as a cause of maternal mortality around the world. Where does India fall? This is a map of global cardiac maternal mortality rate, and you can see yourself right there, and not the highest, but not the lowest. And so I'll present a little bit of data to suggest it is an issue in India as well. This is an article from 2016 from the Cardiovascular Journal of Africa that talks about the maternal mortality ratio in low and middle income countries is 14 times higher than in high income countries. That's no surprise. That direct causes of maternal death remain the largest cause of maternal death in low and middle income countries, but cardiovascular disease is also an important contributor to maternal mortality in both the developing and the developed world. And they specifically comment in this article that in India, cardiac causes were responsible for about 10% of maternal deaths that underwent a pathologic biopsy at a tertiary healthcare center. So something that is important for all of us. Looking at what part does ischemic heart disease, so that's total maternal mortality due to cardiac disease. This is data from the UK up till 2020, and showing that ischemic deaths were the second most common subcategory of cardiac causes of death after myocardial disease. So things like cardiomyopathy, including peripartum cardiomyopathy. And the authors comment that ischemic heart disease is often overlooked as a diagnosis in the maternity population. and there needs to be a high index of suspicion in order to promptly detect and effectively institute treatments for this population. So, MI is more common in pregnancy. Why? Well, I'm going to talk a little bit about the hemodynamic and hemostatic changes that occur in normal pregnancy, which might unmask coronary artery disease. I always say pregnancy is a marathon followed by a sprint, so increased cardiac work and exercise throughout pregnancy, and the sprint is labor and delivery in the immediate postpartum period. Coronary artery disease might be more likely to become manifest by the increased heart rate and myocardial contractility, which leads to increased oxygen demand, along with higher lipid levels physiologically in pregnancy, and the hypercoagulability that's intrinsic to the pregnant state. Spontaneous coronary artery disease, you'll see in a minute, is a very common cause of pregnancy-associated MI, and it's presumed to be triggered by hormone-related changes to the arterial media, as well as the shearing forces that are increased in pregnancy. Coronary thrombosis and embolism can be contributed to by hypercoagulability, as well as the use of hemostatic agents for bleeding. Coronary spasm can occur spontaneously or association with vasoconstrictor medications for peripartum bleeding, or in the situation of preeclampsia, which is a vasoactive state. And demand ischemia can occur in the setting of obstetric catastrophes, such as anemia, bleeding, or severe illness in pregnancy. Now, in the general population, the mechanism of myocardial infarction, the vast majority, 90% of the time, is obstructive coronary artery disease. But in women, it's more commonly presents with non-ST elevation MIs and non-obstructive coronary artery disease, which is referred to as MINOCA or SCAD. Myocardial infarction in the absence of coronary artery disease can be related to vasospasm, coronary embolism, or thrombosis. Sometimes SCAD is not does not lead to severe narrowing of the blood vessels. There can be supply-demand mismatch, plaque disruption, and coronary microvascular disease. So that's women in general. What about pregnancy? And I'll talk briefly about SCAD. So SCAD stands for spontaneous coronary artery dissection. It has a prevalence of about 4% of all myocardial infarctions, but it is the underlying cause in up to 1/3 of all ACS cases in women under 50. Patients with SCADs have lower rates of traditional cardiovascular risk factors and are more likely to have hormonal fluctuations and other conditions. So what do we know about pregnancy-associated myocardial infarction? The starting point would be with retrospective data from case series. One of the most commonly referenced ones is by El-Kayam et al. And published back in 2014 in Circulation. It provides a comprehensive description of risk factors, mechanisms, and treatments received by pregnant women with MI. But because they're non-consecutive patients, there is some issue of selection and publication bias in the data. Nonetheless, it is a useful starting point. They found in this study that about half of the pregnancy-associated MIs occurred postpartum, with the rest spread across the trimesters of pregnancy, and that the most common mechanisms of pregnancy-associated MI were coronary dissection and coronary artery disease, which together made up 70%, with smaller amounts for coronary thrombosis, spasm, and other causes. I participated in a research project looking at the larger database-derived studies, which provide information on the epidemiology of pregnancy-associated MI. I had the privilege of presenting it at the WHO, and we ended up publishing it along with the World Health Organization Maternal Morbidity Working Group back in 2016. And it was a systematic review of pregnancy-associated myocardial infarctions. What did we find in this study? We were again looking at large database studies, is that the incidence was about 4 per 100,000 pregnancies. That the incidence was increasing over the last 30 years, that there was a fairly equal distribution of the events between the antepartum, peripartum, and postpartum periods. But because the peripartum and postpartum periods are much shorter, it confers a higher day-to-day risk of MI in the peripartum and postpartum periods. That the incidence of maternal mortality was about 0.2 per 100,000 pregnancies, conferring a case fatality rate of about 5%. The limitations on this data is the lack of sensitivity for missed cases because it's corporate data. It doesn't provide the same level of detail on the characteristics, risk factors. And very importantly, especially to you, is that the data was all from developed countries, and there was no data from low and middle income countries at all that was available for inclusion in the systematic review. So difficult to know whether to generalize. I'm not going to fix that problem with my next couple of slides, but this was another project that we just published, a population-based study of pregnancy-associated MI in my home province of Alberta. So we did a consecutive case series over 15 years of a large population of 4 million people identified by corporate data and review of maternal mortality cases and linkage to a provincial angiography database. This led to a robust data collection over 17 years. Cases were validated by original record review, and we were able to get detailed information on testing, treatment, and outcomes collected in this population. So we found 43 cases of pregnancy-associated MI over 17 years, giving an incidence of 5.6 per 100,000, slightly higher than the systematic review of corporate data provided. That the rates of pregnancy-associated MI in our population increased over the period of study, and the maternal mortality rate was higher than was predicted by the corporate data at about 9%. We found, very similar to the case control data, that the predominance of MIs, about half of them were postpartum, and the rest were spread over the peripartum and antepartum period. But the most common cause of pregnancy-associated MI overall was spontaneous coronary artery dissection, followed by unmasking of underlying coronary artery disease, followed by demand ischemia, and some women had normal coronary arteries, which could have represented in situ thrombosis or spasm or demand. And overall, 60% of our pregnancy-associated MIs were caused by either spontaneous coronary artery dissection or unmasking of latent coronary artery disease. Interestingly, we were able to break it down by timing in pregnancy and found that there was some heterogeneity there. In the antepartum period, the 7 MIs that we had during the antepartum state, the most common cause was underlying coronary artery disease, speaking to the demand state of the increased myocardial oxygen consumption in pregnancy, and some of them had normal coronaries. For the peripartum events, so the MIs that occurred during labor and delivery, demand was the most common mechanism, and this included things like prolonged peripartum hypotension from regional anesthesia, severe maternal illness due to things like HELP, DIC, pulmonary edema, severe anemia from massive peripartum hemorrhage, and other causes. And interestingly, and again concordant with the retrospective data, is that postpartum, the most common cause was spontaneous coronary artery dissection, representing 75% of the MIs in that period. So that tells you about the mechanism of MI and the timing of it in pregnancy. What about risk factors for pregnancy-associated MI? Who do we need to worry about? Well, there's a long list, and I'm just going to touch on a few of them. Maternal age over 35 and multiparity are common risk factors for pregnancy-associated MI, along with the traditional risk factors for coronary artery disease, personal or family history, as in this patient, pre-existing hypertension, dyslipidemia, diabetes, and past or current smokers. Pregnancy complications, including hypertensive disorders of pregnancy and severe bleeding complications, can be associated with pregnancy-associated MI, as well as patients with a history of heart disease, including valve repairs, atrial fibrillation, underlying thrombophilias, or ongoing substance use. So those are all things that would make us more alert and more aware. That said, we need to maintain a high index of suspicion in all patients. Not everyone's going to have these preconception or early pregnancy red flags, and they may just present with acute chest pain or even atypical chest pain, along with new ischemic ECG changes and elevated biomarkers. So again, you need to maintain a high index of suspicion in order to make this diagnosis and not assume that chest discomfort in pregnancy is a benign etiology. EKG changes that would be abnormal during pregnancy include any ST elevation, ST depressions that are persistent or occur in the setting of chest pain, or T-wave inversions that are widespread. And what about the biomarkers? So there was a study looking at troponin levels in normal pregnancy, published in JAMA Cardiology in 2023, and they found that high sensitivity troponin levels were comparable among pregnant and non-pregnant women, and they did not have elevated levels compared with non-pregnant women before or after adjustment. In other words, pregnancy alone does not result in significant changes in the troponin level. What about in preeclampsia? There was a systematic review that looked at this and found that troponin I levels were higher, slightly higher in women with preeclampsia than in those with an uncomplicated pregnancy, but the elevations were very modest. And so major or significant elevations are very likely to be of significance in patients presenting with chest pain. There is a chairman of the American College of Cardiology advanced expert panel that made some adjudication on this, and they said if there's pre-existing or suspected cardiovascular disease, the biomarkers, the troponins and BNP retain their negative predictive value. Elevated natriuretic peptides and protein and troponins may occur in the immediate postpartum period, but again, modest elevations. But clear elevations in the setting of clinical suspicion should prompt further investigation into possible cardiac pathology. In other words, these tests are valid for use in pregnant patients. That said, you have to keep in mind the other possibilities. Again, they're sensitive but not specific markers for myocardial infarction and may be elevated in the setting of myocarditis, including peripartum cardiomyopathy, the setting of sustained arrhythmias, pulmonary embolism, sepsis, renal failure, and even in the setting of COVID-19 infection. So in terms of having an approach to the possibility of an ACS in pregnancy, in the setting of either ST or non-ST elevation MI, the recommendation is to consider proceeding to coronary angiography relatively promptly, the urgency depending on the severity of the presentation. So what about coronary angiography in pregnancy? Concerns regarding this test include the fact that it will involve some fetal radiation exposure and the possibility of procedural complications. However, it facilitates treatment which is tailored to the mechanism and gives the option of immediate stabilization and revascularization. In terms of the technique, there's a preference, if possible, to access the central vessels via the upper extremity through a radial approach, to use low pressure injection so as not to propagate dissection if that's what's the mechanism, and ideally to use limited guide wire manipulation. Again, this is outside my expertise. What about estimated fetal radiation exposure from angiography? Well, coronary angiography up to 50 milligrams is considered acceptable with minimal increased risk of either malformations or childhood malignancy in pregnancy. And coronary angiography confers much less than that. Fluoroscopy past the groin, if you're only able to access the vessels from the lower extremities, it can add up. And so that's why upper extremity access is preferred when possible. But percutaneous coronary intervention, including placement of stents when that's appropriate, generally offers less than 1 milligram of fetal radiation exposure. So again, up to 50 milligrams or 5 rads or less confers a negligible risk of spontaneous risk among non-exposed women, and an angiography with PTCA procedure confers about 2% of that limit. So it's a very acceptable level of radiation exposure in selected patients. However, additional investigations to consider would include echocardiography, which can identify LV dysfunction and regional wall motion abnormalities with no radiation exposure. Stress echo is an excellent test and an alternative to nuclear cardiology if patients are presenting with suspected coronary artery disease, perhaps not an acute myocardial infarction, and we'd be looking for inducible regional wall motion abnormalities in that case. A CT of the chest or a transesophageal echo should be pursued if there's a clinical suspicion on the basis of the presentation for aortic dissection. And CT coronary angiography is an alternative, non-invasive assessment of the coronary arteries. It offers a similar fetal radiation dose, which is still acceptable to angiography, but it does confer the possibility of inconclusive findings and doesn't offer an option for therapeutic intervention. So it can be, when for instance, coronary artery dissection is suspected, it can confirm that diagnosis when the treatment is generally non-invasive. Speaking to that, specifically the management of spontaneous coronary artery dissection, conservative medical management is generally recommended in this state because of the friability of the underlying vessels. And again, this tends to present peripartum and in the postpartum period. The radial force is generated by balloon inflation or stent expansion in the setting of spontaneous coronary dissection may broaden the dissection and result in procedural failure. And it's generally recommended that percutaneous coronary intervention should only be performed in the setting of a left main dissection if the patient is very hemodynamically unstable, having failure of conservative management, or having ongoing ischemia. And in preference to that, conservative management with antiplatelet therapies and beta blockers is the preferred option for the stable patients who are experiencing spontaneous coronary artery dissection. Now, what about medications? So this is from the Canadian guidelines from 2021, and I've selected, this is for cardiac disease in general, and I've picked the ones that are most applicable to coronary ischemia. So beta blockers are perfectly appropriate and acceptable and are used for other indications in pregnancy with the small chance of fetal growth restriction and neonatal bradycardia or hypoglycemia. Metoprolol is the preferred agent where I work. And certainly aspirin and low molecular weight or unfractionated heparin are appropriate agents for use in the setting of coronary ischemia. Hydralazine and nitrates can be used for patients with reduced LV function or hypertension and can be an alternative to things like ACE inhibitors and ARBs that you might use outside of pregnancy. And among the other dual antiplatelet therapies, clopidogrel is the one with the best pregnancy safety data for use in the ongoing pregnant woman and during lactation. Thrombolytics, including TPA, are listed here, and those would be used very selectively. They do not traverse the placenta and don't cause fetal bleeding complications, but they can cause obstetric site or placental implantation site bleeding and abruption, and would only be used as a rescue when coronary angiography and primary coronary intervention was not available. Drugs that we generally avoid in pregnancy, anything but most extreme situations would be amiodarone, ACE inhibitors, ARBs. There's very little data on SGLT2 inhibitors, and I can't foresee very many situations where that would be helpful. Aldosterone antagonists generally they have potential for androgenization of the fetus, and there's few indications for that in use in pregnancy. And direct oral anticoagulants cross the placenta, and their safety is definitely suspect. And similarly, in breastfeeding, we avoid use of most ARBs. There are some ACE inhibitors which can be used safely in lactation. SGLT2 inhibitors haven't been studied in that situation, and direct oral anticoagulants are generally discouraged as well because unless the woman elects to forego lactation. Statins are another point for discussion. They're generally discouraged for use in pregnancy and lactation, but the observational data regarding their safety is actually pretty reassuring. And we've had the odd patient who had out of control familial hyperlipidemia, where we did use statins to control the levels of that for various indications in pregnancy. What about surgical revascularization? Well, not a robust literature, but there are scattered case reports and case series talking about coronary artery bypass grafting. The risk of maternal mortality is generally about 2% and maybe higher than that in an emergent setting. The risk of fetal loss is substantial, up to a 1 in 3 risk of fetal loss, and that may be mitigated or improved upon by techniques around the time of revascularization, including using warm cardioplegia, minimizing on-pump times and using higher flow rates. And in some cases, there's an option for a mini thoracotomy and doing the coronary bypass without cardioplegia, which is likely to reduce the risk of fetal damage and loss in this situation. I can't speak to that because, again, that's not something that I participate in directly. Overall, surgical revascularization is largely reserved for double and triple vessel disease, dissection of the left anterior descending or the left main, or in the setting of complications or failed percutaneous coronary interventions. In terms of moving to delivery after an antepartum MI, it's preferred, if possible, and of course this is not always going to be possible, to delay the delivery for at least 2 weeks to give the heart a little bit of time for recovery, similar to how you would delay elective or semi-elective surgery after an MI. The mode of delivery should generally be by obstetric indications, and the individual should have an interpartum plan that's individualized to their care. In general, it's recommended to continue aspirin and beta blockers throughout the peripartum interval. If they're on dual antiplatelet therapy, it would be ideal to hold the clopidogrel for 5 to 7 days to reduce the risk of bleeding. Continuous cardiac monitoring is a good idea where it's available, particularly in patients who have had any dysrhythmias. And cardiac anesthesia refers to early regional anesthesia with careful implementation in hemodynamics to reduce the cardiovascular stress, that sprint to the finish at the end of pregnancy, and thereby reduce the amount of cardiac stress. The second stage of labor could be assisted or extended if the patient is stable to reduce the amount of stress at that point in time. And it's generally recommended to avoid ergots and prefer the use of things like oxytocin, carboprostol, or misoprostol to control peripartum blood loss when excessive. And the patients ideally would recover in a monitored unit if that is available. And what about future pregnancy in women who've had a previous coronary artery disease or a previous MI. The CARPREG 2 score is the most contemporary clinical prediction rule, which is used to estimate risk. And according to this rule, patients with a prior cardiac event with established coronary artery disease would gain at least 5 points. And if they have reduced ventricular dysfunction, they're going to have even more. And so their estimated risk of a cardiac complication in pregnancy is going to be in that 50% range. So these patients are all high risk and all merit close monitoring in subsequent pregnancy. The data regarding prognosis in subsequent pregnancy after MI is limited. There was a meta-analysis published in the BMJ in 2019 that shows only 21% of women have an uncomplicated pregnancy. Much of the complication relates to their underlying comorbidities. Obstetric complications occurred in 58%. Fetal and neonatal complications occurred in 42% in this systematic review. But a primary ischemic endpoint only occurred in 9%. So it depends on your perspective. That's pretty high, but it's not as high as the risk of obstetric complications in general. They didn't comment that women with underlying atherosclerosis as the mechanism of their previous MI had more cardiovascular complications, and there was 2% maternal mortality rate, which again, most of us would agree is high risk. In terms of pregnancy after spontaneous coronary artery dissection, there was a concern about the high rate of recurrence. This study, published in JAMA Network, looked at 23 women with 32 pregnancies after spontaneous coronary artery dissection, and similarly found a 9% rate of recurrence SCAD related to pregnancy. They did find that most women tolerated pregnancy without complications after SCAD, and that it wasn't the pregnancy so much as the women who've had previous spontaneous coronary dissection have a high recurrence rate in general. So what should we do to plan for future pregnancy after women have experienced a pregnancy-associated MI? Well, first of all, preconception counseling is strongly preferred, recommended, but not always possible because women return in the pregnant state without having received this. What's recommended is an assessment of their risk factors, especially looking for modifiable ones, a review of their ECG and echocardiographic findings, and optimization of their cardiac risk factors prior to pregnancy, as well as an assessment of residual ischemic disease if possible, and a management plan for pregnancy, which most often will include aspirin and beta blockers. And it's recommended that all future pregnancies should be followed by a high-risk cardio obstetric pregnancy team where that is available. And at a minimum, they should have regular obstetric and internal medicine or cardiology reviews during that subsequent pregnancy. So I'm going to summarize the take-home points is that cardiovascular disease is a leading cause of maternal mortality. Pregnancy-associated myocardial infarction is an important and increasing mechanism of cardiac morbidity and mortality in pregnancy. Pregnancy is associated with a 3 to 5 times increased risk in the probability of MI, and the mechanism of pregnancy-associated MI appears to be variable by timing in pregnancy. Spontaneous coronary artery disease spontaneous coronary artery dissection is the most common cause overall and predominates postpartum. Underlying coronary artery disease and unmasking by the hemodynamic stresses of pregnancy remains a common mechanism, but you also have to think about demand ischemia in the setting of bleeding or severe maternal illness, spasm, particularly in the setting of preeclampsia, coronary thrombosis and embolism are also possibilities. Diagnosis starts with clinical suspicion and should be followed by completion of an ECG, measurement of biomarkers, and in most cases, pursuit of coronary angiography. The treatment for coronary artery disease in pregnancy is adapted for pregnancy and includes coronary assessment, revascularization where appropriate, and specific medical therapy. And of course, there's a substantial risk of recurrent morbidity and even mortality in subsequent pregnancy, and these patients need very close monitoring throughout. The last thing I wanted to bring up was some interesting reading I had when I tried to customize this talk to the audience. There was an article in the Indian Heart Journal called Bridging Gaps, the Urgent Call for Cardio Obstetrics as a Subspecialty in India, and this is from 2024. The authors comment that cardiovascular disease during pregnancy is the leading cause of maternal mortality in developed nations, and the trend is expected soon in India with the ongoing obstetric transition. They comment, this isn't my words, they comment that India lacks robust data, risk stratification tools, management guidelines, and a well-defined cardio-obstetric team concept. Note that a recent analysis of maternal deaths in Sri Lanka identified 18% of maternal deaths were attributable to heart disease, and that there is therefore a present need to establish national registries, develop risk stratification tools, develop and disseminate management guidelines, and create dedicated cardio-obstetric programs. I'm certainly not telling you what you need or what you should do, but this would be something that we would want to support. And they talk about a stepwise approach to developing cardio-obstetrics in India. Speaking on behalf of the ISOM, we'd be very supportive of what we can do to support these developments if deemed appropriate for your population. So with that, I'm going to thank you for your time and attention. I will stop sharing my slides, and I'm happy to take a few questions if there's any time left for that.
Thank you, Dr. Paul. It was a wonderful exposition of the MI during and after pregnancy. I would just like to ask you about a case. This was a 32-year-old gravida 2, no risk factors, no family history, underwent a cesarean section for obstetric indication. 4 hours later, she complained of chest pain. The ECG showed ischemic changes, and even before we got the drop eye results, she collapsed and died. Is there any way this kind of a death can be avoided?
That's very difficult. Avoiding, recognizing it and responding as quickly as they can is the best you can do. The most likely mechanism in that situation would be spontaneous coronary artery dissection. It really depends on your local resources, but there is lots of reports of maternal mortality related to delays in considering the diagnosis, appropriate investigation, and treatment. But we can't prevent them all. So I would have a strong suspicion for spontaneous coronary artery dissection, and there's only so much you can do.
The next question is, why does ischemic changes occur more rapidly in the postpartum period? Generally, it happens within 24 to 48 hours, not a prolonged time. Is there any particular reason why this happens?
I'm sorry, I'm having a hard time hearing. I'm hearing talking over your voice.
We thought that the postpartum ischemia is more common in the postpartum period. Most of the ischemic disorders occur in the postpartum period.
It's very curious that spontaneous coronary artery dissection occurs more commonly in the postpartum period, but we think it's related to a combination of the hemodynamics of pregnancy, including the stress of labor and delivery, as well as the hormonal changes that are affecting the media of the blood vessels. It's, in my mind, it's the similar mechanism to why aortic dissection is more common in pregnancy. There's a softening or a weakening of the media of the arteries, including the coronary arteries, along with the increased shearing forces, and those shearing forces reach a peak during the increased cardiac output associated with the labor and delivery process. That said, spontaneous coronary artery dissection has been described up to 3 months and even 6 months postpartum. So those structural changes seem to persist for some period of time postpartum.
Thank you. And the last question, there was a patient who was gravida 3, a bad diabetic, gravida 3, at 34 weeks, she needed to undergo open heart surgery for MI. And we were a little bit in a dilemma whether I need to do a cesarean section at that particular time or wait for her to recover and do it at term. Ultimately, I chose to do a C-section at 34 weeks along with the open heart surgery. What would be your opinion of that? Do we wait or do we do the surgery at the same time?
So again, I'm an internist, not an obstetrician, so I tread very lightly about telling obstetric care providers when to deliver anyone. That said, I think that makes good sense. And assuming you've got neonatal care that can handle a 34-week delivery and that sort of thing, if you have the resource to that, I think it makes good sense to do a staged procedure or even a combined procedure, just because being non-pregnant will actually, assuming the patient is stable, being non-pregnant will reduce the hemodynamic burden during the period of recovery post-surgery.
Yeah, thank you. Because one more question. Okay.
Yeah, that was a lovely talk. I would like to ask you whether doing a echogram or a stress echogram for women with a past history of preeclampsia with IVF pregnancy or age more than 35 years would help.
Sorry, I didn't quite hear a question there. I heard a woman over 35 with past history of preeclampsia getting a stress echo. Is that what I heard?
An echogram or a stress echogram in pregnancy, in early pregnancy, in people who have risk factors for panic?
Okay, I'm sorry, it's a bit murky, but a stress echo can be used as a prognostic factor after women with peripartum cardiomyopathy as well. And like I said, would be an excellent provocative test to look for inducible ischemia in women who have a history of ischemic heart disease to assess latent burden of ischemia, and women who are having current symptoms. I'm sorry I couldn't hear the other question.
What about prophylactic aspirin?
Prophylactic aspirin?
Yes.
Okay, so definitely, again, the mainstay of treatment for women with a history of ischemic heart disease of almost any sort would be low dose aspirin and beta blockers to mitigate the cardiovascular response to pregnancy. It would certainly be protective and obviously would confer some benefit in terms of preeclampsia risk reduction as well.
Paul, please join us for the inauguration and the book release. Incidentally, for the audience, Dr. Paul Gibson has given a foreword for our book, and we'll be definitely pleased to have you with us during the book release.
Hello,
Okay.
Dr. This is Dr. Revati, and thank you so much for making it happen. And we are just hoping that we will further collaborations with the International Society of Obstetric Medicine, and thank you so much for giving us your time. So with this, we would actually move on to the next most important event, which is the inauguration. Thank you.
ಲೈಟ್ ಲ್ಯಾಂಪಿಂಗ್ ಇದೆ ಜೂಮ್ ಓಪನ್ ಸ್ಕ್ರೀನ್ ಶೇರ್ ಮಾಡಬೇಕು ಜೂಮ್ ಓಪನ್
Good morning to one and all, and welcome. As we gather here at this maternal fetal medicine conference, we stand at the crossroads of science and life itself, honoring the miracle of creation, the resilience of mothers, and the tireless pursuit of knowledge that helps us safeguard the tiniest of hearts before they even take their first breath. So to begin with the invocation and the life sighting, I kindly invite our dignitaries to come forward, please. Dr. Pushpa Srinivas, we are deeply honored to welcome Dr. Pushpa, a towering figure in obstetrics and gynecology and former professor and HOD at Bowring and Lady Curzon Hospital, Bangalore. Dr. Kasturi Donimat, former president of Kasoga and ex-professor and HOD at KMCRI Hooghly. She is currently director of Takadarsha Hospital in Hooghly. They are both accompanied respectively by Dr. Prakash Mehta, president of the SMFMI, Dr. Revati Rajan, secretary of the SMFMI, and Dr. Smita, treasurer of the SMFMI. It's an honor to have you all here today. We will now begin by invoking the blessings of the Lord Almighty with a small Navakar mantra by Dr. Akshita Sheth.
नमो हरिहन्तारं नमो सिद्धारं नमो आयर्यानं नमो वज्रायानं नमो लोये सर्वसाहूनं येसो पञ्चनमोकारो सर्वपावपणासनं मङ्गलालं च सर्वेसिं परमं हवै मङ्गलम्.
On that spiritual note, we will have an invocation song by Aprameya Govindarajan to seek divine grace as I invite the dignitaries to please proceed to light the lamp. Aprameya is the son of Dr. Revati Rajan, who, as you will be hearing, has a wonderful voice.
Saraswati Namostute Jayadeve Jayavare Saraswati Namostute Jayadeve Jayavare Saraswati Namostute Jayadeve
What a melodious and uplifting start to the day. I now invite Dr. Prakash K. Mehta, President of the SMFMI, the brain and the backbone of our society, to deliver the presidential address.
Good morning to you all. I need another mic. Shivamastu sarva jagataha parahita nirata bhavantu bhutaganaha dosha prayantu nasham sarvatra sukha bhavatu lokaha. This Sanskrit shloka means that may the whole cosmos be blessed, may all beings engage in each other's well-being, may all the weakness, sickness, and fault diminish and vanish. May everyone and everywhere be healthy, prosperous, blissful, and peaceful. It is with immense honor and gratitude that I stand before you today as the President of the Society for Maternal Fetal Medicine of India. At this remarkable gathering, we have online, on-site, on YouTube. We have people across the world watching us today as we are going through this program for this annual conference of the SMFMI. I stand here today filled with pride and deep gratitude to be a part of the community that continues to shape the future of maternal and fetal care with unwavering commitment, compassion, and courage. First and foremost, I extend a warm welcome to all our distinguished guests, speakers, panelists, delegates who have joined us from across the country and around the globe. Your presence here is a testament to the shared passion, dedication, and vision that defines our community, that the community of the maternal fetal medicine specialists across India and the world. Now, coming to the Society for Maternal Fetal Medicine, we are a baby society. We were officially registered for the first time on the 14th March of 2016. That means we are about 8 years old today, or 9 years old. Now, we started with only 10 members. We were actually 9 at that time. There were 9 maternal fetal medicine specialists. And then we pulled in Dr. Jyotika as the 10th member because the registrar of societies needed a minimum of 10 numbers to register our society. So that's how she came in. Now, I'm proud to say that in these 10 years, we have now more than 500 members all across India. We also managed to hold the first international conference of hypertension. This came to India or even to the Asia for the first time online, because it had never come to Asia before. And this was done in 2023, where of course most of you were present. We have conducted very successful PENI programs, both online and offline. In these few years, we have to manage to certify 1,000 gynecologists across India. And we continue with our tri-monthly VLSP program that delves into the deeper aspects of preeclampsia. We go into the aspects of renal disorder, hepatic disorder, which causes preeclampsia. We have moved all over India to ignite academic passion and better care for our mothers. And we brought out a comprehensive book on the hypertensive disorders of the pregnancy, which was an international collaboration, which is going to be released today in front of this august audience. For the first time, we have a named oration, Srimati Mayabai Kantilal Mehta Oration, and which will be held for the first time today. And we have also brought in Suraksha PE, a program for the support of the patients, which also will be unveiled today. And we have a lot of patient education and programs in that. We also have Guidance SMFMI, a program that helps obstetricians across the country and in all the developing countries. If they have any doubt, they contact us for any clarifications required or any support required. Our journey has not been simple. We have had many challenges. Some were expected, many were unforeseen. Yet we met with resilience, innovation, and unwavering commitment. As a society, we have succeeded thanks to the spirit of collaboration that binds the SMFMI. And SMFMI has always been partial to young doctors. We have gone out of our way to ensure that the youngsters take part in these programs. The youngsters are given a stage to talk about, and the youngsters are initiated into research. And to cap it all, my entire team of committee members comprises of very young members who have been my students once upon a time. And starting from Dr. Revati Rajan, our secretary, to whom I drive at least 8 hours a day to work for the society. And she has been doing that more than a year for me now. Our special faculty, we have Dr. Smita, we have Dr. Srimati, we have the youngsters like Akshita, Aishwarya, and of course, a whole lot of our other team members. Unfortunately, if I take the name, it keeps on going for a long time, but that includes all our team members and also our branch at Mysore, where we have Dr. Sushma as president. Dr. Sushma, could you get up, please? So that was the first branch we started, and we always have a special love and affection for the very first branch that we have had. Okay, now this conference is more than just a series of sessions and presentations. It is a celebration of knowledge. We went out of the way to ensure that we bring it out as a celebration of knowledge, a platform for exchange and a crucible for new ideas. You just now saw one of our younger members asking Dr. Sosh that you would like to do research and how could we collaborate. That was what exactly we are looking for. In our society, the seasoned professionals and the young minds come together to learn, grow, and chart the path forward to transform patient care across our nation and the world. We are soon going over into the various other countries, including Africa, Afghanistan, Pakistan, Bangladesh. We already have had few PNI certifications from Afghanistan and Pakistan, and Bangladesh, of course, and Nepal. But we are soon moving over into Africa and next on into the South America. Those are the areas where we are going to concentrate to spread the PNI. Now, as we look forward, our mission remains very clear: to foster excellence, encourage inclusivity, and drive meaningful exchange within our field. Let us use this opportunity not only to reflect on our achievements. No, achievements are great, but we are not going to reflect on it, but also to reignite our collective purpose. Let this conference serve as a reminder that while technologies and treatments evolve, humanity must remain the center of it all. I would like once more, I would like to thank my dynamic secretary, Dr. Revati Rajan, the entire organizing committee, my young set of volunteers here who have been working tirelessly from the last 3 days, one day before the conference and the current 2 days. They're all my international medical student undergraduates. They have been working very hard. The sponsors who have been very kind to us, without much ado, they supported our program, and that is why we could get in youngsters at a very nominal fee of 500 rupees. The management of the Bhagwan Mahavir Jain Hospital, which supported us in a very big way, and every individual whose tireless efforts have made this conference possible. Your dedication, all of you, is truly commendable. Thank you once again, and thank you for being with us.
Great, exciting talk by our president. We will now move on to the most important part of today's meet. So this is nothing but the much awaited book release. When great minds converge, their collective wisdom writes a legacy which goes on to inspire the coming generations. So this book is an attempt to inspire the coming medical generations to be aware of preeclampsia, and it is definitely an enigma which has been unraveled. So this book consists of 80 chapters with 15 sections, both from Indian and global authors. So our Indian editors are Dr. Prakash Mehta, our president, and Dr. Revati Rajan, our secretary. And our global editors are Dr. Kenneth Shen, who is the past ISO president. And he's also the clinical lead at for endocrinology at Harvard Medical School. And last but not the least is Dr. Munishwaran Ganeshan. He is also the founder of Society of Maternal Medicine in Malaysia and current president of Maternal Fetal Medicine in Malaysia. Yes. I now call upon Dr. Pushpa Srinivas for the book launch.
Tanya ma'am.
Make an essay.
No, we shouldn't move it. We'll move back. We'll not move it. We'll go on that. Yeah, we'll go on this.
No, Biomarkers will start in the front also.
No, we'll come again on this.
I think,
Asha. Yeah, we'll read the.
And then Dr. Kenneth and Dr. Manish will be recording on a live. Then we take the picture. Thank you. Thank you. These people want to. I now request Dr. Revati to pass on a special message by Dr. Anne Marie. She is the current president of ISSHP. So over to Dr. Revati. I think it was a very emotional moment for all of us. It's been almost 2 years of conceptualization, hard work, editing, collaboration, and a lot of learning. So I would want to read the special message from Dr. Anne-Marie Hennessy, who is the current president of ISHEL. I'm reading it as is, quote, "This is the first time to my knowledge that a prestigious and scholarly report
has been published after the International Society for the Study of Hypertension in Pregnancy Congress. Over the last 40 years, the ISHIP has brought together clinicians and researchers from over 60 countries to share and investigate preeclampsia and the other hypertension diseases in pregnancy. We have seen great contributions to the definitions of disease, the options for treatment, and the discovery that preeclampsia does not just end with the delivery, but causes potentially long-term cardiovascular effects. Our teams have monitored the outcomes for our babies and our families all around the world. I recommend this book to clinicians, scientists, and students to see the breadth of effort and rigorous standard to which the field of pregnancy medicine research is being undertaken. Thank you to all of the contributing authors for their efforts for this tome and for the women and their families. Professor Anne-Marie Hennessy, President of ISHIP, Deputy Executive Dean, Westmead, University of Sydney, Faculty of Medicine and Health, Westmead Innovation Center, Sydney. Thank you so much, Dr. Anne-Marie Hennessy, for this lovely message. I'm sure we are all really emotional at this point, and we hope that this book has a far-reaching impact with more than 150 authors from 5 different countries, 80 chapters, 16 sections, even a separate section with patient representatives contributing a chapter. We have a chapter from the Preeclampsia Foundation as well. So we are just hoping that this textbook reaches its far-reaching intent across India and beyond. Thank you so much. Yes. I also see that we have our editors, Dr. Kenneth Chen and Dr. Munishwaran, who have joined this link. So I invite Dr. Kenneth Chen, if he is there, to say a line from your end. He's now talking to you all from Boston. Thank you so much, Dr. Kenneth, for taking your time in the midnight. And I know it's been a lot of collaboration over the past 2 years. So we invite you to say a few words.
Yeah, thank you very much. It was a wonderful opportunity to, participate in co-editing this wonderful textbook with all of you. And, I'm very pleased that it has been completed. And thank you very much for all of your collaboration. Thank you.
So he's the chief of endocrinology, clinical endocrinology at Harvard Medical School and our international advisor. We also invite Dr. Munishwaran Ganeshan, who has been the founder of the Society of Obstetric Medicine for Malaysia, who is also one of the global co-editors. Dr. Munishwaran, a line from your end, please.
Thank you so much, Dr. Revedi. I would like to sincerely thank the hard work from the Society of Maternal Fetal Medicine, Dr. Prakash K. Mehta, Dr. Revedi, Dr. Kenneth Chen. It's been a truly honorable pleasure. And I think this book is a labor of hard work, passion, and dedication. I'm sure this will make a significant impact. Congratulations, and thank you for all of you.
Dr. Paul, who is the founder of the Society of Obstetric Medicine from Canada. Dr. Paul, can we have you say a line, please? He's actually been generous to give us a wonderful and an impactful foreword. Dr. Paul, are you there?
I'm still here. Yeah, I'm just getting late. I just want to say congratulations to everybody. It's a great collaboration and brings forward some real life experiences from around the world. So well done.
Dr. Sosh, are you still there? Dr. Sosh? Yeah. Is Dr. Sosh there? No. Okay.
No, ma'am.
Okay. Dr. E. Ping has joined us from UK, and she's done some work. She's done some original work on placental-derived growth factor. Dr. E. Ping Teo from UK. Are you there?
Yes, I am. Hello, hi. It's good morning from UK, and I'm looking forward to reviewing the book and also looking forward to the afternoon talk later on PLGF. Thank you.
Thank you so much. Thank you all. And we move on to the next part of the inauguration.
Yeah, thank you all the authors, all the editors for bringing out the wonderful book. Please let us have a big clap for everyone. Thank you. Okay, Madam Pushpa Srinivas, one would like to say a few words.
Believe me or not, I was in tears for that little boy who came to our institute, BMC, has become so much like, international fame and proud of it. And one friend will never want, and I'm sure mother is always blessing him wherever she is. I am not a mother, but also called as guru, which also mentions that they learn from their teacher also after the mother. So I must congratulate you, and for anything, it is not only one person can do. You require to have a good team, and to have a good team, the leader should be knowing how to make the good team. And for that, we require youngsters. So younger energy, enthusiastic people wanting to come ahead in their life requires an experienced person, Prakash or anybody like that, to have a combination of that. And it's not only that, I think the Asha might have sacrificed quite a lot by being in special courageous leader, passionate doctor, and always being more interested. Of course, his another passion is to have a good food because Asha cooks good food also. So, but I'm very, very, very happy, and it has touched my heart. And I'm grateful to you and your team for having made me to come and inaugurate this session, Dr. And thank you so much for you made a day for me, and I'm very, very proud. I can say beyond that, I have no words because my eyes are flowing, tears are flowing from.
Thank you, ma'am, for this very kind words.
Yes. Now moving on to the next launch. We're not done with our series of launches. So the launch of PLGF point of care test. May I request Mr. SM Rafi, Country Director, Mr. Devashish Chaudhary, Marketing Head, Mr. Tarun Tripathi, the Business Unit Head, and Dr. Shika Malhotra, who is the Marketing Manager, as well as Mrs. Ajita, Director, Marketing, JASPAC. We request you all to come on stage, please.
So I really want to take this opportunity to thank you, to say thank you to the Society for Maternal Fetal and Medicine India, especially to Dr. Prakash and Dr. Revati and each and every team member here for giving us this opportunity to share a life-saving test, and that to one point of care, which will, I think, it will help us to take it to far corners where the need of the test is to deal with preeclamptic cases and to save both mother and child. And we have a stall outside to demonstrate and to take care of any questions that you have for point of care. And we are excited that this is the forum which is so, I think, rich in clinical experience and has the capacity to really best utilize this test, and open to any questions after the launch, and share your experiences. And thank you so much again. And thank you, ma'am. And thank you, sir.
Thank you, Dr. Shika. Now let's proceed with the unveiling. Can we have Ms. Adita to speak a few words, please?
Thanks everyone for being here for this launch. It's the right opportunity for us to bring to you all a test which is really going to help save both the mother and the child, as Dr. Shika mentioned. So we, on behalf of Fetal, are happy to be launching this test in India, which is called the Triage PLGF Point of Care Test, which will allow earlier and quick diagnosis of preeclampsia. We'll have a session by Dr. Teo from UK, who will talk a bit about her experience of using this test in the market and how it has been adding clinical value to managing preeclampsia patients maternally. So thanks, and look forward to your support in making this test available to more and more patients and saving lives for both the mother and the child. Thanks.
Test is something that was absolutely essential in management of preeclampsia. We have got all kinds of tests. Some are very good, some are excellent, some are okay. But no test is good enough unless you get the result in your hand in time. And most of the preeclampsia, the complicated preeclampsias that tend to come only on Friday afternoon or a Saturday morning. Where even if I have the best of the tests in my hand, I'm not going to get the result till Monday evening. My patient is going to be absolutely fine by then or dead and gone in those next 3 days. So point of care test is something that we require. The patient comes to me, I do the point of care test, and I get my result. I know what to do with my patient. So that is the importance of point of care. In Society for Fetal Medicine India, we generally do not allow product or product launches. But we made an exception this time because this is a life-saving test which could help all our obstetricians and all our women across everywhere, so that the moment you get the result, you know whether you need to take action or not. Do you deliver a preterm or do you wait and still deliver a further? So that is the importance of the point of care test, and I'm sure the test will help us in saving many, many, many mothers. Thank you for bringing this test. I've been waiting for such a test for many years. Of course, PLGF was there for 5 years back. We have had a hesitation here done, but after that, some of the test disappeared from the market and we are back with it. I'm glad about it. Thank you.
And just to round it up, we have used PLGF before, and this was way back in 2012 when we used PLGF as a POC on the Allier platform. So I have conducted a study where we looked at 300 plus pregnant women who were high risk, not necessarily hypertensive, between 18 and 24 weeks of pregnancy. And what we actually found was women, this is just a summary, women who had a value of less than 12 could be upgraded to a tertiary facility because they all ended up into an Angiogenic or an emergency delivery because of worsening endothelial dysfunction. So by making a diagnosis of less than 12, we were able to put them in tertiary care and make sure that they did not throw a fit or the baby did not die. And extending beyond that, people who had a value of between 12 and 100 were subjected to higher level of surveillance. So instead of having a problem within a week or two, we were able to prolong their pregnancies for about 4 to 5 weeks and got a viability gestation. So we were able to save the mothers and the babies. And this made a huge difference because maybe many of these elderly mothers had just one last time to have their babies. So beyond 100, it is safe. We also have gestational age-based cutoffs. So what we humbly urge is make use of these preventive and predictive strategies to make a difference to these pregnant women who definitely need heightened service and channelized resources for those who actually need them the most. I'm sure this is going to make a huge difference if we're going to have a point of care test in a country like ours, both from the rural as well as the urban perspective. Thank you so much. Dear Dr. for actually facilitating this, and thank you, sir, for actually being a strong sense of support for both academic research and all the innovative technologies that we want to implement in the community.
Thank you.
Thank you, everyone. Now, moving on to the next segment, I now request Dr. Revdi, our secretary, to go ahead with the legacy of Penai and Suraksha B. I would like to call upon the chairpersons. Yeah.
Oration chairpersons.
Yeah. Dr. Asha D. Nervi, Dr. Prakash Mehta, sir. We would want to back on the stage Dr. Pushpa Srinivas, ma'am. Dr. Sadhana Gupta.
I'm so glad on this Sunday during the SMFY annual meeting, we are again talking about preeclampsia education in a very big way. We are so glad to say that our flagship project, Preeclampsia Education of the Nation, India, which actually started off way back in 2021, has now touched 1,000 registrations. We have certified more than 680 obstetrician gynecologists from across the country for preeclampsia management based on the latest evidence-based research and guidelines. So I take this 5 minutes to tell you about how we evolved. We had the Penai start off as the online series during May of 2021. So we have the global co-chair, Dr. Sosh, Rana, who collaborated with us along with Prakash Mehta sir as well as myself to actually set up this project with the entire team of the SMFMI. This was actually followed by a series of programs like the virtual learning series on preeclampsia, which actually happened every 6 to 8 weeks to add on to the existing knowledge of preeclampsia, to give us updates on preeclampsia. Then came the iShip World Congress as an extension. So we were able to host this Congress in the Indian Institute of Science, Bengaluru, where we had about 400 delegates from across the world, from 20 countries participating. It was the first time that India and Asia was hosting this Congress physically. The next important milestone was that we went across the country at the state level. We went to Tamil Nadu Federation of Obstetrics and Gynecology, had the biggest state level Penai certification course, which was a huge success. We had about 150 obstetrician gynecologists who were actually participating in that. And then we went to several places. We have several Penai nodal leaders like Dr. Asha Nervi, and there are many who actually, and Dr. Sadhana Gupta, who actually got us to their places like Hubli and Madurai and Gorakhpur, where we actually certified these clinicians for preeclampsia education. And it was at Gorakhpur, which was held recently in February, that we touched the 1,000 mark. We also had several webinar versions. Recently, we had a program for South Zone in December, where we certified about 200 clinicians from across South India. We plan to do it across the country. And this is the first ever course which aims at certifying clinicians for preeclampsia management in the world, which has been endorsed by the International Society of Study of Hypertension in Pregnancy. We're so glad that we also had the workshop in the World Congress, which kind of recruited clinicians from countries like Bangladesh. We had some attendees from UK as well. So now PEN is going global. There have been requests from countries like Kazakhstan and some African countries, and we also plan to explore South America to take this formal preeclampsia education course across these places to make sure that the clinicians are empowered to make sure that they make a difference to the mothers and the babies. It is not just enough that we actually empower the clinicians. It is very, very important that we educate the patients as well. And that's how we started what is called the Suraksha PE program for all of those who are joining us from abroad. Suraksha means keeping somebody secure. So we're trying to protect our pregnant women through these initiatives. So we have the first video for patient education as part of today's inauguration. I invite Dr. Aishwarya Karthik, who's been one of the leads of the Suraksha PE program, to actually play the video. In fact, the book has also been an extension of preeclampsia education. This is for the clinicians and the doctors. And now what we are concentrating is for our patients. So Dr. Aishwarya, can you please play the video? So you want to say something? Yeah.
Before Aishwarya starts, I should say when we made this video and the future videos that are going to come in, we have made a very clear-cut decision because we would like this video to be played in everybody's outpatient. So we have made sure that no name, no person is ever seen in the video because obviously if one particular obstetrician is seen in another obstetrician's office, it doesn't go well. So no faces will be shown, no names will be taken. It's a pure educational initiative, which could be played in anybody's office without, any worry, I should say. Yes, Aishwarya. Aishwarya is very, very young doctor who has, I think Dr. Kasturi is very much student. And she has taken a lead in the Suraksha program, and this is the first video she's bringing out. So anybody's comments, we welcome it. Mostly send us an email or on phone, so that the next video that we make will be even better. to help the patient to do a home blood pressure monitoring, which I'm sure all of you will agree that home blood pressure monitoring is going to be the future. They have to monitor BPM at home. So this was meant for that. And as I said, we welcome any comments. This is the first of our video that is coming out today. Welcome any comments, any suggestions towards this improvement. Like this, we are going to bring out the whole series. We are going to bring out the whole series, including investigations that they need to do, care they need to take, and their diet and everything else. So please send in your comments.
In SMFMI, where we would reach out for collaborations and research associations from each one of you or your organizations. So this is guidance SMFMI, and any kind of a clinical situation which you want clarity on, apart from the emergency situations, we are ready to answer you through the society. So this is e-support SMFMI, and here we are looking forward to answer all your queries, whether clinical or research-based or collaborative. We are also looking forward to collaborate national and international authorities onto these research projects. We urge you all to reach out to Guidance SMFMI. Thank you. And now we move on to the much coveted session of the day, which is the oration. Before I proceed, I would want to call upon stage Mrs. Neena Rohit Gupta. Mehta, sorry. So sorry. Mrs. Neena Rohit Mehta. I'd like to introduce the chairpersons. Dr. Pushkar Srivas Madam, we're deeply honored to welcome you. She is a towering figure in OBGYN and former professor and head of department at Bowling and Lady Curzon Hospital. A celebrated teacher, past president of BSOG, she's received multiple lifetime achievement awards and accolades for her outstanding leadership and dedication to medical education. Her enduring impact on the field is evident in the many honors bestowed upon her, including the prestigious Kamalanjali Award and BSOG Best Teacher Award. Thank you, Madam, for gracing us with your presence today. Dr. Sadhana Gupta, Madam, is a leading figure in OBGYN, currently serving as ICOG Vice Chair-elect 2025. She is Director and Senior Consultant at Jeevan Jyoti Multi-Speciality Hospital and Research Center, and has held prestigious roles, including President of North India Gynae Forum and Gorakhpur Chapter of ISOPAB. With over 20 original publications, e-textbook authorships, multiple national awards, including the Dr. D.C. Datta Prize and Foxy Honors, she is widely respected for her work in academic and social health. We are truly privileged to have her with us today. Dr. Asha Miravi Madam, it's a pleasure to welcome Madam, a stalwart in field of OBGYN with over 25 years of dedicated teaching experience. She currently serves as Professor and Unit Chief at SDM Medical College in Dharwad, Karnataka. A respected academic professor, she has contributed to both national and international journals and continues to guide postgraduates and fellowship trainees in minimally invasive surgery. Thank you, Madam, for being with us today and enriching this forum with your presence. Also welcome Dr. Prakash K. Mehta and Dr. Devati. We welcome Srimati Mayabai Kantilal Mehta's elder daughter-in-law and Prakash Mehta's sister-in-law, Ms. Neena Rohit Mehta. We request, sir, to speak a few words.
Thank you, Akshita, for that. Now, our society needed an oration. Although I was the president, it didn't mean that I decided that this was the oration. I put it before the committee members, saying that since my mother is an eclampsia survivor and we are highly interested in pre-eclampsia, if they would all agree, we would start an oration in my mother's name. And thanks to all of my committee members, they all accepted. And today we have the first oration. I'm very proud to say that the very first oration is given by Dr. Kenneth Shen from Harvard. He's the Chief of Clinical Endocrinology at Harvard, Boston, and he's giving the first oration. Thank you, Dr. Kenichi, for accepting to give this oration. And with this, we go further with the procedures.
Thank you, sir. Today, I feel honored to speak about one of the most precious gifts in our lives, mother. A mother is not just a word, she's a feeling, a shelter, and strength. Her love is pure patience and selfless. Behind every strong person is a mother who never gave up. And we all know who this strong person is, Dr. Prakash Mehta, sir. So, a few words about the mother. A mother par excellence and an eclampsia survivor, like mentioned by Sir right now, in an era where maternal mortality due to eclampsia was more than 80%. An astute, intelligent, rational, and uncomplaining lady, born in 1923 in a village in an era where date of birth was neither considered important nor recorded. And sadly, she expired in 1986 at the age of 63. So, a symbol of resilience, in 1952, she developed eclampsia and was on the verge of deathbed. World War II had recently ended and morphine was just introduced. As a last resort, she was given morphine to control convulsions. Miraculously, both the mother and baby survived. She went on to have one more pregnancy, the birth of Dr. Prakash K. Mehta. Maybe the reason why Dr. Mehta is highly interested in preeclampsia, making all her efforts to save the mothers. She was God-fearing, generous lady. No one went from the house without being served food. Although she was only third standard pass, encouraged a daughter and son to become obstetricians and took keen interest in their studies, ensuring that they become good service-minded doctors, serving women folk without consideration of creed, caste, or cash. She was thoughtful and went out all the way to help poor people. She uncompromisingly stood for righteousness and ensured women's rights in her own small way. If one were to describe her in three words, they would be empathetic, indomitable, and dauntless. I feel privileged to launch this oration, and she exemplifies the statement that sometimes the strength of the motherhood is greater than natural loss. I now request Dr. Kenneth Shen to go ahead with the oration, which is on historical evolution and future directions of obstetric medicine as a specialty. Before that, Dr. Revati would be introducing our orator.
It's this great privilege, tears are again rolling out of my eyes, to introduce Professor Dr. Kenneth Chen, who's been our international advisor. Dr. Kenneth Chen was born in Hong Kong, China, and moved to Sydney, Australia with his parents at a very young age. He studied medicine at the University of Sydney and on graduation was conflicted into choosing a residency in internal medicine versus obstetrics and gynecology. He ultimately completed a residency in internal medicine and subsequently subspecialized in endocrinology as he really enjoyed caring for the large number of pregnant women whom he encountered with diabetes or other endocrine disorders. This led him to pursuing and completing a fellowship in obstetric medicine at Brown University, United States, where he gained a lot of clinical and research experience in preeclampsia. Upon completing this fellowship, he returned to Sydney to be a dual specialist in endocrinology and obstetric medicine at the University of New South Wales. He returned to Brown University in 2012 to become the Division Director of Obstetric Medicine and the Co-Director of the Integrated Program of High-Risk Pregnancy at the Women and Infants Hospital of Rhode Island, where almost 10,000 deliveries occur each year. He set up the first multidisciplinary clinic in North America to care for pregnant women who are morbidly obese, BMI of more than 40. He became heavily involved with the International Society of Obstetric Medicine, or the ISOM, and ultimately served as the president between 2018 to 2024. He became an international advisor to the Society for Maternal Fetal Medicine India in early 2017. And just as this esteemed group was being formed, in fact, he launched us internationally during the ISOM meet at South Africa. He became the president of the medical staff as well as the associate chief of medicine at Women and Infants Hospital in late 2022. In early 2024, he moved to Harvard Medical School, Boston, to become the clinical chief of endocrinology, diabetes, and metabolism at the Beth Israel Deaconess Medical Center. He also visits the Joslin Diabetes Center on a regular basis and continues to be heavily involved with ISOM as the immediate past president, and is also been the co-editor, the global editor of our prestigious book, Preeclampsia, an Enigma Unraveled, from the global perspective. Thank you so much. And with this, I request Professor Dr. Kenneth Chen to be rendering this prestigious oration. Thank you, sir.
Thank you very much for your kind introduction. It's a great honor and privilege for me to deliver this oration, and I will just bring up my slides. Okay, I just want to make sure that everybody can see my slides and you can all hear me, right? Yeah, can I just get confirmation everybody can hear me and see my slides okay?
Yes, sir, we can see and hear you.
Okay, all right. I'm going to proceed. Okay. Well, thank you all very much once again for this kind invitation. And like I said, it's a great honor and privilege for me to deliver this oration. I want to first of all begin by paying tribute and giving a lot of credit to where I'd worked for 12 years prior to my moving up to Harvard at the beginning of last year. I did my fellowship in obstetric medicine here, and then I also subsequently spent 12 years working at the Women and Infants Hospital of Rhode Island, where about 10,000 deliveries are performed each year. And it is part of the CWISH network, which is the Council of Women and Infant Specialty Hospitals in USA. So this network contains 14 maternity hospitals with a total delivery volume per year of almost 150,000. And it was a great privilege for me to have worked here, because it is here at this hospital that I gained a lot of understanding and experience, in learning and dealing with the multiple medical disorders in pregnancy that we encounter each day. And as part of this oration, I wanted to reflect upon, obstetric medicine. I want to pay tribute to all the people who had set up obstetric medicine before me. I want to talk a little bit about the current status of obstetric medicine, and then actually spend some time towards the end talking about the future directions of obstetric medicine. And so obstetric medicine, in my mind, stands for the interdisciplinary care of medical illness and pregnancy. And it's the focus is on optimizing maternal health in the context of pregnancy. And it basically stretches all the way back to effective preconception counseling, the investigation and treatment of various medical illnesses in pregnancy, and the research and training in this field. As has already been introduced, I was very privileged to have been involved with the International Society of Obstetric Medicine dating back to 2008 when I entered this field. I want to just highlight that the missions of ISOM is twofold: is to foster the growth and networking of like-minded clinicians and researchers in maternal morbidity and mortality in order to generate study questions and gather data across different countries and continents. And so it was really pleasing for me to have helped, launch SMFM India all the way back in 2017, in March 2017, with at our meeting in Cape Town. And as an organization, we're always looking for new partners and regional organizations around the world to join in and collaborate with us. And then the second mission is really to use the above, like using the growth and networking to collaborate on authoring guidelines and how to improve maternal care and reduce morbidity and mortality in both the developed and the developing world. So again, I want to pay tribute to the training that I received at Brown. I did an obstetric medicine fellowship, which was first established in 1992, and it continues to be a 2-year fellowship for board-certified internists, and it's based at Brown University and Women and Infants Hospital, Rhode Island. And again, it was here that I personally gained a lot of experience in this field, and I'm aware of a number of other programs internationally that provide this training, and it is our hope that more and more such programs will continue to be developed and nourished internationally. So why go into obstetric medicine? So more and more women are having their pregnancy complicated by medical illness due to a number of factors, including delayed childbearing. And even though there is now improved medical care, there are more women who traditionally may not have gone pregnant that are now getting pregnant, and we need the expertise in obstetric medicine to care for them. So as an example, it is not uncommon for us to see women with, lupus, epilepsy, and various other conditions now get pregnant, and we have to maintain a good level of medical care for these women and their children. There's also now improved reproductive technologies, so a lot of women historically who may not have been able to conceive are now able to conceive, and quite frequently they are at risk of having concurrent medical disorders as well. So I want to go back to data that dates back to the early 1950s through the UK maternal mortality data that shows that at that time, a little bit less than 50% of complications were related to medical causes, okay, like relating to maternal mortality. As you can see there, purple part reflect hemorrhage, sepsis is yellow, and green is medical. So at that time in the early 1950s, a little bit less than 50% are deemed to be medical. Now, fast forward to almost 50 years later in 2000, a little bit now over 75% of maternal mortality is related to medical causes. And this coincides with, of course, an improvement in management of hemorrhage and various other conditions. So, now the proportion has significantly increased by just under 50% to over 75% in a little bit over 50 years. And then I also want to kind of highlight, the theme of the 4th trimester. We often forget about women in the postpartum period because, like once they deliver the baby, we feel like the job is done. But again, we need specialists in maternal and obstetric medicine to think about and care for women in this kind of period, in the 4th trimester, because there are a number of changes that occur after birth. And, and basically, one of the key things that we have to talk about and discuss with patients are the transition and progression of chronic illnesses that can occur in the postpartum period as they move into the future. And of course, there's a lot of other things that we have to talk to them about, including breastfeeding and mental health. But the 4th trimester, is now very much a keystone in the management of women in pregnancy, that we must also always remember to care for them, in the immediate postpartum period and further on. And then, of course, there has been a lot of emerging data over the last 20 to 30 years that pregnancy itself is very much a window to lifelong health. And in the US, only just over 50% of women see the primary care physician during the first year after birth. And, again, because of that paucity of women who seek medical care, I view it that it is quite important for those of us who specialize in obstetric medicine to provide care for these women in that postpartum period, to make sure that they're getting the adequate care that they should receive, to minimize any medical complications in the future. It's well documented that 24 to 40% of women with preeclampsia develop chronic hypertension within the first year after birth. And again, if we're not following these women carefully, we're not going to recognize this, and these women will be at significant risk of getting cardiovascular disease in the future. 22% of women, so just a bit over 1 in 5 women with gestational diabetes, have persistent glucose intolerance at 12 weeks postpartum. And a number of these, you know, and out of the 22%, the majority of these women actually have pre-diabetes, impaired glucose tolerance, but 4.5% of women in total by 12 weeks postpartum are deemed to have type 2 diabetes. And again, that is why it is vitally important for us to keep these women on our radar. So I've talked about already that maternal mortality, the major causes are postpartum hemorrhage, hypertensive disorders, and venous thromboembolism. In various developed countries, there is still a large disparity of care, you know, with different ethnicities. And in the US, currently, the Black women are 3 times more likely than white women you know, to experience maternal mortality. And a number of studies collectively have shown that up to 60% of pregnancy-related deaths are preventable. And so, again, you know, we want to highlight the importance of obstetric medicine in, you know, in using our expertise to prevent and minimize these pregnancy-related deaths. And in terms of pregnancy-related deaths, the timing is such that, you know, about a third occur during pregnancy, a third occur within the first week of delivery, and then the last third actually occurred between 1 week and 1 year of delivery. So again, in that context, because such a high number of this mortality occur postpartum, it is vital that we, again, as in our specialty, we, you know, highlight this risk to women and serve as a bridge of care for these women until they can safely return to their primary care physicians. So I'm going to now talk a bit about preeclampsia as being the prototypical condition in obstetric medicine. And I felt that this was very timely because of the release of the book and, you know, and all the work that I personally have been doing with the SMFM India organization over the past, you know, 8 or 9 years. So I want to spend a little bit of time talking about, you know, discussing preeclampsia as being the prototypical condition in obstetric medicine. So the history of eclampsia and preeclampsia dates back almost 300 years to a French physician by the name of Bossier de Sauvage, who actually was probably the first person to use the term eclampsia, differentiating from epilepsy. And, you know, and then subsequently, you know, the physician de Manet recognized extreme swelling that occur in eclamptic women. And in 1840, about 100 years after the condition was first, you know, described, Pierre Reye described proteinuria, you know, in eclamptic patients. Subsequently, a couple of physicians demonstrated that the proteinuria accompanying eclampsia was specific to that disease and not part of a generalized disorder. And in the mid-1800s, various hallmark prodromal symptoms, including headache, vision changes, and abdominal pain and edema, were contributed to the recognition that there was a preeclamptic state. And then almost at the turn of the 19th to the 20th century was basically when the mercury manometer was introduced to measure blood pressure, which led to recognizing that preeclampsia was a hypertensive disorder. So in the ancient times, again, you know, the records show that, you know, for these women who might have had, you know, a preeclampsia/eclampsia, that bloodletting was a form of treatment. And essentially, you know, if I could just move along, like, you know, in the late 1800s to the early 1900s, it was recognized that, one of the ways to treat preeclampsia was to deliver the baby somewhat more quickly. And in the 1920s, after the First World War, magnesium was shown to have been useful in improving the morbidity and mortalities of these women with preeclampsia. And Dr. Leon Chesley, who lived to the age of 92, is considered the modern day father of preeclampsia research, owing primarily to his extensive renal function studies and prospective follow-up of patients, hundreds of patients with eclampsia for quite a large number of years. And essentially, the body of this work led to the recognition of various maternal and fetal risk factors for preeclampsia. So I've listed the maternal risk factors on the left and the fetal risk factors on the right. And, all of us are very familiar with all of these risk factors. And again, like a number of studies, large studies over the years have shown, us also what are specifically the risk factors which create the highest risks for patients who get preeclampsia. And I've shown them here that probably the most major ones are people, of course, who've had prior preeclampsia, people who've had chronic hypertension, pregestational diabetes, for those with multiple gestations, and pre-pregnancy BMI of more than 30, and antiphospholipid antibody syndrome. That having these are termed as the risk factors of the highest risk of developing preeclampsia. And then of course there's a lot of other ones as well, including chronic kidney disease and lupus. But it's now recognized that these are the major ones for sure. So in terms of the causation of preeclampsia, like again, over the years, with the body of work that's been done progressively, it was found that preeclampsia basically is a two-stage process where at the very beginning of pregnancy, there's almost abnormal presentation causing placental ischemia, which, may not necessarily occur very early on, but will eventually develop throughout the course of pregnancy. And then as this process develops, that there is then subsequent endothelial damage that occur due to the release of anti-angiogenic factors. And then these two factors in combination then lead to the clinical syndrome of preeclampsia. And so this, Karamanchi, who all of us in the audience would be very familiar with, actually did his work at the current place where I work, which is the Beth Israel Deaconess Medical Center in Boston. And in 2003, him and his group published a number of papers which showed that basically, various anti-angiogenic and pro-angiogenic factors, the imbalance lead to endothelial dysfunction. And these factors here all play a role, okay? SFLT1, VEGF, platelet growth factor, and soluble endoglin. And he published a landmark paper in 2003 in the New England Journal of Medicine that demonstrated that excess SFLT1 decreases the availability of VEGF and PLGF, which basically, was shown to be significantly relevant in the development of preeclampsia. And so this diagram just kind of, basically summarizes all of the interactions that, basically, the imbalance of some of these pro-angiogenic and antigenic factors, contribute to, significant endothelial and vascular dysfunction that lead to preeclampsia. Okay, so what about the prevention of preeclampsia? So again, once people worked out what were the risk factors and causation of preeclampsia, then people became very interested in working out how to try to prevent it. And of course, we know that aspirin has been a mainstay of the prevention of preeclampsia for many, many years. And essentially, there was a Cochrane database meta-analysis that was published in 2007 that showed that, low-dose aspirin significantly reduced the risk of preeclampsia, preterm delivery, fetal neonatal death, and small for gestational age babies. But interestingly, it did not actually have any effect on the rate of placental abruption, cesarean section, or induction of labor. And this was, and all this data was pulled in 59 randomized control trials in more than 37,000 women. So the CLASP study that was basically, published in 1994, again, was a multi-center study, which is a large randomized control trial looking at almost 10,000 women. And it demonstrated that the women who randomized to low-dose aspirin, had a 12% reduction in preeclampsia, but there was no significant effect on IUGR, neonatal death, placental hemorrhage, and it certainly did not cause any adverse neonatal outcomes. So I want to digress briefly to talk a bit about, some work that my previous hospital actually and myself, we still collaborate on this. We're trying to develop, here in the US, and the program is called a Step Up program, which stands for Screening, Treatment, Early Prevention, and Understanding Preeclampsia. And it was basically a statewide effort in Rhode Island to reduce the incidence of preterm delivery due to preeclampsia. And the main drivers were the statewide effort was to use improved screening and more appropriate aspirin prophylaxis to reduce the incidence of preeclampsia. So basically, in the US, it was documented that between 1987 to 2004, so really barely about 17 years, the rate of preeclampsia has actually increased by 25%. And specifically at the hospital where I worked previously, again, the rates of preterm preeclampsia had been increasing, like 16% in 2016 to a little bit over 20% in just over a 2-year period in 2018. And remember what I said at the beginning, that, our hospital looked after almost 10,000 deliveries a year. So this kind of increase in percent actually, leads to quite a significant increase in number of patients with preeclampsia. And so, what myself and my collaborators were, trying to do was to standardize the use of the ACOG and SMFM screen to use the same, basically try to screen women at high risk early and to identify the high and moderate risk pregnancies. And what we were thinking is that, by the way, there was a paper published a couple of weeks ago called the Aspero paper, a study that showed that double dose aspirin, like 162 milligrams daily, actually significantly reduced the risk of preeclampsia in women deemed to be high risk. Again, what we were trying to do was to try to screen these women early and then basically recommend them going on a high dose of aspirin to see if this would reduce the risk of them getting preeclampsia at the end of the pregnancy. There was a lot of work that we had to do to try to, get the general OBGYNs to buy into doing this. I guess, frankly, checking these women early, and what again, as I've highlighted, we recommended that, we wanted to try to stratify these women early on as to being high risk, moderate risk, or low risk. That if they're high risk, we certainly want to use double dose aspirin. If they had moderate risk, that they would use at least just the regular low dose aspirin, which is 81 milligrams. And if they were deemed to be low risk, then they don't actually need the low dose aspirin. And I've listed all the risk factors under high, moderate, and low risk on the left-hand side, okay? And specifically, as I said, the high risk were the people who've had a history of previous preeclampsia, especially when accompanied by adverse outcome. The women had multifetal gestation, chronic hypertension, type 1 or type 2 diabetes, chronic renal disease, and autoimmune disease such as SLE and antiphospholipid antibody syndrome. Before the Aspero study that was published a couple of weeks ago, the ASPRI trial published by Ronick et al. In New England Journal 2017 basically showed that, in this multi-center randomized double-blind placebo-controlled trial, that the 26,000 women, were screened for preterm preeclampsia at 11 to 14 weeks. And, and again, the women who were on 150 milligrams of aspirin until 36 weeks had a 60% reduction in preeclampsia before 37 weeks and 82% reduction in preeclampsia before 34 weeks, and there were no difference in adverse events at all. So this was the first study that showed that using the double dose aspirin, created a better outcome. Now that being said, in order for the positive effects of this aspirin use to come into fruition, the women have to be adherent to aspirin. And so as part of these studies, just as an aside, there were some there was a test that were done on these women throughout the study to ensure that they were taking the aspirin. So, when I was working in Rhode Island, we actually managed to get funding, for the PAI test, the platelet aggregation test to be done in the lab to ensure that the women were actually, if they were to demonstrate a positive effect, that they were actually taking the aspirin throughout the study. So as I was moving to my current job, we were trying to, move into the phase 2 of the step-up study to basically, also potentially, check the serum marker, placental growth factor as well, in order to help us stratify the risk from high, moderate, and low risk. Like I said, I currently still collaborate with that group to figure out a way, for us to standardize this test being covered by insurance companies here in the US. Okay, so I'm going to just move to talking a little bit about the long-term postpartum studies related to preeclampsia. And again, it is not just important for us to, treat preeclampsia to improve maternal and neonatal outcomes, but specifically in the maternal context, we really want to, improve the long-term outcomes for women who get preeclampsia. And so, basically there's been a number of studies done over the years that show that the lifetime cumulative estimates of maternal survival after preeclampsia is, significantly reduced, compared to women who don't have preeclampsia. As you can see in this graph here, this solid gray line reflects the women who don't get preeclampsia. And if you follow, these women, up to 35 years after delivery, their outcome is significantly better than those women who get the preeclampsia but who subsequently become normotensive, and much higher even compared to women who get preeclampsia who get long-term chronic hypertension. As you can see there is a wide disparity of outcomes when you follow them up to 35 years. And so, in 2001, so a bit over 20 years ago, there was papers published in the Lancet that showed that, women who basically had these factors, at the end of the deliveries, when you looked at to see whether they're preeclampsia, preterm delivery, and lowest birth weight quintiles and so forth, that the risk of death from ischemic heart disease is significantly higher, if they had any of these kind of factors, and if they actually have preeclampsia and they had preterm birth and the birth rate was in the lowest quintile, so the lowest 20%, the risk of death from ischemic heart disease is actually, 16 times more likely. So this is quite significant. And then the CHAMP study published by Ray et al. From Toronto in 2005 showed that, women with the maternal placental syndrome, so preeclampsia, had a risk of cardiovascular death of 2 times, and if they have actually maternal placental syndrome and 1 to 2 features of metabolic syndrome, so that could include impaired glucose tolerance, hyperlipidemia, and so forth, the risk was actually 4.5. And they've actually have 3 to 4 features of the metabolic syndrome, and the maternal placental syndrome, the risk is actually 11.7. but at baseline, even if they didn't develop anything else after the maternal placental syndrome, so i.e. preeclampsia, the risk is at least 2.0. And a Bellamy in 2007 published in the British Medical Journal that basically the risk of cardiovascular disease is significantly increased if they've had preeclampsia. Okay, so again, we look at autorelative risk as at least 2 to 3 times when Bellamy looked at the results of the various trials published for the preceding 10 years. And again, similarly for hypertension, the risk is significantly higher, at least between 2.0 to even up to 20 in one of these studies that were shown. So at this point, I'm going to just summarize by saying that, really preeclampsia and cardiovascular disease share a lot of common risk factors. And again, this is why, it is so important for us as obstetric medicine and maternal medicine specialists to really, I think, frankly, educate not just the general population, but also the medical community in understanding preeclampsia better and providing better care for these women, particularly in the postpartum period, to improve the medium term to longer term maternal health. So I want to make a number of acknowledgements. 2 of my colleagues from the Division of Obstetric Medicine at Women and Infants Hospital, as well as a couple of my collaborators from the Division of Pathology and Laboratory Medicine at Women and Infants, for doing this work with me over the years. And a large number of people I want to say thank you to and acknowledge as my, professional partners over the years. I had the pleasure of being the ASM president for 6 years between 2018 to 2024. And these were all the members of the executive committee from around the world who, frankly, gave me lots of wonderful ideas and support over the years and frankly, kept myself in check. And these are all my colleagues from, Brown University in Rhode Island, who I worked closely with. And these are now my current colleagues at Harvard Medical School. And then importantly, these are my current trainees, and it is my, I think my adage is that in life, we must always pay things forward so that whatever, we have tried to do over the years, that we empower the trainees coming after us to, to continue doing for the better good of the society and community. So on this note, I want to once again thank you all very much for listening to my oration, and thank you very much for the kind invitation once again. And wish you all I wish you all very well, and that you'll continue to enjoy the rest of this wonderful conference. Thank you very much.
Was just done to the first oration. There will be a small announcement by Prakash Mehta, sir.
Thank you, Dr. Kenneth. We really appreciate your spending time with us. We have a memento for your oration. We have a memento for your oration. This happens to be Mrs. Mayabai Kandila Mehta's picture, and this is the oration plaque for you, which Dr. Reddy will bring it by September when he comes to Boston. So you get your desk at that time.
Okay,
Thank you very much, and it was a wonderful oration, and we are very pleased with whatever you have been doing for us. Thank you.
You're welcome, and thank you.
Thank you.
Thank you so much. I hope we've refreshed and revised everything. We have a very interesting session coming up.
I call upon stage our chairperson for the next session, Dr. Satyavani. She's a senior consultant in the Department of Maternal Fetal Medicine at Bangalore Baptist Hospital. Dr. Satyavani is also a trainer and examiner for postgraduate. She brings years of experience and dedication to training. As chair, we'd also request her to chair and Dr. Asha ma'am, Dr. Sadhana ma'am, and Pushpa ma'am to please stay. We have a speaker. It is a moment of great pride for us to welcome Professor Anne-Marie Hennessy, a formidable presence in the field of maternal medicine and a global authority on preeclampsia, to be our next speaker. She currently serves as the Deputy Executive Dean at the University of Sydney, Westmead, and is President of Ischemic. With over 180 publications, 300 presentations, and an extraordinary $18 million raised for preeclampsia research, her contributions to science and mentorship are unparalleled. We're truly privileged to have her join us virtually from across the globe. Thank you, Professor, for being part of this international gathering. We welcome you.
Yeah. Good morning, Dr. Anne-Marie.
Hi, everybody. Yeah,
It's
can
our
you hear me?
pleasure. Dr. Anne-Marie, good morning, and it's our pleasure that you are joining us virtually. This entire proceedings are being distributed all across the world. We have many delegates from across the world who are going to listen to you, and later on it will also be on the YouTube. So thank you very much for being with us, and thank you very much for supporting us all the time. Thank you.
Good to see you, everyone. So thank you so much for your invitation to your wonderful conference and for your efforts in helping our women around the world who have preeclampsia. So I bring you this talk on behalf of the International Society for the Study of Hypertension in Pregnancy. And the theme of this talk is going to be around the current guidelines and an approach to guidelines. So are you able to see my slides? You're happy? Yep. So I guess we wanted to start the talk with a bit of a discussion about the point of guidelines, because they're clearly increasing in use across our sector in health, but across pregnancy specifically. And you don't have to search very far to find guidelines about everything from a specific activity such as laparoscopy. There's recent guidelines come out of the Australian societies regarding sepsis, hyperemesis gravidarum in pregnancy. Guidelines might mean something to patients in terms of an outline about how they need to look after their care, but to we as healthcare workers, guidelines give us a very clear open door into what might be reasonable clinical practice going forward. I'm going to refer today both to the International Society for Hypertension in Pregnancy guidelines, or the Ischemic guidelines, but also to acknowledge the fact that recently the Society for Obstetric Medicine in Australia and New Zealand, and you saw some of our executive in the previous talk, Angela Macris and Sandra Lowe and others who've been part of the ISOM, or the International Society of Obstetric Medicine network, who have sought diligently to not only look at hypertension in pregnancy, but other complications for women and what they might mean. The guidelines that have come out of SOMANS, which is the Australian and New Zealand Society, in the last 2 years have been translated into multiple languages. And I include for you here a slide that just shows that there is an outline about aspirin use in Hindi language, which we provide to the 1.1% of Australians who have Hindi as their first language, that are part of the community that we look after here in Australia. The interesting thing about the most recent guidelines is they also include, so we've jumped to the end slide, that they include facts about what guidelines need to be, how they need to develop and what they're intended to do. So why do we have guidelines? Well, ultimately, the aim of guidelines, as you heard from Kenneth's talk, are to provide recommendations that optimise care. And as you can see from the data that Kenneth has provided to you, we're getting incremental bits of information at all times about the use and application of the treatments and preventions that we think might be useful. Do we use aspirin for prevention of all preeclampsia or just preterm preeclampsia? How do we focus on the right kind of women? So what recommendations can we go to that give us the best evidence-based guidelines that will optimise care at that point in time? How do we provide a systematic approach to evidence so that that's built in by a series of experts rather than the individual person who might be looking at those guidelines? How do we reduce unwanted practice variation? And that's a big deal in a country like Australia with a great geography that goes from very remote communities that have very little access to any health care in some of our remote Aboriginal communities up to communities across different parts of our states that have different approaches to what they might instigate in terms of care. How do we enhance our research evidence into everyday clinical practice, and how do we improve quality and safety? And ultimately, they give us a really nice tool to educate and train the next generation because it's a summary of data that's state of the art at the time of their training. But I also wanted to add that there are really potentially a strong influence towards health services to influence our policymakers and government. We're seeing it a little bit in pregnancy practice in Australia, but I'm sure you're aware of examples in your own communities where guidelines have helped you say, no, we can't discharge this patient until we've had this done, or we can't put this patient on an antenatal pathway unless we can offer this particular piece of evidence because the guidelines tell us that that's the right thing to do. So the guidelines provide that international or local strength to our evidence and our argument to say that we're not the only ones that say that this is necessary. My argument around the guidelines that I've been involved with in the last few years is that they straddle the notion between healthcare policy development, which sits in governmental areas, academia and their tremendous contribution to the generation of evidence, but also how our health systems and hospitals in particular work in getting that translated into action for our patients. So the people who make guidelines and who use them, there's some debate going on, particularly out of some recent arguments around the Cochrane collaboration, is about the right of professional societies to develop guidelines, and some pushback that there's a lot of self-interest in a society getting what it wants, if you like, out of establishing guidelines, and that generally professional societies are seen as using a lot of scientific evidence as their basis for their decisions about what might enter into guideline practice. Governmental authorities may be slightly more focused on the cost effectiveness of those treatments, and while that's not an illegitimate approach because we need to have equity and access to those treatments, it's a slightly different lens to what might be found in the evidence. And then, of course, international agencies are ultimately responsible for making sure that those service efficiencies are offered across the globe in the best evidence-based way. What I intimated there with a cranky face is that in my life in this practice, I often see, discontent from consumers about, well, this is the best evidence. You've presented this study. This shows that everybody should get this or that. And then you've got a community that are ravaged by cost constraints or by the constraints of the communities and the healthcare workers that they're working with. How can they find that best balance to make that go forward? So how do we balance across the concerns of our policymakers who say that we can't afford to do that, or it's not efficient, or that it distracts from other activities that we're trying to undertake at the same time as balancing what clinicians see from the evidence as being something almost immediate to what they want to do in everyday clinical work. I think there's another important imperative to think about, and that's this notion of a real world evidence, that we find stuff that's produced like the Asprey trial in a highly stylized, educative, academic environment, where in fact the rates of high-risk preeclampsia or high-risk pregnancy were nothing like what was anticipated at the design of the study, and how we then take that out of that research environment and apply that to everyday clinical practice. Do we try and go straight from A to B, or in plan A, go from a pre-state to a post-state that seems somewhat linear in design? Or do we find that taking into account cost constraints, that's somewhat a journey to get there? Or in real life, that's a messiness between the thoughts that we have and the way that we want to roll out those constraints in real time. I've recently been involved with a team in Malawi instigating a prevention clinical trial in preeclampsia, and that work some of you will have seen in the preeclampsia domain. But that was a life that was ravaged by both COVID and cholera and Ebola, and a typhoon that nearly wiped out a third of the accommodation in that city. So any ideas that we had about, you know, the number of visits or the number of reviews that were required, even in the clinical trial setting, had to readjust themselves continually about the real world environment, which I'm trying to demonstrate by that curly line that sits underneath. So if we think about early pregnancy advice and assessment, what's costly and detailed versus what's pragmatic, as in what is able to be provided in the moment within the systems in which you work, what's objective and what's simplified, and that very much is part of the way we're going forward. I mean, do we really think that aspirin is a solution for all of our ails? Well, we don't think so, but we're wanting better information all the time about how to apply that. If we think about the cost and application for our most at-risk group, they're in fact our primips, aren't they, in pregnancy? So how do we come up with an algorithm that gives our women in their first pregnancy the best chance at an outcome when they don't have a reproductive history on which we can base the assessment? So if you think about the National Institute of Clinical Excellence and NICE guidelines and others, they very much rely on the fact that pregnancy history matters. And while I completely understand that, in an environment where we have many women who only have one pregnancy, how do we apply those to their best benefit when we've got that constraint? I'll talk a little bit later about, sorry, I've just got a cold, the new diagnostic tests for preeclampsia. But my consumer groups talk to me a lot about why do we restrain those tests to only women who start to get symptoms? Don't women want to know what's going on earlier in their pregnancy, and how do we write those things into a risk assessment or into the progress of pregnancy in a way that might be meaningful? So the Amanda 3236 is a study that's been designed from a consumer group that I work with, who specifically want to know what we can do to test women at 32 weeks of gestation or 36 weeks of gestation that give us the best chance of turning around their progress to preeclampsia and its awful outcome. And then the ultimate question for us as an international society, trying to work with all the different countries around the world, is how do we make that application to all countries and systems the most reliable that we can and reasonable? In my practicing lifetime, I've seen a marked improvement in guidelines over the years. What I've seen, and I wanted to reflect as I've attended these conferences for the last 35 years, is what I call the journey of the definitions. We were so distracted by what is the definition of preeclampsia when I first started in this area over 30 years ago, that was almost paralyzing. There were 23 definitions of hypertension in pregnancy. We've started to move away from that to say, let's have some common ground about what we think is the disease, and let's use that common definition to try and move our way forward. I think the more recent guidelines, particularly the SOMAN guidelines, don't just talk about the definitions in terms of what is the diagnosis, but they talk about the definitions in terms of what is the target for treatment. And I think for active clinicians, that's a way more useful piece of data than that defined by just the diagnosis. So I think that that's really helpful, and I'll come back to that as well. I think they provide more concrete options for treatment. And again, one of the commonest phone calls I get as a nephrologist and obstetric physician is around women that get commenced on treatment that are underdosed. And I think Kenneth alluded to the fact that, you know, why would you choose 81 milligrams versus 150 milligrams? Did you genuinely double the dose? Different countries just produce different milligrams of aspirin. Actually, that's the truth of it. Some countries make 325 milligram tablets. Some countries make 300 milligram tablets. Do you take a half or a quarter? What does all that mean? But I think it's actually quite helpful when you're arguing for treatment in a jurisdictional sense to your government or to your agencies to have some data that supports the treatment options that are in front of you. I have to admit that post-COVID, that's never been more important, because we're here in Australia, we're having trouble accessing some of our medications because we don't produce them in Australia. So how do we get the right doses at the right time against the recommendations that we make? I think the other great improvement has been the involvement in consumers, not just in being co-designers or approvers of what we're doing, but actually being the people who say to us, this is what we want you to study the most. And I think that leadership from consumers is only going to take us further into the future. What I'll show you from the SOMAN's guidelines are a series of flow sheets and better communication strategies out to the broader community that give I think the patients great comfort that this is not just that clinician speaking, but it is the imprimatur of dozens of clinicians and consumers who've been thoughtful about what their needs might look like. I'll talk a little bit about the Ischemic guidelines now, which is the International Society for the Study of Hypertension in Pregnancy. So this is a global group representing around 60 countries in terms of membership, who look at particularly the guidelines for practice, but also look at application of the evidence, as I've suggested, in what we do in everyday practice. The 44 recommendations in the Ischemic guideline fall into 6 main areas, and they are the diagnosis and classification of hypertension in pregnancy, the prediction and prevention, and I'm so happy to see those elevated to the strong components of what we do. What are the components of management, and how do we enter the postpartum regime of taking women who've got hypertension in pregnancy and then be advisors about their cardiovascular health over the next, 20, 30 years of their lifespan, well beyond their pregnancy. What you'll see in the Ischemic guidelines is a statement of fact about those 44 recommendations based on whether there's strong evidence on the basis of randomized controlled trials or other strong evidence, or is it a good practice point? And that is that no reasonable clinician would think that that's not an okay thing to do within the context of that patient. So what I'm going to do is just work through the recommendations and bundle them up. This one is about hypertension, but I'm going to talk about sometimes when you read these things as a clinician, you see a bundle of them that seem pretty easy to action, seems pretty logical and straightforward. Why wouldn't you do it? But then there's another bundle of those that's put in the harder category. It's harder to apply that to the populations that we work with, and harder to imagine how we might apply that data. And where there's new data coming in, that means that we're modifying our thinking about those as we go along, and that they can't be set in stone. So if you have a look at the blood pressure recommendations within the Ischemic guidelines, they're really logical, straightforward issues are around have a valid machine. We would say in Australia, just have the right machine. Don't use a wristwatch blood pressure machine that is not validated in pregnancy. The second domain is do it properly. It's a very simple test. It's not inexpensive because it's labour driven and someone has to take their time to do it and do it properly, but there's no point in doing it badly. I've had women say to me, no one's ever asked me to take my jumper off, my woolen top off to take my blood pressure. That to me is bizarre. How you think that a piece of clothing is going to represent someone's blood pressure is beyond me. The other recommendation is strongly about repeating the measures so that you're not ever making a decision based on one reading. So I think that stuff is easy, isn't it? As clinicians, let's do those things. What's a bit harder and more recently emerging in the literature in the last 2 years is the definitions of hypertension. So the American Cardiac Society Association have recently changed the definition of hypertension to 130/90. 130/80, isn't it? Sorry, rather than 140/90. So what does that mean for us in pregnancy, given that blood pressure is a continuum? I've only picked a few papers out here, just try to make the point that you might see the definition of hypertension as greater than the cut points of 140/90. But the reality is somebody with a blood pressure of 139 or 138/89 less worrying to you than someone who's at 141/91? Well, of course, they're not going to be. But how do we find those cut points when we're trying to deliver a system of blood pressure control that's reasonable? So this was a study by Porcelli and the American Journal of O&G in 2020 that showed that if you looked at women who developed any reading of 130/80 at any time in the pregnancy after 20 weeks, that little bit of a step up, while in the previous diagnosis didn't become hypertension in pregnancy, had a greater risk, a significantly greater risk of both getting preeclampsia or another hypertensive disorder of pregnancy with severe features, but they didn't have poorer outcomes. So they certainly were more likely to be defined as having preeclampsia. I think this study is really interesting, but it just defines the journey to me. So these weren't women who started hypertensive. They just started to move towards that hypertension stage 1 or whatever you want to call it domain, and then became on their way to becoming defined as someone with a hypertensive disorder of pregnancy. Very useful information, though, to say that that rise in blood pressure is real. Jung et al. From, I think it was a Canadian study that looked at 375,000 pregnancies where they did what McGillivray and others had done in the early 70s, and that was to show it's genuinely a continuum across lots of patients. The higher your blood pressure, the more likely you were to end up with a composite of a score of a poorer outcome. And these were women whose blood pressure was elevated pre-pregnancy. So it comes into this domain of what determines hypertension from the outset. Their composite endpoints were real. They weren't just getting preeclampsia. They were preeclampsia and or placental abruption, stillbirth, low birth weight, or preterm birth. And those composite scores were continually elevated. They did divide that data into those with a high BMI or low BMI. The high BMI are the blue line in those graphs, and the low BMI were the red lines. The green lines were the cumulative data. Again, like Kenneth has indicated, when you overlay those metabolic factors on top of the risk, it's really compounding the risks of those women going forward. Very helpful for us to know that if you're seeing someone pre-pregnancy with a blood pressure of 135 and 85, then you've got a worrying pre-pregnancy risk factor profile that's not the same as someone whose blood pressure is 120 on 80. If we go back to the previous slide, what's easy is it has become easier with time is the definitions of proteinuria. So again, I can remember the days 20 years ago when we were fussing about whether a protein creatinine ratio was useful, whether we needed to do 24-hour creatinines or 24-hour proteinuria measurements on everybody. We've fallen away from that, and I think that's very helpful at the bedside. The dipstick is still very useful, a cheap and easy test that can be rolled out to most clinics around the planet, where you've got 2+ or more proteinuria becomes a reliable indicator of what's going on. The next domain in the Ischemic guidelines are around definitions. And there's been a lot of fuss about going from 23 classifications to 4 classifications to 6 classifications. The current guidelines generally talk about the big 4, let's call them that. So gestational hypertension, preeclampsia, chronic hypertension, and superimposed preeclampsia. But we've added these much harder definitions to define. White coat hypertension is where your blood pressure is elevated at the clinic setting, but not at home. Masked hypertension, where it's elevated at home, but not in the clinic. And the only way you can sort those conditions out is by having lots of home measurements versus clinic measurements. And that's not inexpensive. Women are struggling with the notions of how and when to take their blood pressures at home, what readings to react to, how do they incorporate their understanding of those readings into their day-to-day activity, and what does that look like. Within the current Ischemic guidelines, there's 2 other caveats that I thought I'd bring to your attention, and that is the notion of a rising blood pressure in someone with chronic hypertension. So as a renal physician, I look after lots of women with high blood pressure that seems relatively stable until 32 weeks, and then it's not. They've got, every time you see them, they've got rising blood pressure. They might have a bit of edema and a bit of headache. However do we sort that group out? And our advice is that blood pressure alone can't define preeclampsia. While I totally accept that, I ask myself as a clinician all the time, what is going on with them that their blood pressure has suddenly become much more difficult to manage? The current recommendation is not to test for secondary causes unless there's a clinical indication. But in a busy clinic where you're seeing hundreds of patients, it's very difficult to have the time to sort out what might be an additional risk factor that indicates secondary causes. You know, do we screen them all for hypokalemia? Do we screen them all for abdominal bruits. It just goes on and on. So it remains an area that I think is very vexed. In the classification area, what's new is about the use of standard blood tests. So we use liver function tests and creatinine and a platelet count to define preeclampsia and HELLP syndrome. But we also have the advent of the anti-angiogenic tests that measure placental function. So there's no doubt that they measure placental function. But I would argue in the harder category that we still don't know exactly when to test for them. Do we do them all repeatedly during pregnancy? Do we do them only when we've got suspected preeclampsia? And by the time that someone's headachy, edematous with a rising blood pressure, the test may give us a bit of an indication, but I would argue that that's not in the predictive domain of being able to offer them any substantial prevention to the superimposed preeclampsia. Should we use it routinely? Do we rule out disease? Do we rule in disease with that test? Do we use the ratio or the individual results? So some of the commercial bedside tests use just placental growth factor rather than soluble FLT1 ratio, or do they use them alone? We'll work around these things, won't we, in the next, I think, 5 to 10 years. And then, of course, it's not inexpensive. So the consumers say to me, why don't you just test women all the time? And I say, yes, because the cost of the test would kill the system if we were to try that in Australia, let alone globally. In the prediction algorithms, the clinical history is pretty straightforward. And again, Kenneth has showed you a very structured algorithm that allows us to take into account the women's reproductive history, their metabolic risk profile, their personal history, to try and make an attempt at ascertaining a risk. I would argue, though, that I don't think we're really there on defining what we mean by the risk of early versus late onset disease. And I think even the definitions of early onset disease are a bit fraught. As a journal editor, I just as often see papers presented as early onset disease, meaning onset of the features of preeclampsia before 34 weeks, and others who define early onset as delivery before 34 weeks. And then again, places that I've worked globally, having preeclampsia is almost an immediate commitment to having the pregnancy delivered. So there's not a lot of a gap between diagnosis and delivery, but there is a big gap in other places where they've got better and more neonatal expertise to develop the very premature babies. So I think I looked back at a Ischemic survey of the executive about what defined early versus severe disease, and they really based that assessment on onset, but that's not by any means universal in the way the scientific evidence is presented in the published literature. And I would contest you to look at that carefully as you read those papers. It's all very well to say that prediction is easy if you've got fancy ultrasound with very high quality ultrasound techniques and technologists who can do quite sophisticated testing of pulsatility indexes, etc. And I'm speaking to you as an FMF society where that's your brief. But I would argue that that's not available for the vast majority of women at the bedside. And how do we get the best possible information? And doing a placental growth factor test is getting cheaper, and we might be able to incorporate that more with time, but that's not straightforward. And of course, how do we actually offer prediction strategies to women who work through our doors at 20, 24 or 28 weeks of gestation when that opportunity has passed us? On the prevention strategy in terms of what to do, the guidelines talk about exercise. That seems straightforward, particularly communities that don't do much exercise. I think globally women exercise terrifically, try to support their families. So I don't know how much that is in play in lots of places. Calcium supplementation as a low-risk strategy seems pretty straightforward, except it's expensive, more expensive than you might think in some jurisdictions. The low-dose aspirin seems a no-brainer, but I still think that the nature of which part of the disease we're trying to prevent, the idea about how we handle our primiparous, how do we link that to the technology and the biochemical testing that's available, and which type of preeclampsia we're trying to prevent matter. The guidelines are very clear on the fact that low molecular weight heparin, vitamin C, and folic acid are not recommended in a standard way, and that's helpful in terms of, again, providing funded advice to health policymakers about what we're prepared to back and what we are not prepared to back. The next set of guidelines are around management. Very easily obvious is that if you're complicated women, they should be in a high standard place of care. Hospital, a tertiary referral centre. These are not patients that can be looked after in places of in centres of low resource. It's an easy decision to use antihypertensives, and there's lots of places that I've had dealings with globally where they have some antihypertensives in the cupboard so that we can start and control the blood pressure. That will save lives. The use of antihypertensives is urgent in cases when the hypertension is severe. And of course, the magnesium trials, as a result of the MAGPIE trial and others, has told us when both to prevent and treat seizures with magnesium, and that has become globally a standard of care. We shouldn't diminish the role that good scientific evidence has played in adapting magnesium treatment to the right women at the right time. The guideline does say don't bother with plasma volume expansion. So there's both what not to do and what you can do in those situations. That's helpful from the guidelines. I think what's a bit harder in the management paradigm is this notion of when to deliver. So the HIPPY-TAT trial and other trials have suggested to us that we should automatically deliver everyone at 37 weeks. But I looked after lots of women who are not ready to be delivered at 37 weeks, even though they might have preeclampsia that may be largely asymptomatic. The offset between delivering a 37-week pregnancy or a 39-week pregnancy are baby brain development. And how do we make sure that we haven't created the imbalance there that might be detrimental to our baby's well-being in the long term? It does say not to deliver women on the basis of proteinuria alone or hyperuricemia alone, and not to use steroids for HELP syndrome. So again, helpful in thinking about the way those treatments are provided. It's not infrequently that I get a paper to review as a journal editor that might use those strategies. I don't think that's a bad idea in the sense that you're thinking about what might be their best local knowledge and the local application. But at this point in time, there is insufficient evidence to suggest that they would be reasonable treatments across the board going forward. And again, harking back to Kenneth's talk, the postpartum domain is genuinely much more cemented in our clinical practice. I used to say to women 30 years ago, your preeclampsia is over, it's all better, nothing to worry about here, just get on with your life and go home. And that couldn't be further from the truth. The strong recommendations are about monitoring carefully for a couple of days, even up to a week. To treat the blood pressure when it's elevated, use non-steroidals maybe with a bit of caution as long as there's no hint of renal failure, that breastfeeding is supported. Talk to the woman about future pregnancy risk, instigate counselling around cardiovascular risk at 3 months and 6 months, and even annually for up to 10 years. What I think is a bit harder, at least in my world in Australia, is how do we connect that strategy with what's going on in your health system? So our patients move out of a hospital system into a primary care scenario with probably pretty poor communication between the hospital and community practitioners. So how do we make that connection stronger so it's meaningfully taking the woman's continuous journey going forward? There's a cost to reviewing every woman annually, which the system hasn't had to bear in the past, but women have been ignored in the past. So I would argue that that is a no-brainer, but I'm only saying that it's harder because the system isn't used to the cost of doing that. And what the guidelines all say, instigate a healthy lifestyle, but we know how hard that is. So I just put that out for you there. The SOMANS guidelines, which is the Australian and New Zealand guidelines, one of the great aspects of this guideline is a series of fact sheets, and I've just downloaded a couple of them here. I'll give these presentations to Revathi for her to share around with all of you going forward, but are very quick and easy tools to say, have you got calcium in your diet? And if you haven't, how do we supplement that? Women find this in my world, very reassuring, because you're talking about the things that they can do to help their own condition going forward. We've got multiple languages in terms of our aspirin in pregnancy guidelines. And again, the Hindi version of these guidelines is available. I like these guidelines because they tell us about the targets for the blood pressure. If the blood pressure is under is elevated, we want to target it to under 135/85, which is that sweet spot between what we're defining as the old hypertension domains. Tells you what treatment and how often to give it. I can't tell you the number of times someone gets referred to me because they're on twice a day Aldomet or twice a day labetalol, and people are surprised that their blood pressure is not under control. The drug only works for 4 to 6 hours, maybe 8 hours. It makes no sense of the pharmacology to use it twice a day. While I understand the pragmatics of women forgetting the third dose, it doesn't make any sense pharmacologically. So this is a tool that says start with the best minimum dose that you can and move forward. Again, I've been around long enough to know that severe hypertension was 170 when I started. Thank God it's now 160, because those blood pressures are very significant within the context of a normal pregnancy blood pressure, and it gives us some strategies about what we would use when we expect it to be effective. This doesn't overtake a local guideline that's been thoughtful to what your hospital might do, but it gives you ammunition to say that this is a national agreed stance on what might be a reasonable paradigm for treatment. This is quite a straightforward single on a page. What should I do about getting magnesium started when I need to? And you'd be surprised how often I get a phone call from pretty sophisticated environments about how do I get and when do I get the magnesium started. So this gives you a bit of idea about dose, understanding that the reactions and the potential complications of those treatments we need to be thoughtful about. And there's a nice algorithm about what to do in the postpartum space. Immediately, that 3 to 6 months postpartum period, and then annually afterwards, and how can we make a difference. I wanted to finish just quickly with a couple of slides about what the consumers say. And I showed this slide at an ISSHB conference on the last 2 global conferences after discussion with the consumers about what questions matter to them. And these are probably typically the questions that you get asked. Why has my blood pressure gone up? What is preeclampsia? That's fine. Why didn't I know about this? Why didn't anyone tell me that this was even possible? What was all that about? I was so unwell I couldn't think about it. I couldn't make a decision because no one even told me that that was possible. Did I do anything to cause it? Am I going to get better fully? And unfortunately, the answer nowadays is no. Your cardiovascular trajectory has changed forever. You've just had a baby. Imagine being told now that your risk of having a heart attack or a stroke is double what it was before you had this dreadful thing happen to you in your pregnancy. That's a much bigger deal, I think, than we've given it credit for. How do we include the views of women who are actively going through what we're discussing, rather than even women for whom that was a historical event? And they will admit that that's an important paradigm for us to think about. Will I get it again? In hindsight, could I have done something different to stop this happening? How much of this was my fault? Why didn't you test me more frequently for this? Why did it blow up in my face all of a sudden? And that has led us to thinking about more routine placental function testing through those angiogenic tests as pregnancy goes forward. Is my baby going to be okay? Will it all be my fault? What is it about this event that will change my risk of cardiovascular disease? What is that additional risk and what's happened to me? And then finally, the SOMANS has come out with the top 10 tips for women and their families that often gets downloaded from our website as a take home for them to feel like they've got some autonomy and control over what they're doing. So that's the end of my presentation. So I just wanted to draw your attention to the various guidelines that are available, both a global guideline and a local one. But if there's any point in having these guidelines, it's that you've got a group of local clinicians who've sat down and come to a consensus about what's important to your patients, your community, and which of these can you adopt locally. And if you surround those with the evidence about your outcomes, we'll do nothing but improve the care for our women and their families going forward. So thanks, Revathi.
That was a great lecture, Professor Angiogenic, and thank you so much giving us an elaborate overview. Before I ask you, when are we going to get the next updated ISHIP 2025 guideline? Before you think about the answer, I'm going to pass this mic to one of the chairpersons who's here. She's Dr. Rana, who is the Vice President of ICOG. So over to you, Dr.
Thank you, Dr. Rani. It was excellent, and you actually brought out the issue which is really concern of the Indian context a great extent, because that disparity a little bit from the professional guideline to the Government of India guidelines and the international guidelines, which actually we clinician get confused, and we are really going from how much is too much and how little is too less. So few gray areas, which is a 75 aspirin or 88 or 81 or 150, because our people have the low BMI and low birth weight, like Maxwell. In ground level setting, especially, still people don't like is scary about IV Maxwell and sometimes intramuscular or the low dose Maxwell. So thank you very much for bringing out that disparities. And what's your comment that how we, like, finally it is the individualization of the guidelines. So the Government of India says that start antihypertensive, that it is more than around 150, 100, and a lot of disparity between public health setting and the private health setting and the corporate health setting. So India, we have a lot of fragment, like a drivers, that is our strength, and sometimes it becomes weakness. So your comment about that how we take as a clinician, it is international guidelines, it is GOI, which the every government doctor is need to follow. So your comment about that conflict which is created, which gets created in the ground level clinical practice.
Yeah, look, thank you so much. Look, I think we have to sit back and say, like with anything we do, you know, a guideline that's meant to touch on the exact advice for every single woman on the planet isn't possible, is it? So we've done our best to say within the global guidelines that are available, this is what we think is kind of the best approach. And my argument would be, and that's why I've tried to present it as the easy wins. Nobody on the planet would say do the blood pressure badly. We'd all say do it well, do it properly, do it accurately, do it on a validated machine. You're wasting everyone's time if you do that in an environment that's just poor information. But I have worked in communities globally where having a person and a blood pressure machine is way more expensive than other things that we can do. And I've been shocked at how difficult it is to actually do those simple things well. So it's all very well for the guidelines to say you might need thousands of blood pressure readings. That's not possible in some communities. So all you can do is to say this might be an international standard or suggestion, but when I think about the cost, the possibility, the feasibility of doing that within my environment and how I would apply that to the outcomes that I want have to be modified by my local knowledge about what's feasible, and then justify that to your community, which are your patients and your healthcare policymakers, where you justify that that's the best that can be offered under the circumstances, but pushing your system to say, surely we could do a little bit better. How do we add to that with better quality machines or better access to the healthcare workers who are in the mode to take those blood pressures? So I think the guidelines give you a bit of a tool to say this is what might be working elsewhere. And the places that do all of that stuff very well have been able to reduce the maternal mortality to under 6 per 100,000. It's possible to achieve that using these kinds of approaches. I'm not saying you have to because you can't afford to, but the only argument can be one of access and money, affordability and acceptability to the community rather than one of scientific evidence, if that makes sense. So every hospital I've ever worked in has a local construct, a local guideline, because they're trying to adapt these global guidelines to what's feasible and what's workable locally, and that's all you can do. If your women don't come until they're 22 weeks, then you can't offer a preventive strategy. So that means there has to be a push towards saying, rather than having all of the visits between 32 and 34 4 weeks and 38 weeks and 40 weeks of delivery, we need to be able to fund some of those visits to be at 12 to 14 weeks so that we've got half a chance of trying to pick out who the high-risk women are and to offer treatment. I mean, trying to offer aspirin to countries, and I'll just again refer to work that I've been doing in Malawi in Africa with high rates of endemic malaria, where there's endemic anemia, that's a really big deal. You know, aspirin, if there was even a minor change in the bleeding risk associated with a community with, you know, low hemoglobins, we could be doing those women a disservice, and we owe it to them to be able to get the best quality information that we can. And that disparity between local application and what the guidelines telling us to do is the grounds for a study where there's not equipoise about what's the right decision. How do we then study that locally to provide exactly the right evidence that we need? So that's a great question. Thank you for your question. Yeah.
And, before we just move on, when is the next guideline going to come in, the updated guidelines?
Yeah, look, we've talked about that at the executive just recently, Revathi, and I think it's not an inexpensive activity. Guidelines can take up to millions of dollars to produce, depending on the cost structure. So again, we're just as bedeviled by the process as those of you at the coalface. But I think there's enough discrepancy around anti-angiogenic molecules and their application, and so the objectivity of the biochemical tests, the new ACA guidelines about what defines hypertension, and about home monitoring. I was just waiting until there was a bit more evidence around, to be honest, before we went back and revisited the guidelines. I think they're strong. The plan is to fund those this year for review and to have them published next year. Thank you for your question.
It's a very reassuring reply, and we totally understand it's a very expensive exercise, but we would definitely want those guidelines to important updates, at least, which could probably add value to the clinical practice across the world. Thank you so much, Dr. Anne-Marie.
Thanks for the invitation. I appreciate it.
Thank you, Dr. Anne-Marie, for being with us. And your lecture has been very widely appreciated. I've been told by all the people that they were looking forward to the lecture and they are very happy at the end of the lecture. Thank you for being with us. Thank you.
Thank you so much.
We thank the chairpersons for their valuable contribution. Thank you so much.
That was a masterclass, concise, engaging, and full of valuable takeaways. Thank you for that wonderful lecture. Our next speaker today is Dr. Munishwaran Ganeshan. We are delighted to welcome you, sir. Dr. Munishwaran is a distinguished speaker in maternal fetal medicine from Malaysia. He serves as consultant obstetrician and gynecologist, visiting lecturer at the University of Malaya, and consultant to the National Heart Institute of Malaysia. As president of the Obstetrical and Gynecological Societies of Malaysia and the founding president of the Malaysian Obstetric Medicine Society, his influence on national policy and academic advancement has been profound. Thank you, Dr. Ganeshan, for joining us and sharing your insights on this global platform. I'll just hand over the mic to Dr. Prakash Mehta for a few words.
Yeah, good morning, Dr. Munishwaran. I think good evening for you.
Good evening.
We are very glad that you have joined us, and I'm sure all of you were there for book release in the morning. Dr. Ganeshan is one of the international editors for this particular book. And I have quite a few of my Malaysian students sitting here, so that I'm sure some of them would like to work with you in future. So thank you for being with us. Please go ahead with your lecture.
Thank you so much, Mr. Chairperson, for the kind introduction. And I would like to congratulate the Society of Maternal Fetal Medicine in India, especially the wonderful work done by Dr. Prakash K. Mehta and Dr. Revathi. Wonderful work, and thank you so much for inviting me. Ladies and gentlemen, I'm going to talk about pregnancy implications and maternal health. I'd like to declare that I've got no conflict of interest for this talk. But in the next 30 minutes, I'm going to highlight three things: the long-term impact of pregnancy, what are the responsibilities of the modern obstetrician, that is all of us, and how can we now make a difference in the future. So, ladies and gentlemen, what is the obstetrician's role? Is it just to take care of a pregnant mother? Is it just to deliver a pregnant mother? I believe it was true many years ago, but now I believe obstetrics is holistic to take care of women before, during, and even after childbirth. And that is going to be the highlight of my talk. Let's take a look at some gestational syndromes. Over the last few years, we can appreciate certain conditions called gestational syndromes, and they are gestational diabetes, gestational hypertension, gestational thyrotoxicosis, peripartum cardiomyopathy. Fast forward, ladies and gentlemen, the list goes on. And now we can also appreciate gestational sleep disorders, bleeding called gestational apnea. And I believe the way a pregnant mother changes and adapts is a whole new physiological appreciation of the hemodynamic changes. What has been established? I think we now can appreciate that pregnant mothers who deliver and after delivery has got a higher incidence of stress incontinence, overactive bladder, anal incontinence, and even pelvic organ prolapse as a consequences of childbirth. We also can appreciate the long-term fetal implications of a pre-labor cesarean section to the fetus, especially increase in incidence of atopy, allergies, asthma, reduced gut microbiome, long-term neurodevelopmental issues, inflammatory bowel diseases. But having a child delivered via pre-labor cesarean section predisposes the child to a future health of obesity and metabolic syndrome. And these are well-established facts. We also know, thanks to the Barker's hypothesis of the long-term implications of intrauterine fetal growth restriction, namely the increased risk of diabetes, cardiovascular diseases, and obesity. And these are all known facts. But ladies and gentlemen, I'm not going to talk about these facts. I'm going to talk about what is the current momentum, the current understanding of the long-term maternal health implications of a pregnancy. This is the data from the Malaysian Confidential Inquiry STAT. Looking back into the last 35 years, when is the highest risk of maternal death? It is not antenatally, it is not intrapartum, but 1 in 2 of our pregnant mothers, up to 55% of them die in the postnatal period. And I'd like to highlight the importance of focusing in the 4th trimester, a fact clearly highlighted by Dr. Ken in his lecture about the importance of obstetric medicine. So, ladies and gentlemen, it is not delivering a child. It is not taking care of the mother throughout the antenatal period, but I believe the postpartum care is going to be crucial and essential if we are going to look into ways to reduce maternal deaths. So with that, what happens in the 4th trimester? We now appreciate the whole morning we've been talking about preeclampsia and cardiovascular diseases. There is a strong established link, the association between preeclampsia and cardiovascular diseases, the increased risk of cardiomyopathy, mental health, especially suicide, VTE, sepsis, GDM, epilepsy, and weight, all of which are increased in the 4th trimester. So, ladies and gentlemen, my talk is going to be around the important aspects of what we should look for and how we can refine the management of the 4th trimester. I'm going to start with mental health. Let's take a look at the global maternal mortality deaths reviewed and released by the Lancet recently. Globally, the leading cause of maternal death is hemorrhage, that is followed by indirect causes, especially cardiac-related causes, that is followed by other indirect causes, sepsis and embolism. But in the developed countries, ladies and gentlemen, mental health is on the rise, a condition that I'm sure is also highly prevalent in India as well. If you take a look at the recently released Embrace report, psychiatric illness is the fourth cause of maternal death in the UK, only to be preceded by thrombosis, COVID-19, and cardiac diseases, and more mothers die from suicide than sepsis. What is important about UK, they look into late maternal deaths, the incidents where mother dies after 6 weeks, but within a year from childbirth. 16% of maternal deaths in the UK is related to suicide. Looking deeper into the Embrace report, the death of a pregnant mother is often traumatic. The death usually occurs in the postnatal period between days of 43 and 91. And I hope we can appreciate the fact that mental health is something that we as obstetricians must be well versed, and we must know the red flags associated with mental health. So the fourth trimester, ladies and gentlemen, is an extremely challenging part. We should treat and look for insomnia, depression, suicide, anxiety, vaginismus, secondary tocophobia, especially among mothers who had a high-risk pregnancy or an adverse pregnancy outcomes. Now we've come out with a policy of universal screening for depression and anxiety at booking, at antenatal period, and postpartum. And I believe this universal screening, looking for red flags, will go a long way in saving a mother's life. Next, I'm going to move on to gestational weight gain. Ladies and gentlemen, there's been numerous guidelines about what is an appropriate weight gain during pregnancy. The International Medical Society, the IOM guidelines, still remains controversial. And the age-old relationship saying that a pregnant mother should gain 10 to 12 kilograms during pregnancy is no longer true. Now, what happens in pregnancy, ladies and gentlemen? If a mother gains weight, there's going to be an increase in fat mass. If there's going to be an increase in visceral fat, that's going to lead towards complications such as GDM, preeclampsia, and dyslipidemia. And most mothers will retain 30% of this weight. Not everyone returns to their pre-pregnancy weight, and that is going to cause an increase in the incidence of type 2 diabetes, cardiovascular diseases, and metabolic syndrome. From being a healthy, thin mother, if you have 2 pregnancies, if you have significant postpartum weight retention, you'll be obese by the end of the 2nd child, an endemic that we as obstetricians should look at. Ladies and gentlemen, Malaysia has got a high incidence of obesity. The incidence of obesity among women is 1 in 2, and the incidence among obesity among pregnant mothers is 1 in 3. So how should we look into this? I believe as obstetricians, we must talk about physical activities during pregnancy. We should debunk the myth about confinement. We should ensure and educate that women continue to exercise during pregnancy at least 20 minutes of moderate intensity, non-weight-bearing exercise. And as obstetricians, in the postpartum period, talk about how to manage postpartum weight retention. A mother who starts healthy should, at the end of pregnancy, return back to her weight, and that will reduce the incidence of obesity among women. I'm going to move on to the third condition, gestational diabetes. The incidence of gestational diabetes in Malaysia is about 15 to 20%. It's higher among Asians, it's higher among Malaysian Indians. So what happens if the mother has got GDM? If the mother has got GDM, there's going to be a significant in utero programming. There's going to be a placental dysfunction, and the baby of the mother of the GDM mother is going to have a higher risk of developing diabetes in later on in life. Studies also show that mothers who have got GDM have got a 50% of the chance of developing diabetes in 5 years, has got a higher risk of developing obesity, cardiovascular diseases, and not to say that infants of mothers with GDM will later on have a higher chance of having metabolic diseases. So ladies and gentlemen, the solution towards tackling the future generation is to look into early detection, is to look into active monitoring and screening, is to transition the care where it does not just end the childbirth, but to educate and empower the mother and her future baby towards remaining healthy throughout her life. And the way forward is universally screening for GDM of everyone at risk in the antenatal period and transition of care in the postnatal period. Let's talk about the disease of the day, the preeclampsia. And by now, I'm sure everyone can appreciate the incidence of preeclampsia, the importance of diagnosing, screening, and treatment, and the long-term health implications of preeclampsia. Ladies and gentlemen, I think now, after birth, we should risk stratify all patients who are at risk of postpartum hypertension. There are 4 groups of mothers who are at risk. Mother who required antihypertensive therapy, mothers who have had severe preeclampsia, mothers who have delivered preeclampsia prematurely, and any mother who got preeclampsia, the disease does not end at childbirth. It usually worsens postpartum, only to normalize a few days after childbirth. Delivery is the cure, but the blood pressure does not normalize at childbirth. So we should continue to watch them closely. Now, what are the long-term implications of preeclampsia, ladies and gentlemen? 2/3 of mothers with preeclampsia will later on develop complications of cardiovascular diseases. If a mother develops preeclampsia during pregnancy, she's got a 2-time increased risk of having heart disease later on in life before the age of 50. She's got double the increased risk of stroke and 4 times increased the risk of blood pressure. Now, how many hours actually counsel our pregnant mothers at and after childbirth about the long-term health implications of preeclampsia? Now, what are the acute changes of preeclampsia? You can have increased thickness of the LV wall, an abnormal RV strain, left atrial enlargement, diastolic dysfunction, and that can predispose mothers to pulmonary edema. But a significant amount of pregnant mothers who have got preeclampsia will have diastolic dysfunction, and people believe that is the trigger for labor. But having said that, what is the pathophysiology and pathogenesis? There's a significant genetic, epigenetic, endothelial, and anti-angiogenic stress, apart from oxidative stress, that predisposes the mother towards preeclampsia. And this stress affects both the individuals, the mother and the baby, who are both at a higher risk of having metabolic diseases later on in life. There's a lot of DNA methylation. There's a lot of micro mRNA changes. And this in utero programming, as I said, also affects offsprings of mothers who have had preeclampsia. So the impact is significant, ladies and gentlemen. Now, what are the other changes? If you had preeclampsia, the chances of a mother to have coronary artery disease increases before the age of 50. The chances of her having heart failure increases twice before the age of 50. The incidence of aortic stenosis and mitral regurgitation, purely because of the failure of the heart to remodel after delivery, increases in mothers who have got preeclampsia before the age of 50, an onset which is way before the onset among men. Now, this is a study looking into mothers who have got preterm preeclampsia, followed them up for a good 35 years, and looked into the onset of acute myocardial infarction and ischemic stroke. And ladies and gentlemen, if you think myocardial infarction and stroke are diseases which are prevalent among men, that is no longer true. It is diseases which are prevalent among women, especially mothers who have had preeclampsia. And the incidence is high in the first 10 years after childbirth, not at a later age, but few years after childbirth. And that is true for acute myocardial infarction and acute ischemic stroke. So the next time we're talking about cardiovascular health, an important question is asked whether the mother developed preeclampsia. She is at risk, and a risk should be stratified. So the solution, ladies and gentlemen, I'm sure this has been highlighted by Dr. Ken and Prof. Anna Mary about the importance of prediction and prevention, about the importance of the fourth trimester that I'm going to highlight. And I'm going to emphasize the importance where obstetricians after delivery should have the care transitioned to the physician, to the cardiologist, to the primary healthcare giver, a point that I'm going to highlight after this. Let's take a look at cardiomyopathy. For many years, we thought that mothers who have got a complete resolution of the ejection fraction, who made a full recovery, will have a better outcome. But that is no longer true, ladies and gentlemen. Any mother who developed peripartum cardiomyopathy, even among mothers who made a complete recovery after 6 months after childbirth, are at a higher risk of heart failure, stroke, and cardiovascular diseases, just like preeclampsia. I'm going to speak about VTE. VTE now, ladies and gentlemen, is the leading cause of maternal death in the UK. It is the third cause of maternal death in the Malaysia. And I'm sure everyone can appreciate the importance of scoring, the importance of initiating a risk-based low molecular weight heparin, especially after childbirth, especially after cesarean section. Now, the incidence of thrombosis is highest in the first trimester. It reduces in the second trimester. It peaks at about childbirth and remains highest per day in the first 3 weeks after childbirth, but remains high up to 6 weeks of childbirth. And that is how the hypercoagulable state of pregnancy predisposes a mother to thrombosis. But ladies and gentlemen, not all pregnant mothers who have treatment for a complete duration of 6 months make an uncomplicated recovery. We must appreciate that the risk, although it's highest for the first 3 weeks, remains high for the first 6 weeks after childbirth. And that is why some mothers need 3 weeks of treatment prophylaxis. Some mothers need longer prophylaxis of 6 weeks, but the treatment is, of course, 6 months. Say you had a mother who developed thrombosis. You have effectively treated her for 6 months. Who takes care of her? Do you routinely follow up mothers who develop thrombosis during pregnancy? Unfortunately, not in Malaysia, ladies and gentlemen. And now we can appreciate the importance of chronic thromboembolic pulmonary hypertension, where not all mothers who develop pulmonary hypertension make a complete recovery. In fact, the incidence is increased 1.5-fold even among pregnant mothers who have completed 6 months of treatment. And this can be a significant cause of maternal mortality. I'm going to finally talk about other metabolic causes. I'm going to highlight about intrahepatic cholestasis in pregnancy, previously known as obstetric cholestasis. So now we are well versed about the management of intrahepatic cholestasis. We have identified the gene, and we think it is the MDR3 protein, the ABCB4, the ABCB11, which is an autosomal dominant trait, and perhaps the defect in the gene that maintains the bile acid is the cause while the bile acid goes up, and that is associated with adverse fetal outcomes. Now we can appreciate that long-term implications of intrahepatic cholestasis includes, after delivery, higher risk of gallbladder diseases, higher incidence of liver diseases, non-steatotic metabolic liver dysfunction among pregnant mothers, higher incidence of autoimmune hypothyroidism, cardiovascular diseases, even among mothers with intrahepatic cholestasis in pregnancy. And of course, we know the genetic association, where if a mother has got intrahepatic cholestasis, her daughter has got a 90% chance of having intrahepatic cholestasis in a pregnancy alone. So what happens during childbirth does not end at childbirth. I'm going to finally talk about pregnancy and sleep. Now, we do know that if a woman have got insomnia, think of mental health. Don't say it is normal. Sleep is important to prevent prematurity, preeclampsia, and even hypertension during pregnancy. There's an association between sleep and metabolic diseases. There's an association between sleep and infertility, immune system, function, and of course, maternal safety. And there's a condition called gestational sleep apnea, which is made worse because of the weight gain, which is made worse by the hypertension. And mothers who do not sleep well tend to have higher pregnancy complications. So we spoke about all these conditions. We spoke about all these complications in postpartum. What can we do now as obstetricians? What is the solution, ladies and gentlemen? I think it is time we as obstetricians appreciate that our job is not just to deliver. Our job is not just antenatal care. Our job is not just 6 weeks of postnatal care. It is time we invest in pre-conception care, 12 weeks prior to pregnancy. We have done a wonderful job in antenatal care. We have elevated the quality of intrapartum care. We have established postnatal care. But it is time we as obstetricians look beyond 6 weeks, talk, discuss, empower, and modify the long-term implications called the 4th trimester. Don't just take care of mothers before, during, and after pregnancy, but also take care of mothers in between pregnancies called inter-pregnancy care. And the complications of the mother does not just end at her. A mother who's obese, a mother who's got GDM, a mother who's got preeclampsia, a mother who's got intrahepatic cholestasis may pass the risk through the baby, and that is known as transgenerational health. And we as obstetricians have got this unique role to take care of a mother holistically, intergenerational health. So I believe now what happens at 6 weeks should be a continuous process. In the 4th trimester, we should still talk about diet, exercise, home blood pressure monitoring devices. The postpartum period is an important period to talk about preventive strategies, to talk about medications, antihypertensives, statins, and aspirin. Aspirin is not just used during pregnancy. Some mothers also need aspirin to prevent the cardiovascular risk. The postpartum care should be continuous. Mothers who have got complications during childbirth now should have their care transient to the physician, to the cardiologist, because now we know they are at a higher risk of developing cardiovascular diseases. Starting treatment early in the postnatal period is going to make a significant impact with regards to their long-term cardiovascular risk. So I believe as obstetricians, after delivery, we should transient the care and make sure the care is continuum to the midwives that we should train, to the patients that we should empower, to the counselors who should be able to provide these mothers evidence-based counseling. We should update the family medicine specialist, the primary care physician, that this mother now has got a long-term, life-term risk of having complications. The dietitians in the postpartum period is going to be an important intervention, and we should timely refer them to physicians, endocrinologists, cardiologists, psychiatrists, and even sleep medicine specialists, a care that I do in my one-stop high-risk pregnancy care. So for obstetricians, ladies and gentlemen, let's not be engrossed with 6 weeks or 12 weeks. Our job does not end at delivery. I think our care has to be holistic. It has to be continuous, and we should work as a team with people in the primary care level, people with other disciplines, and we should empower our pregnant mothers about the 4th trimester and long-term implications of maternal health. And we should close the loop and circle, and that will be the only way where we can make a difference in terms of women's health, because we must appreciate the life course towards women's health. To summarize my talk, ladies and gentlemen, an obstetrician's role does not end at childbirth. I think as a society, as a fraternity, as a nation, we should invest in the 4th trimester and think beyond how we can introduce risk stratification and preventive tools in the 4th trimester that's going to make an impact in the mother's long-term life. I think we can all appreciate today that pregnancy has got significant cardiovascular and metabolic diseases. Pregnancy is a hyperglycemic state. The incidence of obesity and dyslipidemia is enormous. It is important that we transition our care after delivery appropriately based on the mother's risk to the primary care, to the family physician, or to the cardiologist. As obstetricians who are passionate about women's health, we now need to champion women's health before, during, and after delivery. And ladies and gentlemen, pregnancy remains a window of future health. The only time we can make an impact in mother's life is not just during pregnancy, but throughout her life as a mother. The final quote I would like to say, that an obstetrician's role does not end at childbirth. I believe your job has just started. With that, if you want to know more resources, I would like to welcome you to visit our free social media. There's a lot of YouTube videos on the Obstetric Medicine website. All you need to do is Google Malaysian Obstetric Medicine Society. You will hit our social media. There's a lot of resources in our YouTube channels. It's free to be used and shared by everyone. With that, I would like to thank you everyone for this wonderful opportunity. I'd like to congratulate the wonderful work done by the Society of Maternal Fetal Medicine, namely Dr. Prakash Mehta. Keep up the wonderful work, and thank you so much for spending the 30 minutes of your precious time listening to my talk.
That was a very wonderful exposition of the importance of the fourth stage. I'm sure all our people who have not been practicing the fourth stage and further care of the of our obstetric patients will definitely follow this and make sure that they follow up the patient till possibly the end of life. So thank you very much for this wonderful lecture. Thank you very much for again being with us and being the editor of the book. Thank you.
For lunch, and the session will be postponed to post lunch. Thank you.
You have to put it before thing.
You have some delivery ornaments, right? I thought I could go. That is something to look for.
Exit agaya. Exit agaya. ಮತ್ತೆ ಎಲ್ಲ ಬರ್ತಾರ ಯಾರ್ಯಾರು ಎಷ್ಟು ಜನ ಅವ್ರೆ ಯಾರು ಎಕ್ಸಿಟ್ ಆಗಲ್ಲ ಇಲ್ಲ ಹಾ ಇದೆ 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 ಆಮೇಲೆ ಮತ್ತೆ ರೀಚಾರ್ಜ್ ಮಾಡ್ಬೇಕು ಯಾರು ಇನ್ನೂ ಜಾಯ್ನ್ ಪ್ರಾಜೆಕ್ಟ್ ಡ್ರಾಪ್ ಮಾಡ್ತೀರಾ ಈಗ ಸರ್ ಲೇಟ್ ಆಗುತ್ತೆ
அந்த பையன் கொடுத்தாங்க. One fellow is there, no, you can transfer by that person. Transfer. அந்த பையன் சைடு கொடுத்தாங்க போல. That I don't know, but it's going to come on YouTube. That's what I What is happening is whatever the web time is capturing is going on to the system. So the integration is they are sending it on to
ಮುಗಿಯುತ್ತೆ ಅಂತ ಒಂದು 5
Hello all, good afternoon and welcome from the next session. We are here with the next presentation, which is supposed to be a symposium on fetal growth restriction. So how small is small? So just like how we can see on the diagrams, there is big and there is small, but for saying that an elephant is big and a rat is small or a mice is small is just not fair. It is just that they are genetically made up to be small or big. But when it comes to babies, we need to understand the fetuses. How do we categorize one fetus as small, another fetus as big, another fetus as normal? So let's try and find out how we are going to go through this question with my excellent panelists here, Dr. Kasturi and Dr. Supriya. Before we jump into the entire questionnaire scenario, let's just look at very briefly what is growth restriction, and I'm sure everybody knows about it. It implies a pathological restriction of the genetic growth potential of a fetus. So in this, two words are very important. One, there is a genetic potential for each fetus. So some fetus may be genetically potentiated to grow to 2.5 kilos. Another one may be genetically potentiated to grow till 4 kilos. Now, if we say that, okay, something has caused a pathology which doesn't let a 4 kg baby grow into a 4 kg baby, it is pathological. But a 2.5 kg baby who is supposed to be 2.5 kg and grows to be there, it is quite normative. A growth restricted fetus may manifest not just decrease in weight, but also may show evidence of fetal compromise in terms of abnormal Dopplers, etc. Defining FGR, fetal growth restriction, is important in every pregnancy, but there is also a challenging aspect to it because of how we are going to understand what is the genetic potential of that fetus. So there are lots of definitions which have come in. And whenever we see that there are lots of definitions coming in, we know there is so much of enigma about it, which means we don't know exactly what we are doing to the pinpoint. So there is still something that we can, wiggle upon and say that, okay, this may still be normal in our population. It may not be so normal in another population. To say for fetal growth restriction, AC or EFW less than third centile, or two of the above, AC or EFW less than 10 centile, AC or EFW crossing greater than 2 quartiles on a centile, CPR less than 5th centile, or umbilical artery PI greater than 95th centile. What are the issues with this? The issue is certain times suboptimal growth may also be indicative of GR and can be diagnosed when the growth previously was normal. So it is not a standalone thing. One scan cannot tell that this baby is going to be fetal growth restricted. It is a continuum of problems. Growth above 10 centile with Doppler abnormalities. I'm sure all of us would have seen at least one pregnancy in which growth restriction by these definitions would not have happened, but the Doppler changes have already set in. How do we put them? Where do we put them? Growth is a progressive dimension, just like we were talking before. And Delphi consensus then came up with this idea that AC or EFW crossing 2 quartiles, not necessarily less than 10 centile, can also be defined as growth restriction. What are the associations, madam, that we can think about when we talk about growth restrictions?
So it may be constitutional, that is a small for gestational age. And then that it can be maternal factors like predisposing disorders like hypertension, diabetes, blood disorders, thrombophilias, all this. And it can be that can affect all this will affect the placental aspect. There are so many things that are non-placental,
Like if the baby has some anomaly, either it can be structural, genetic, chromosomal, or some involved levels of metabolism, or some fetal infection which is exposed here.
So, ma'am, do we really see a difference between something called as an early growth restriction and a late onset fetal growth restriction? Do we have a watershed line where we say this is early and this is late?
Yeah, I think so. We should kind of pay attention to that, and the mark is 32 weeks. So actually here is a little ambiguity because this depends on time of diagnosis. So it's possible that a lady has a growth restricted baby, but she's coming up with 32 weeks. So then the challenge is this earlier or late, and as it's shown from this table, there's a lot of difference in early and late, and therefore monitoring and finding decision to delivery will vary between early and late. So in simple terms, yes, I think this is to be paid attention.
So the next question is, why is it so important that we should diagnose and then classify them into early and late growth restrictions? One, of course, is as early as we can detect, we can also start managing the fetal growth restriction early. So which means to say, if we can even predict before the problem happens, the earlier that we are putting in a process of monitoring and probably something to do with not making that outcome come in. Also, if you diagnose it, you at least go through the monitoring process to be a little more robust so that poor outcomes can be avoided. We can modify the risk factors, we can correct the disease process, we can think about and counsel about the surveillance that we would want to. So we may not send a patient home saying that everything is okay and you can come back after a month when we diagnose a fetal growth restriction. Our surveillance mode changes. We put her into a high-risk category patient and then we continue with our surveillance. Delivery considerations, when to deliver them, how to deliver them, should we give them betamethasone before, should we not? All these things also can be answered. Also, we will be able to counsel the couple regarding what are we looking at, what in terms of preterm delivery, in terms of cesarean sections if need be, we can be counseling them about it. Now, this categorization for surveillance, Madam Kasturi ma'am, in your opinion, does it really work when we categorize into low risk, moderate risk, high risk? Do we should take it into consideration?
Yeah, it's important because we can modify our counseling and surveillance and precautionary measures so that she doesn't develop depending upon this disease basis.
So this tells us that it's very important that we identify who is in low risk, high risk, medium risk, and we should work towards it. Then comes the strategy of prevention. Prevention is basically just to the best I can understand, it is pre-pregnancy lifestyle modification. Very obese people should reduce their obesity, they should be working out well, they should do their exercise properly, they should change their food, they should quit smoking and things like that, which does make sure that they are at a high risk later on. And also antenatal aspirin in recommended cases we can start, just like we discussed yesterday. So let's go into a case. Now these cases are just to guide us about how we will see this in a day-to-day scenario. A 25-year-old primary gravida reaches for her first antenatal visit, and in terms of fetal growth restriction, what all would be the history that you would want to understand?
First is history taking, very important. Starts from the age. If she is elderly or very like adolescent pregnancy or elderly, so then we are more. Then if she is very poor, her nutrition is less, poorly undernourished, or obesity. That also. So her weight, this thing, in history, any history of hypertension, diabetes, thyroid disorders, all this, any autoimmune disorders. So we'll be taking in detail. Not only that, her family history of if any of her kids have suffered from this, and also if this is her second pregnancy or third pregnancy. What about the history of the first pregnancy? What was the outcome? Did she have FGR baby that time? Did she have preeclampsia? Did she have any of these medical diseases which are this to the disease, which can again repeat during this pregnancy? So all that history and regarding the lifestyle and any substance abuse, alcohol, smoking, passive smoking, active smoking. Not only active smoking, we have to ask about the passive smoking because the passive smoker is more affected than the active smoker. So that's what when we ask patients, they tell no, we never. But I ask them, does your husband smoke?
are we exposed to that? Because that is also affecting which we are not realizing. So all that, and then nutrition and whether level of stress. If she is in a very stressful work, stress really affects a lot. Lots of inflammation, which we cannot prove it, but it affects. Then coming to the examination, as head to toe examination, everything. So we can look her weight and then blood pressure, serial monitoring blood pressures, and the examination of any other risk factors, which are thyroid disorders or any other autoimmune disorders, all that, and serial monitoring of blood pressure monitoring. And then when we come to the investigations, very, very important one we should realize is dating scan. That is, we have to do that because sometimes irregular periods are not. That dating scan on which we can detect the FGR data. We can follow the growth velocity curve and then detect. So if you don't have, and every time we cannot change the dates, sometimes we find ultrasound report, every time they will be giving a different dates. So that we should, the first dating scan on that, we should plot on the list.
Supriya, what is the importance of dating scan? I did start on it and the first trimester screening in fetal growth restriction.
Coming to when will you do the dating scan? So as per guidelines, it's from 8 weeks to 13 weeks, 6 days. So I think in our scenario where people pay for the scans, but also in our scenario where everybody is sent for an early pregnancy scan, if you have a good CRL, when I say good CRL, the way to take a CRL 7 weeks and less for measurement is different from the CRL taken 7 weeks and after. So the point is you have to take CRL as per guidelines. 7 weeks and less, it is a straight line length. 7 weeks and after is vaginal. So if you see CRLs taken with the embryo showing foldings, that's a common thing. Now, does this make a difference? Yes, because few millimeter difference at this stage will mean a lot more data. So dating scan is important in the way you take the CRL, number one. Number two, at the dating scan, if you're talking, I think that will be dated. So as per guidelines, less than 9 weeks, there's a difference of 5 days, and after 9 weeks, there is a difference of 7 days. So I don't think you should be dating just when there is 1 or 2 days difference. Number three, if you're looking at FGR, then what are the prognostic factors that may be there with the dating scan? One is I will look for separate hemorrhage. I will look where the sac is. A low sac has a tendency to have small babies later. I will also see if it's a small sac. Small sac meaning if the difference between the CRL and the mean sac diameter is less than 5 millimeters, it's a small sac. So these are the prognostic areas to tell me that she may have, apart from other complications, she may have a small baby. So that's regarding the dating scan. And as the doctor said, once assigned, then you will not change the date. You will only correlate subsequent scans and the growth of subsequent scans to the CV. So that's first part. The second part is in the first trimester screening. Oh yes. What for the LP scan, the first trimester scan? Here again, if she's come to me for the first time, and then I get a discrepancy in CRL. Now what I do in practice is I don't go by the impression. I will look at the image. So if the early pregnancy scan image is not as per standards, then I will not mention that it's not per standards, but I'll just kind of brush it aside when I say pregnancy data at the LP scan because of a difference of more than 7 days, and I will make sure that the CRL taken there is as per guidelines. So CRL is important in order to prognosticate. Second is I will look at uterine artery Doppler. Now, uterine artery Doppler again, transabdominally is the preferred method. There is a methodology to that. And with the value, what do? I put it in nomograms. For the nomogram, if on the nomogram is more than 9th percentile, then it is high. But in practice, what I really do is put all these parameters, that is metal characteristics. Where I work, we have the facility, or we do mean artery pressure, and the CRL. I put that into the FMF risk calculator, and then it gives me a risk of this baby being growth restricted. The cutoff is 1 in 150. So if the risk is high, there is 150, 1 in 100, 1 in 50, then I think aspirin definitely has a role. But if the risk is more than 1 in 150, then it's not a high risk. So these are the two parameters. So at first,
just to reiterate, If it comes as a risk for FGR, but doesn't come as a risk for PE, which is a very rare thing to happen, you still put her on aspirin.
Yes, as per evidence, yes, because the calculator straight away says, it recommends.
No, because risk for fetal growth restriction is not something that everybody is into.
Yeah,
They
but
look for
then,
FPE,
I agree, but then we are looking at all these parameters, so we got to know how to interpret it the right way. And this is a free calculator. It's a free calculator there from the website. Even if you don't have PAPA, even if you don't have PLG of them, you can still enter the values. And even it takes some, history and maternal BMI, smoking, ethnicity. Ethnicity is very important. And it gives a risk, so why not use this, especially it's free.
So I hope that's one take-home point, if not anything else, that you should look at fetal growth restriction risk also, not just PE risk. So the others are, like we discussed yesterday, PAPA 11s also. If you have it available, please use it also in calculation. So now the patient's gone forward, everything is fine. She did early pregnancy scan, dating was confirmed, but did not turn up for NT scan or double marker. A common scenario that we see that they don't generally turn up. And then she comes at 20 weeks with an anomaly scan that said, good growth, no anomalies are seen, but subjectively reduced LICA and the uterine artery mean PI of 3.6. Ma'am, if you get a patient like this in your OPD, what do you think about it?
We do tell them that this can be having anomalies because she has not undergone NT scan.
But anomaly, they have said is normal. No anomaly seen at that point of time.
So we take it to whether she had any risk factors for this thing. And so she is more prone to develop preeclampsia and FGR. We do tell them that which is the LICA less. So.
Now, this subjectively reduced LICA in your experience is a factor. Can we look into it subjectively? Because ASI checking is no.
No, I think everybody likes to be objective. So when you see a report subjectively reduced LICA, I would think that why is the sonographer should be reported? Probably when you do a survey scan, there's not enough adequate spaces surrounding the baby. That's why I say subjectively yes. But then when I measure, and what
20 weeks.
At 20 weeks, yes, there's no nomogram at 20 weeks, but then I will measure and only take the deep pocket, no AFI, no roll for AFI at 20 weeks. So take the deep vertical pocket, but of course as per standards. And if I find the measurement is less than 2 centimeters, then I will definitely call it reduced.
Ma'am, and the uterine artery at 20 weeks of 3.6 as a number, do you want to comment on it or you will still put it on?
No, the number stares very hard at me and it's high. So yes, even if I put it to a nomogram, it is high. But then I have a thing here. Now, when we say no anomalies, the tendency is just look at impressions. Please look at the text. Because in the text, there should be a mention of what structures and things to say. If you find that there's no structure, say the renal system has not been evaluated, then I think you should, probably repeat this.
Redo the scan. So if we are not very sure about what kind of scan is done, we redo the scan in the same sitting. But if you're very confident about the scan, then when do we redo it now? With this,
with me?
Yes, when do you call this patient back? Suppose you
are now she's a high risk.
Yes.
She's a high risk because there is less LICA, there's uterine artery PR, which is high. And so she's a high risk for both, I would say FGR, modern preeclampsia. By guidelines, this lady should have a growth scan starting from 24 weeks, some say 24, some guidelines say 26, some guidelines say 28. I think by and large, most agree 24 to 26. So next scan will be at 24 to 26.
Ma'am, and at this time, do you start aspirin for her? 20 weeks.
Actually, we have to start early for her because
But she didn't come. And history based, she was not at risk at all. Now she has come at 20 weeks in history somewhere, but what we are seeing is somewhere else. Do we still start equestrian?
Yes, we start.
Yes,
I have two important answers. I think as a clinician, I wouldn't wait for another month to repeat a uterine doctor. It is glaring to me that she is going into endocrine dysfunction.
No. Not about uterine growth.
No, I have two
repeats. That
is
growth.
Yeah, I'm answering both as a clinician. So one is I wouldn't really wait for another month for another repeat. I would act immediately. I would look at the biomarker at this point of time because it is glaring that there is a endocrine dysfunction. And the second important thing, there are studies by the ACOG practice bulletins which clearly Because you may not completely reverse the disease, but you can definitely improve the prognosis. You will prevent or postpone.
So we start aspirins.
Better late than never.
You postpone disease, and that might give that lady some kind of viability window.
And for repeat growth, we call her early. We don't wait till 28 to 32 weeks for the growth. Yeah, we call them early.
Whenever you have a uterine Doppler PI very high, I should clearly say that you have to see her at least a week for fetal well-being, and at least 2 weeks you have to.
But at 20 weeks, no, one is, I mean, I know, but then, okay, say, suppose you get viability is also not there. Well-being at 22 weeks will be good.
No, I'm saying about the Liker, I'm saying about the Doppler. You can even look at the fetal Dopplers at this stage.
I think 24 weeks is not about Liker guidelines, because in that environment, they will start in 24 weeks.
That's correct. But
So
you're
that's
right.
why, I would think that if we call them more frequently, we're going to add a lot more stress. So I would call this lady definitely 24 weeks later, because in our environment, we still have the facility.
The problem is we need to risk modulate her as early as possible. So that is why at least once you call her early, then maybe 4 weeks.
See the progression.
Okay, so there's a
See the
scope for
progression,
changing the risk.
then you go further.
At 24 weeks, she comes back and says AC at 5th centile, EFW at 14th centile, and normal Dopplers. First question is, can we call it a fetal growth restriction now?
Better than a fetal Doppler.
No, can we call it a fetal growth restriction now? Again, it depends on what guideline you're following. But I do think even if it's not Doppler or normal, in this scenario that I would definitely call it fetal growth restriction. What are we additionally looking for at 24 weeks? 24 weeks, again, because of the time of onset, I will label it early. Although an early scan has said no anomaly, I will redo the scan, or I will send it to somebody who can look for fetal anatomy, signs of fetal infection as well, and do a good Doppler. So why I wanted to put that question is when we send for the repeat 24-week scan, we should not write a growth scan. We should preferably write at least an anomaly scan, repeat. Late anomaly, and look for fetal echo also. See, as a part of anomaly, because the growth per se does not impact the heart. I mean, not at this stage, but definitely look at the rest, I look for fetal infections, I look at the life, I look at the complete document. I mean, this is important. How early can we do the umbilical artery analysis? Yeah, as per normograms, if you look at a nomogram, it starts right from 22 weeks. But having said that, if anybody is doing an NCA Doppler at 22 weeks, and what I practice, a word of caution is don't search for the NCA, don't search for the NCA using a Doppler. You get your correct plane, you go below beneath the BPD plane, the circle of Willis area, that is the stomach won't stand out very well. Once you have that, what do you say, like a hexagon kind of appearance, then only put on Doppler. Because to use very crude terms, I don't want to roast the baby's head. After all, Dopplers, it is potential. I mean, it can give rise to heat. So don't search for an NCA Doppler, but certainly go ahead and do the Doppler. Thank you, ma'am, for that. When to ask for the next step? Again, I would say 2 weeks. 2 weeks. She's high risk now 2 weeks. Yes. So now here again, why not 1 week? No, why not 2 weeks? Not 2 weeks. Somebody said 2 weeks, no?
For the surveillance? As a clinician, I know, because now I think if I'm going to risk modulate her, I would take her to 26 to 27 weeks, which is viability. So I wouldn't really worry about delivering her in 22 weeks. So I would definitely look at her 2 weeks. I would even check for, sir, with your permission, I would check for APLA, secondary APLA at this stage, explain to her the implications, and maybe add on immunomodulators so that she gets that benefit of another 3 to 4 weeks. I'm saying comprehensively.
So that 4 is on red for you to understand it's not 4 again. No, you can't. It's 2 weeks out of question. 2 weeks. 2. And not 1 week. The reason why not 1 week, although we see practices, because on the chart, you really can't see the difference. You can't receive. And there is a lot of inter-observer, intra-observer variability. So 2 weeks is a good time. Now, even before 2 weeks, when do we send the patient? Do you? If she develops hypertension or any bleeding. And what do you ask for being looked at that point of time? Growth, like ma'am said, we cannot look for, but can we look for fluid and Dopplers at that point of time at less than 2 weeks? Yeah, we can look for. Now, what do we plan next? Yeah. So now that the baby has fetal growth restriction, how do we go about with further?
So we have to counsel her regarding like she has to maintain strict fetal count.
What's the plan for management for this fetal?
Yeah, she has to fetal count, she has to maintain every day. And then whether she's developing any other complications like preeclampsia, she has a headache, upper abdominal pain, vomiting, severe tiredness, any decrease in urine output, all those dangerous signs we'll be asking for. So if she has anything of that, she has to report immediately.
Now from this, which was very early, and we are going kind of too strict about monitoring, too strict about evaluation, we go to the next case where everything was quite normal. Second trimester also she completed with good anomaly scan done. And then comes with decreased fetal movements, where BP is at around 140/90, uterus fundal height looks at around 26 to 28 weeks, cephalic, but she is at 32 weeks now. At 32 weeks, after anomaly scan, she is coming to your clinic between no visits. Now 26 weeks to 28 weeks is the fundal height, cephalic with heartbeat present. Now what is your next step? No, I'm not doing anything. It's going off on its own. Yes.
You're asking tough questions, that's why.
So we're suspecting early fetal growth restriction in the
with preeclampsia also.
With preeclampsia, so there is a presence of hypertension.
So we are probably thinking about onset of PE also, and we are thinking about follow-up of the onset of PE also. Sorry, that was about PE, this was about growth, sorry, that was a spelling mistake. Investigations for fetal growth restriction will be serial monitoring. And how serially will be monitored at 32 weeks? Every 2 months. At 2 weeks, do we do growth, ma'am, or no?
Now you said the Doppler was wrong.
No, ma'am, we have not done scan at
No,
all.
okay, so when I say that
32
2
weeks,
presuming that, I mean,
growth
there
restriction
are
is
no
there.
reports, okay, say there are no reports of early scans, I will still treat it like I see her for the first time.
Yes.
So as much as I can see, I will assess fetal anatomy again. As much as I can see, I will look for fetal infections. Then I will look at growth. And if I don't have a previous dating scan, for me, I think what
No,
I'm
still 20 weeks, she has done everything.
You said nothing. No, she done everything.
Everything
Okay.
is 20.
So everything is normal. So that means, yes, because there are the limitations in looking at the fetal anatomy. So for me, we focus now on growth and growth. And I will, even if it's normal, I will feel it every 2 weeks.
Ma'am, everything, now 32 weeks is where we have found fetal growth restriction, and assuming that till 28 weeks she was fine. Like ma'am was saying, now she falls into the late onset fetal growth restriction.
No, on the fence.
She's on the
She's on the fence, but yes, there is a way that we can make out. Can I?
Yes, ma'am, of course.
Okay, you said she's had a previous scans.
20
So what I will do is I'll plot all her, say for anomaly, if that was the only scan, yes, I'll plot that and I'll see if there was a falling trend. Now, if she had more than 2 scans prior to my visit, if there was a falling trend, then I would think that more this is in terms of early FGM. Plus, although not strictly followed, but it is said the early FGR is symmetrical, which means if the HC is also less, the AC is also less, then I would think in terms of early FGR.
And we are actually not very happy when it is early FGR. So this, if the baby till 20 weeks was fine, when do we call her for the next scan? If at 20 weeks she was fine.
24 weeks.
Not absolutely normal baby. At 20 weeks, when do we call her back from?
28 weeks.
28 weeks. Anybody for 32 direct?
No, it was according to, sorry.
No, 32? Some
It
papers.
depends on what you're looking for. It depends on what you're looking for. Because according to the ISOC third trimester guideline, if your onus or responsibility is to look at the fetal anatomy again, then call it 32 weeks.
if you're trying to detect late fetal growth restriction, call it 36 weeks. I think I will do both. Call it 32 weeks and call it 36 weeks.
If clinically everything is normal.
Yeah, she said everything is normal. She said everything.
So at least at 32, we have to call it out.
36. No, they say, yeah, why not is because the guideline says they look at evidence and having repeated scans has not improved that.
Yeah.
So no, I'm saying,
why not consider 28 is from 32?
Normal pregnancy.
Yeah, because, no, your question is why not do so if you do a growth scan at 28 weeks, then when would you follow it again?
36.
No. Because I think the way I look at it is physiology wise, most of the growth happens from 28 weeks upwards. Physiology wise, so I think I would go with the 32 weeks.
The UK guidelines say that when there's growth restriction from 20, I mean, at 20, let's say you can have the Doppler abnormal, you're suspecting any of the risk factors.
No, suspecting is not. You're talking about. Absolutely nothing at 20.
Absolutely normal. I would go about 32 would get into the growth happens supposed to happen up. 32 and then 34.
This is something that we use to decide on management of FGR. Very nicely available literature. But this versus this, early severe growth restrictions versus late mild FGR. Does this actually happen this way when we look at the Dopplers?
No, you're talking about this or you're talking about the other one?
This.
See, this is exactly what happens in pathology.
That's what my question is. In severe early FGR, the Doppler changes are quite dramatic sometimes.
Not all.
That's not all. How does it?
Because if you go by pathophysiology of the placental function, if you look at I mean, do we have time? No, okay, I'll skip that. I'll skip the pathophysiology. You're talking about uterine artery, yes. So the earliest stage, I mean, let me put it
not just the uterine artery, the cascade of events that happen in fetal growth restriction. We are following on the baby with growth. Growth is already bad. Now what we have at hand is decide based on Dopplers, fetal Dopplers. Now that cascade that happens, umbilical artery goes bad, CPR goes bad, FS express goes bad, ductus goes bad. That cascade, do we get that kind of a time in both, in early versus late?
No, not late. Not late. You'll get on an early. You'll get on an early FGR, but not a late FGR. Because late FGR, the challenge is that fetus is mature enough, so it will not always hypoxia as much as it will preterm. So not get the cascade. But then that part is exactly how the pathophysiology works in early FGR.
This is again something that we have to do. So the problem statement, just like how we started early, reduce the mortality and morbidity associated with fetal growth restriction is a problem statement. We have to do that. So we need to know how to diagnose, how to predict, how to treat, how to manage. The requirements are basically identify at-risk mothers, diagnose fetal growth restriction, demarcate the growth restriction from small for gestational age, avoid unnecessary preterm or early term deliveries due to wrong diagnosis. The whole idea is maternal factors should not be non-identified. It should also be identified at the same time. So just like the last patient who also had a preeclampsia test. So don't just look at the baby, look at the mother also in this process. The optimum surveillance pathway is something that we all will have to keep looking into, keep delving into and find out at some point of time. Thank you for your patience with me. Thank you so much.
Present it. This one? Not this one. Not this one.
This session was perfect blend of depth and clarity. I think we have all learnt a lot today. Thank you all. Next, we have a very interesting session. We have a dialogue on labor challenges. I invite the chairpersons for this session onto the dais. I invite Dr. Indra C. Reddy, a respected clinician and academic in obstetric and gynecology. She currently serves as HOD at Sagar Hospital, Bangalore, and has previously held the role of Associate Professor at Vanivilas Hospital, Bangalore, as the Honorary Treasurer of BSOG, and contributed significant publication, namely Hematemesis in Pregnancy and Ovarian Hyperstimulation. Her work spans both clinical excellence and scholarly contribution. Thank you, ma'am, for joining us today and looking forward to hearing your experiences. I invite Dr. Kasturi Donimath. We are privileged to welcome Dr. Kasturi Donimath, a highly respected academician, clinician, and global collaborator in women's health, former professor and HOD at KMC Hubli.
Thank you.
I invite Dr. Rajni Sammal. It's a pleasure to introduce a senior consultant and head of maternal fetal medicine at Bangalore Baptist Hospital. Now for our lovely faculty for the session, Dr. Lata Venkatraman. Who are you? It's an absolute honor to welcome ma'am. Dr. Srimati Raman, a consultant OBG at Rangadore Memorial Hospital.
There is already an imbalance. That side is very heavy. Yeah, with knowledge, experience. Okay. Not by weight, Rajni.
I think it's a challenge.
Your time starts now.
Try our best to finish it in 30 minutes.
Yeah, any labor is a challenge, isn't it? Any labor is a challenge?
Yes.
Yeah. So, yes, labor challenges are many with high-risk pregnancies. So we are going to stick to some special situations. Okay. And there are heavy audience also here. So, anyway. Yeah. So what are the objectives? We wanted to
use the mic. Yeah. It's being transmitted all over the world.
Oh, is it? I thought it was only in this room.
All over the world.
So we'll talk about some general principles. We'll run through actually labor challenges in various medical problems. How do we prepare ourselves for delivery? What should we keep ready? Where should we deliver this lady? How should we be delivering? And when should we be delivering? And do's and don'ts in delivery. Okay.
So I think before that, we need to understand about physiology of labor and delivery, because that helps us plan the labor and delivery in high-risk pregnancy situations. So if you see that there are, I think the slides are not coming properly here. The matter is not coming. Excuse me, there is some problem. The slides aren't coming here properly. The fonts are not seen. Sorry about that. So anyway, the physiology, I think, is something which we would need to look into. The cardiac output generally increases, the pain increases, stress and catecholamine release. There's a raise in the pressure. This obviously affects when the woman is pushing in the second stage because of Valsalva maneuver. We also have concerns because of the GI bowel transit time being reduced.
Absolutely, not only for the patient, but for the obstetrician also. All these changes can happen. Okay.
And I think a few practical overall principles which you need to be thinking about is what medications we are using. I think we need to be careful with the medications, and of course what we should also be thinking about. Yeah, thank you. Now it's coming. Thank you very much. So we might need to, because of the drug absorption being a problem, we may have to give them IV medications. Fluid balance, because obviously there are going to be lots of shifts which happen in labor, which can affect especially women who have critical cardiac output dependent lesions. And as we already said, second stage can affect cardiac and cerebral circulations. And of course, we have to think about what analgesia, anesthesia we are going to be using.
And also we might be introducing infection, which can be more detrimental in some of the medical conditions. So it's very important. So three main caveats, what are they? Yeah, effect of medical condition on labor and effect of labor and birth on medical conditions. So we have to know these as obstetricians and high risk, if you are dealing with high risk pregnancies, effect of medical conditions and its management on the baby. So you have to have a team, neonatal anesthetic team should be robust for you to give, face labor challenges. Okay. So, yeah.
I think this is obviously the way it is. The babies come at the most unplanned time. So I think it's important that we have a planned delivery, especially in high-risk situations, because we need MDT management. Of course, I think we shouldn't forget the optimal disease control in the preconceptional period, because this then helps us avoid an early delivery. I think that is very, very important. And I think it's important, as was emphasized in the previous speaker as well, I think we shouldn't be doing a very early delivery as well. But of course, we cannot leave it too late. I think it's a very gentle balance and a tightrope walk.
It's a tightrope walk. And you can most of the time go safely up to term. In most of the high-risk pregnancy conditions, it is obviously balanced between risks and benefits for the mother and the baby. Not too soon, please. And there is a list of this thing from ACOG, NICE, RCOG, etc., when to deliver these women. Okay. So if you really want to deliver them vaginally, that is when we talk about the labor challenges. If you don't let them labor at all, there is no challenge.
So we can go to term in most of these conditions, and the reason we want to emphasize is because of these special education needs, which go up. I think even yesterday, Dr. Shivlina was very clear about the problems which we face in the late preterm babies. We cannot take it like just because you've gone past 34 weeks, the special education needs increase when you have an early delivery. So I think we have to strive to avoid a late preterm and an early term delivery as far as we can.
Yeah, most of you know what problems they have in late preterms and early terms. Next slide, please. Yeah, so labor for baby and mom, and of course the OBG team with all the physiological changes both for mother and the obstetrician.
So the question comes, do we then have to labor?
Yeah.
Well, I mean, it's a labor for the baby, the mom, as well as for the OBG team. Do we need to labor? Definitely we need to labor, because without labor we don't get the fruits. We know that there are lots of complications with the cesarean section for the mother as well as for the fetus, both in the short and the long term. So we're not going to be discussing about the benefits of vaginal delivery, but I think we need to strive and labor to give the benefits to the mother and the baby.
The benefits overweigh the risks of having a vaginal delivery. That is the dictum on which you have to work. And if you want to do the best for the mother and the lady, and the baby, please see how best you can give vaginal deliveries. Okay, it is not that we are fanatic, but it is important that as obstetricians, we are sort of responsible not only for the lady, but for the progeny and generations of progeny.
Of course, there are a few conditions where you might have to do a cesarean section. This could be for obstetric indications. Again, there's a problem, it's not coming the slides with them. So there is a need for cesarean section, which could be for obstetric indications, or we could have select maternal conditions like a cardiac condition or an AD malformation, which might preclude them having a cesarean, they might preclude them having a labor. So you might have to do a planned cesarean section. But what we need to understand is,
you have to take the same precautions. Okay, and you should be prepared for it. That's what we want to emphasize. Next slide. Yeah.
So this is what we wanted to speak about: the where, who, what, and the how. I think that is very, very important. Where are we going to deliver them? Who's available for you?
Where, what sort of setup? Whether it should have an ICU, HDU, CCU, whatever, and also an ICU, etc., etc. Okay, very, very important to discuss and decide with the lady, and also the care plan should be written in the notes, documented, and also consented, in fact.
Okay. So I think the where, who, what, and how should be planned for all of these high-risk conditions, and that is what we are going to be discussing with a few examples. We may not be able to discuss all the high-risk conditions. Let's look at two examples. One is a lady 30. These are cases whom we have managed. This is a 30-year-old IVF pregnancy who had a complete heart block diagnosed 15 years ago. Her heart rate was running around 50, but she was uneventful, and she's been asymptomatic and has had an IVF conception as well. And the other one was a lady who's a 30-year-old staff nurse who had a rheumatic heart disease, has had a mitral valve, prosthetic valve replaced, and she is now 37 weeks pregnant and she's been on therapeutic enalapril during the pregnancy. So these are two conditions we have recently managed. So what are precautions, what we will need to bear in mind?
So what do we have to be prepared for? Okay, so, I mean, how do we assess this lady first? Okay, WHO and NYHA criteria, nature of the heart disease, medications like anticoagulation, on anticoagulation, etc., reducing the effect of tachycardia or bradycardia, okay, in this particular case, and also whether she needs prophylaxis for the bacterial endocarditis. All these have to be borne in mind when you are assessing that lady for the labor challenges. Okay, so preparedness. What do we prepare ourselves for when you are dealing with a cardiac patient? Pulmonary edema, arrhythmia, emergency pacing in this particular condition. Okay, and also you need a cardiologist, anesthetist who is well versed with, and also intensivist, yes. But cardiologist runs the CCU most of the time. That's why I had.
Especially for the heart lady, we wanted to do a CCU facility because we might have to do a pacing.
And also bridging prophylaxis, you should be aware of. And one-to-one care, whenever she is laboring outside your unit, I think a staff who is well versed in labor should be monitoring her. She can't be left alone with staff, I mean, from the other departments. Really.
In terms of maternal monitoring, again, what we are going to be looking at, sorry about the lady problems, I think the slides are not coming properly. I really apologize for that. So what maternal monitoring do we need to be looking at? The usual ones, which is the blood pressure, heart rate, respiration rate.
You should connect her to a cardiac monitor. Okay, it's very important. You might be having pulse oximeter in your labor ward, etc. But it is important that you have a cardiac monitor, especially in CCU situations where these ladies labor. We have that facility, but it's important not to miss.
Monitoring may not be always needed, but in a few conditions you might have to do because it comes with its own pros and cons. For certain, conditions where you're worried about the cardiac output getting the balance, you might have to think in terms, but simple fluid balance I think is very, very important for us to consider. And again, as we were discussing, we would be planning a normal delivery for most of these conditions, but of course there are a few conditions like if they have been on oral anticoagulants and have in labor, or if they are modified WHO of 4, we may not be allowing them to labor, but otherwise generally the principles of labor have to be followed. So specific, I'm sure you all know about it, I'm just going to go briefly through it, just emphasizing on a few things are avoiding a long labor, avoiding infection, and I think drugs, I think we need to be very careful. Especially with misoprostol and dinoprostol. I think even in the morning we had the discussion about myocardial infarction. So I think there are some concerns about, theoretical concerns about coronary vasospasm with prostaglandins.
And also even a bolus of oxytocin.
Yeah, we will come to third stage later. First stage.
Okay, so.
Labor room means or depending on the modified WHO and the NYHA. So, for example, for a second lady who was on the prosthetic pad, we kept her in the labor room with close monitoring. Whereas the lady with the congenital heart block, the complete heart block, we had the laboring in CCU. So, I think depends upon the modified WHO and the NYHA because we have to see what kind of monitoring is needed and basically plan it accordingly. I think a few caveats which we need to be thinking about is prostaglandin usage. Are we okay in those conditions? I think that is what we need to be thinking about. Of course, labor management.
Second stage, labor management. I think you should avoid supine hypertension. Very, very important because it matters a lot for the cardiac output. And even lithotomy, she should not be put in lithotomy and she should not be using a lot of Valsalva to push hard and hard and hard. So all these are very important, and also effective pain relief during labor. And that will avoid tachycardia and also the cardiac output, etc. So it's very important to think about all these and document it. First stage, what needs to be done. Second stage, what needs to be done. Third stage, what needs to be done. It has to be a different colored paper that you have to sort of use to document the care plan.
So I think that is the first stage. In second stage, we don't have to necessarily cut short second stage in all women, but of course, where we are concerned that the pushing might have an impact. It could be who are worried about them going into failure, critical stenosis, or an ischemic heart disease. You may have to cut short the second stage by using a forceps or a vacuum. I think
even in a congenital heart block, we were wondering whether we should be sort of following her to push hard. Sometimes it can provoke arrhythmias, so that is very important. Okay.
So then, of course, the critical point is the third stage of labor, and as ma'am was already saying, I think it's important not to give a bolus of oxytocin. There are some concerns about carbidocin because if you look at NICE recommendations, they say the evidences are still not very strong, especially in preload dependent critical lesions to use carbidocin because what they are worried about is the long life of the drug. So I think we need to be very careful if you're going to be using carbidocin, though it is obviously advantageous compared to oxytocin in other aspects. Of course, prostaglandin F analogs, we know, ergometrin, we know. I think these are important aspects for us to remember. And not to forget prophylaxis and postpartum care in the next 48 hours because that's when most of them end up going into failure.
I think slow infusion of oxytocin, that's what, and also these panicurs or
if they're going to have
cannula,
PPH.
if they have PPH, tranexamic acid is not contraindicated. So I think you have to sort of use your choice depending on the condition. Methyl ergometrin is contraindicated and PGF2 alpha also can just suddenly increase the pulmonary hypertension. So it's very important. Sorry. Misoprostol is okay.
So misoprostol, what they say is that it's a coronary vasospasm. In MI, I think we need to be a bit careful. But otherwise, it is okay. In other conditions, it's all right. But PGF2 alpha is worried about the pulmonary arterial pressure going up. So that's a concern. Ergometrin definitely contraindicated.
Yeah. Misoprostol, sorry. Yes. Cannula, yeah.
Yes,
that is much safer in these conditions where the other oxidocides are restricted. So, bacterial prophylaxis, we have.
Yes. Next question is about IE prophylaxis. I think the cardiologist would help us, but the general recommendation now is that IE prophylaxis is not usually needed for vaginal deliveries. Of course, I think we'll have to have a discussion with the cardiologist about that. So then, moving.
I think even section, whatever
Section,
we are going to give is quite adequate. So,
sorry about the slides, really sorry.
Yeah. Analgesia and anesthesia consideration. Epidural analgesia is preferred. Both for analgesia and anesthesia.
And I thought here also you would prefer to have a hypertension rather than having the local anesthetics because it avoids the hypertension because in critical lesions, avoiding hypertension also becomes important. Of course, if the woman has anticoagulation on board, we will have to plan it accordingly. So this is the ESC guideline which states very clearly about how you do shifting them over to IV unfractionated heparin and then stopping them over. Or if they are already an LMWH, I think we should follow the standard principles of when you can give them regional.
I think the regional, we'll just recap that. Okay, so because regional analgesia can be given on prophylactic LMWH more than 12 hours after the last dose. Just to recap, that's one. Okay, therapeutic LMWH more than 24 hours.
So if you're doing a cesarean section, this might be okay, but when you're doing a vaginal delivery, you might want to eat, high risk lesions, you'll have to push them over to IV unfractionated heparin and then stop them 4 hours before.
Yeah. Regional anesthesia, you can give LMWH, especially in high risk cases, more than 3 hours.
So after the epidural has been cited, we can consider 4 hours as a
3 hours.
So if you look at our lady, what happened to them? So the first one, who was the lady who had the heart block, we delivered her in CCU with all the preparedness because we might have to do a temporary pacing for her. She did have an epidural top-up, which was a low-dose infusion so that we don't precipitate a hypotension. But unfortunately, we did end up having a section for failure to progress, but we did give her a fair trial. Whereas our other lady who was an induction of labor because we wanted to manage.
The anesthetic team and the theatre team, the ICU, CCU team, all of them were prepared, and this happened during the daytime because we didn't want her to come as an emergency or anything like that. In fact, we took an earlier decision for section, So I think it's very important to sort of be judicious about it.
See, our second lady, we had induced her because we wanted to manage her anticoagulation. So for her, we shifted her over to IV unfractionated heparin, stopped it, gave her the anticoagulation, gave her the epidural, and she did progress well after that. And once it was over, we then gave her the prophylactic LMWH, and from the next day, we started her on therapeutic LMWH and then pushed her over to azithromycin or warfarin, one of the oral anticoagulants later on. So I think we just wanted to highlight the important principles of care in heart disease management. With these two cases, I think with that we will move on to the next case, which is again a bit now.
Ma'am, we did normal, ma'am, Foley and Mysore. Foley and Mysore.
Yeah, in both the cases.
Foley and Mysore.
Yeah.
Our policy is oral misoprostol, deliver microgram, 2 hourly we give them. So that is the same principles which we use for both these things as well. So we do a combined one Foley and Mysore together. You put the Foleys and then along with it start with Mysore.
Okay. And we had close monitoring. We had kept her in the HDU area actually.
Yes.
Yeah.
So we monitor them closely rather than in the ward. So in the labor ward triage area. But the other day, though, when she went into labor, we moved to the
CCU. And also they were on continuous cardiac monitor because you need to see what's happening on the ground. So it's very important. Okay. So yes, yeah, I could be on
something.
Very good.
No, we don't usually give them because anyway we put it in the asymptomatic provider. Usually we don't give antibiotics. So
ITP.
So this was the next case. This was a 30-year-old lady who was an ITP on erythromycin preconceptually because she was resistant to other medications. So in pregnancy, we managed with IVIG and lower steroids. She was having monthly IVIG. And of course, at 38 weeks, because of concerns with FGR, she was planned for induction of labor.
So what are we going to be prepared for? There are anesthetic concerns with this lady. If there is thrombocytopenia, MDT, you want to, the anesthetist, neonatologist to be informed about her. And hematologists, sometimes we can keep them in loop, especially if the thing is severe. PPH, we have to be prepared for. Blood and RDP or SDP, we will have to be PRBC. And we don't particularly need FFP unless they have real PPH.
Only when they go into DIC or they are adding massive PPH as part of it. Otherwise, their SDP, RDP would probably be there.
And also we have to think about stress steroids for her because she has been on low dose aspirin. So these are the labor challenges. That's what we need to be prepared for. Okay.
So for her, I think the most important aspects is the platelet levels which we are looking at. So obviously the safe platelet levels for a vaginal delivery, what they say is even 30 is enough, whereas for cesarean section we want 50. But I think we would be more comfortable at around 70 to 80 because we would want to give them some regional analgesia or pain relief and maybe anesthesia as well if she ends up having a cesarean section. And of course, here in ITP, there is more work for cesarean section for the sake of the fetus because it's not going to help us. So mode of therapy is only by obstetric indications. Of course, we don't use FSC or we don't use CalPS, so that doesn't really hold good here. I think it's important
instrumental delivery
instrumental, but we have used forceps and Ventos, and I think you just have to be very pragmatic about it and not do a very difficult.
That's all.
That is all it is.
And active management of third stage is very, very important. And also, tranexamic acid, please give it. And also the suction cannula, we use it quite often to prevent PPH. So avoiding aspirin,
And also iron injections because that is something which we don't, sort of really pay attention because iron carbidose and sometimes they just give it even without realizing. So I think it's important that we look at the platelet levels before sort of giving it. But
more than 30 is fine.
It should be pretty okay.
So
now
stress, what do we use? Okay.
So I think it is important that we have to look at what level of steroids she is taking and then plan the stress cover. So if anybody is on alternate dose steroids, inhaled steroids, topical steroids, you don't have to give them stress dose. Anybody who is on more than 5 milligram for more than 3 weeks, you should consider. Though evidence is that more than 20, we definitely will have to give. 5 to 20, they say you can look at HPA axis suppression, which is obviously very difficult to do. So we take it as more than 5 milligram for more than 3 weeks. We give them stress dose steroids.
In the last 6 months.
In the last 6 months.
Is another thing. Okay, so you just note this minimum dose of 50 milligrams every 6 hours until 6 hours after delivery. Because again, post delivery also, there can be a challenge for her to cope. So it's important in 6 hours post.
So this is a recommendation.
Yeah.
So if the platelet is very low, from less than 30 for vaginal delivery or less than 50 for cesarean section, we might have to give get the SDP running if you're able to, and then do it because the platelets are going to increase immediately. So we don't have to, sort of give it and wait for a long time. Start infusing the platelets and start planning the cesarean
And also both ways, Dr. Indra. One is you can't store the platelets once you get it because it has to be on an agitator. Otherwise, you will be sort of putting the lady into sort of trouble. Okay, so that is one thing. And also, you can't be sort of transfusing the previous day and doing the delivery today because the platelets get destroyed.
So there will be refractoriness also in ITP, but that is why antenatal planning becomes very important because we want to give them some medication so that we have the same platelet level so that we can go through labor and delivery easily. So maybe around 36 weeks, do the platelet and the platelet is low, then start them on steroid or give them an idea so that we can plan a delivery in an optimal way.
It takes a week to 10 days for her to get the platelets up. So, and 36 weeks you just assist her. Okay.
So I think that is important because obviously ITP, we are concerned about the baby being affected. So I think it's important to tell the NICU people and of course during the platelet count for the season and also monitoring it till the platelet counts are normal. I think it's very, very important because many a time that gets forgotten.
And also delayed card clamping, etc., is as usual. A card platelet count should be done because if it is less than 50,000 usually, I mean cranial ultrasound, etc.
Unfortunately, we don't have any major predictors which will tell us what will be the neonatal platelet count be. But so we don't have to worry about doing anything, sort of like a difficult instrumental or a difficult second stage section is supposed to be avoided. But otherwise, routine care in the second stage is pretty all right.
So in any bleeding disorder, what we are concerned about is regional anesthesia, surgical bleeding, postpartum hemorrhage, etc. Under the treating concerns of intracranial bleeding. This is what we wanted to emphasize in this case. Next, respiratory system, asthma.
So let us quickly run through the next one. In asthma, again, I think we have to be concerned about the exacerbation and of course about stress steroids. Here are a few caveats. I think PGF2 to be avoided, ergometrin, especially along with GA, we have to be a bit careful. Some concerns about morphine because they say it could precipitate histamine release, so I think we need to be a bit careful. So that is all about asthma. So
and also epidural is preferred. Yes. Both for analgesia and anesthesia. But avoiding F2 alpha, it's not a definite contraindication. You should avoid. But if the PPH, if with the risk, well.
So how brittle or asthma is, I think it depends upon that. If it's asthmatic, it's very well controlled.
Yeah. And also you should keep the nebulizer ready in the labor ward. That is another important thing. Epilepsy, convulsions during labor, 1 to 2% risk of seizures in labor. So you have to keep your anesthetist informed and also keep a benzodiazepine loaded actually. Loaded. So that on the sort of, what can I say, the infusion stand.
But we can always have so it's like how the anesthetist keep it ready so that if she does have throw a fit during labor, we could do it. But there is definitely no contraindication to labor. Here, like we spoke about in respiratory, concern is about pethidine and of course tramadol. I think we need to be very careful because they could precipitate a seizure. So this is something which we need to be a bit careful about in women with epilepsy.
And also tramadol is not a very good analgesia. But it can cause problems, especially in women like this. So it's very important. Okay.
So I think we don't come across these AD malformations very commonly. So just a brief word, if it's a low risk, we can plan a vaginal delivery, which is a fully treated cerebrovascular malformations. Infections, I think, again, universal precautions and care
very, very important.
Delivery.
Yeah. I think universal precautions should be practiced in all the labor wards for all women, in fact. Because you don't know who is going to be in the winter period, but anyway. Okay, next.
So then, of course, kidney disease, there is fluid balance and avoiding nephrotoxic drugs. So like that, I think we can have a plan in place for all the medical disorders. Now, finally, we want to finish with diabetes and hypertension. Diabetes, I think the most important thing is the target blood sugars during labor, which we want to keep it as between 70 to 125. And of course,
most of the time in GDMs, you don't get into this problem. It is with the pre-existing diabetic. Even type 1, you can allow them for vaginal delivery, but a very careful monitoring of sugar. And also even type 2 requiring insulin, etc. You have to be careful. Okay.
So I think we can have IV sliding scale with dextrose is the best. But if there are concerns, then maybe you could use a short-acting insulin as a sliding scale, though you prefer an IV infusion, especially in type 1 or brittle type 2, because that gives you a better balance and a better control.
And also keep the diabetologist in loop, especially if they are requiring
1 minute, ma'am.
during
1 minute, ma'am.
That's why.
Yeah, so the other thing is obviously the neonatologist, you have to be careful because we have to think about hypoglycemia, hyperbilirubinemia and the baby.
More the fluctuations of sugar during labor, more the problems with neonatal hypertension.
And I
So
think finally, PRH, I think we have all been experts thanks to benign everything, but just to re-emphasize, fluid management, maybe even IV antihypertensives and anticonvulsants, both for prophylaxis as well as for treatment is very, very important. Avoiding ergometrin and of course, magnesium sulfate continuing postpartum, careful management of fluid.
Labor analgesia is very important because that itself, epidural itself might keep the blood pressure under control. So it's very, very important. And also, when they have to go through a section, I think it's very, very important as senior anesthetic because there might be a lot of laryngeal edema, they might not be able to get into the spinal space. So many things. So, and hypertensive response to intubation. See, you have to stabilize the patient and then only subject her for section. Very, very important.
So we're going to skip preterm delivery. Lastly, one word on critically ill women. So I think it's important that we plan delivery if we have ventilation difficulties or if you think the source of sepsis is intrauterine like chorioamnionitis. Otherwise, I don't think we necessarily would have to deliver them, have to stabilize the mother and carrying on with interventions which we can do to stabilize the mother. Of course, if she crashes, then that's a different story.
But there might be a lot of pressure from the other specialists for you to sort of deliver this lady. But as far as possible, don't add the morbidity of a cesarean or a labor unless it's very much indicated. And if the infection, as you very rightly said, it's intrauterine cause the sepsis. Also, perimortem section, never ever forget.
4 minute rule, I think that is very, very important for us to remember. Yeah. So with that, I think we will probably, sorry, we rushed through labor.
We had to rush through. So be aware and beware of physiology of labor and its effects. Don't get into physiological and pathological problems yourselves. Okay. Planned delivery is very important in managing high-risk pregnancies, timing of delivery, where this lady should be delivered, what other things should be available, who all should be involved, are all very, very important. So this care plan should be written in the file. Okay, preparedness for emergency situations and complications should be documented, and also it should be an MDT acceptance. Sometimes a case conference should also happen. I mean, if it's a very high-risk pregnancy, whether it is a vaginal delivery or even if it is for a section, case conferencing is very important. Counseling and consent is very important. Document the care plan, because if you are not there, somebody else should not. Thank you very much. Thank you, Srimati. Thank you for moderating. We enjoyed discussing, and I think we didn't bore you. Basics, but I think very important.
Where is it? Seriously? Yeah.
Thank you. Sorry.
Yes. This has to be connected.
Helpful session, very well structured, informative and precise. Thank you all.
This is yours only, no?
Yes.
What is this being flashed across here? It's going all over. Don't take things with anybody else. Okay, one second. Here come already.
Let us begin the next session, which is a very thought-provoking one on cancer and pregnancy. Let us begin by calling up the moderators of the session, Dr. Asha Nejvi, who we all know is the unit chief at SDA Medical College, Dharwad, our very own Dr. Prakash Mehta. And now I call upon the panelists for the session. Dr. Yuri Bafna. It is an absolute privilege to welcome sir. He's a pioneer in gynecological oncology and a key architect of the MCS subspecialty training in India. Dr. Chaitra Satyanarayana. She's an accomplished consultant in high-risk pregnancy and reproductive medicine at Genia Fertility Center, Bangalore. Dr. Govindrajan. He is a versatile expert in radiodiagnosis and imaging integration. He currently heads onco-imaging at Apollo Hospitals, Bangalore, and also serves as Director and Chief of Imaging at Mirror Health. Dr. Rekha Rajendra Kumar, a distinguished leader in reproductive medicine and the past president of the BSOG. She currently serves as the Medical Director at Chandana Hospital and Miracle IVF, Bangalore. Dr. Supriya Seshadri, she is a consultant sonologist and a key contributor to the ISWOG Advanced Training Curriculum. Dr. Vishwanath, an accomplished medical oncologist and academician, trained at the MD Anderson Center in Houston. He's currently a senior consultant and academic advisor at Apollo Hospitals, Bangalore. We welcome you all for this panel.
Good afternoon to you all. And all my best wishes to people across the world who are listening to us. We have managed a wonderful panel on cancer of pregnancy where we have a multi-speciality, multi-talented doctors who are going to try to answer certain questions about cancers in pregnancy. So we have from all fields, starting from maternal fetal medicine to reproductive medicine to gynec oncology, radiology, ultrasonography, and radiation, radiotherapy, and radiation oncologists.
I know after the challenge of labor, now we are going to face a challenging situation in pregnancy, and we have certain.
Yeah. Okay.
Yes, sir.
So the topic for today, it's uncommon. It is not that you're going to see a cancer in pregnancy every day. But just remember that the incidence of cancers during pregnancy or pregnancies occurring after cancer treatment is definitely increasing. The incidence of cancer diagnosed during or within a year of pregnancy is 48% higher than an equivalent to the non-pregnant population. If you have a 30-year-old with cancer who's non-pregnant, compared to a 30-year-old cancer with pregnancy, the incidence will be 48% higher. Now, why are we picking up more and more cancers during surgery? Of course, the most important point is that there is a higher pickup rates during pregnancy because the women have a higher contact with the healthcare professionals. So there is a good chance that we pick up a cancer during pregnancy, unlike a 30-year-old normal healthy patient is not going to go to a doctor. And for 1 in 5 women with cancer, the improvements in their management might have altered the outcome. So that is why a multidisciplinary approach is very, very crucial. And all those involved should have enough interest for cancer in pregnancy so that this woman could be saved. Quickly, we'll just go through a case of cancer in pregnancy. So how does it present? This is a 27-year-old with spontaneous conception. She was diagnosed at CML at 13 years of age. Of course, positive for Philadelphia chromosome. Patient was on tablet imatinib, changed to injection interferon alpha 2B on alternate days at 7 weeks of gestation. First trimester was uneventful. Her CBC was 10.8, total count 10,000, platelet was 50,000, but reasonably stable. She developed a blast crisis in the second trimester with fever, myalgia, and joint pain. Injection interferon alpha 2B 5 MIU changed to tablet imatinib 100 milligram 303. Imatinib used during pregnancy has its own consequences, but because she had a blast crisis, we had no choice but to shift her to the drug. With this, she got symptomatically definitely better. And finally, we could deliver her. Of course, she underwent a cesarean section, and both the mother and the baby were all right. So with this, we go to the first question, going to Dr. Chaitra. How common is cancer during pregnancy? Mike, please. Mike.
As Sir mentioned, cancer is infrequent in pregnancy. Talk about the incidence of cancer in pregnancy. We use the term pregnancy-associated cancer. So it is cancer which is diagnosed either in pregnancy or within 1 year postpartum. All this comes as pregnancy-associated cancer. The incidence is 1 in 1,000, easy to remember. And also 0.1% of all cancers or malignant cancers, they are diagnosed in pregnancy. There was actually a systematic review and meta-analysis which was done in 2024 by Ben Walters of Mayo Clinic and his team. So there when they tried to do the meta-analysis, there were 29,000 publications, of which only 22 could be included for the study because it fitted all the criteria. And 0.7 million births were included, 60,000 cases of cancer. So there again, the incidence comes to 1 in 1,000.
Yeah, 1 in 1,000. Though Indian data is still not available. And which cancers are common during pregnancy?
Fortunately, cancers, my personal experience over the last 35 years,
Yes, sir.
I've not seen many cancers during pregnancy. Maybe I am seeing 1 or 2 cases per year. So it's not very common. Cancer during pregnancy is extremely common.
Yes.
And the common cancers which are seen during non-pregnant conditions
Yes.
are also common during pregnancy. For example, the common cancers which we see in pregnancy is breast cancer, cervical cancer, then some extent ovarian cancer.
Hematological,
mainly germ cell tumors.
Yes.
Then leukemias and lymphomas.
Lymphomas.
These are the 5 cancers which are commonly seen in
Yes, sir.
pregnancy.
Yes, sir. Yes, sir. These are the common ones. Cervical, the next cervical cancer is seen young woman, very early stage, and can be detected with pap smear. Early stage, I think we have a little, we don't treat them aggressively because we know that cancer doesn't worsen the prognosis, early cancer in pregnancy. Yeah. Then ovarian cancer and other things. The incidence of cancer during pregnancy, we have cervical cancer, which is invasive, is 1%, breast cancer 0.3, ovarian 0.1, thyroid is unknown, leukemia 0.01 per 1,000 pregnancies, lymphoma 0.01 per 1,000 pregnancies, and colorectal 0.02. Now, that question is, what are the...
Very good this incidence, 1 in 1,000 pregnancies.
This is the National Cancer Institute.
I don't agree with this figure. 1 in 1,000 is very common.
Yes.
Not seen it so often.
This is not Indian data.
This is not Indian data. This is from the National Cancer Institute, and this is 2024 data.
Population around 13 cases per 1 lakh population. General population in India is around 13 cases per 1 lakh.
1 lakh. Yes.
So in pregnancy, 1 in 1,000 looks very.
That's not
1 in
Indian.
1,000 is what is the data. Most of the data is saying. And if you go to see in my personal data,
personally, I have not seen. Cervical cancer is so common, but I don't see at all during pregnancy. Now 35 years experience. I have not very few cases.
I have not seen.
No, just to give an example, in the last 4 months, I've seen a bladder cancer with pregnancy. I've seen a thyroid cancer with pregnancy. I've seen a colorectal cancer with pregnancy. This is just in 2025.
I have seen ovarian cancer, 1 germ cell.
You will see all kinds of cancer. For what brings us is that cervical cancer during pregnancy is not so common.
Yes.
Yeah, it is very rare. Because it is very rare, it should go to the maternal fetal medicine specialist, and that is why we have the panel in this forum.
Next question is, what are the challenges in diagnosing cancer during pregnancy?
The most, I think, common cancer would be cervical cancer.
Yes, sir.
And cervical cancer should not be any problem in diagnosing. Only problem is that in pregnancy, you tend to have cervical ectopy. That could be mistaken for malignancy.
Yes, sir.
Okay, so it's very important to have co-testing done, mainly with pap test and HPV. After the age of 30 years. Before the age of 30 years, normally we recommend only pap test.
Sir, have you done colposcopy? What is the role?
Yeah, colposcopy is recommended for all abnormal pap tests.
Yes, sir. Yes.
Or whenever you have high risk HPV positive, especially type 16 and type 18.
Yes, sir.
If HPV is positive for type 16 and type 18, then
definitely.
Even though the pap smear is normal, you recommend
colposcopy. Yes, sir.
Colposcopy.
Yeah, colposcopic findings which are abnormal, you feel that they require. Yes.
Yeah.
There are two important carry-home messages here.
Yes.
The first thing is that the non-specific symptoms and signs of malignancy, non-specific symptoms and signs of malignancy confuse you and make it difficult to diagnose a cancer in pregnancy. We need to be very careful about that. And the second important message is that pregnant women with suspected cancer should be investigated along the same pathway, in the same timeline as you would do for a non-pregnant patient.
Yes.
So there should be no change just because she's pregnant.
Right.
The investigation and the timeline shall remain the same.
And we are seeing more and more cases becoming pregnant after age of 40. So I think we have to start screening them.
Okay, this will just be the overview of various cancers and where you could get confused. In a breast cancer, because pregnancy, the breast become a little pendulous, more fatty. It's very difficult to identify a mass in the breast at that particular time. So same way with every system, there is some confusion during pregnancy.
Yeah, and the delegates wanted to know, sir, Bhavna, sir, whether there is any role of endocervical curettage or colposcopic directed biopsy.
No, you can take a biopsy from the ectocervix.
Yes,
but
endocervical no role, sir. This question.
Common sense.
This also
Bhavna, sir, again for you, what are the challenges in diagnostic approaches for such a scenario?
For which cancer?
No. Pregnancy with cancer. What would be the diagnostic challenges?
Sir.
Now, if you are talking about ovarian malignancy,
Yes.
I think benign ovarian tumors are not very infrequent, but malignant tumors are unusual.
Unusual.
And most often, the malignancy we see during pregnancy is germ cell tumor.
Yes, sir.
That is, densitomelanoma is the most commonest.
Yes, sir.
Yolk sac tumor and choriocarcinoma of ovary are very uncommon, even during pregnancy also.
Yes, sir.
And epithelial tumors, which are common during pregnancy, are usually benign tumors.
Benign. Yes.
And sometimes you may see borderline ovarian tumor.
Borderline, yes, sir.
Okay, but frank invasive, high-grade invasive cancers are extremely uncommon during pregnancy.
Yes, sir.
And the challenges which we face is differentiating between a benign ovarian tumor
And
and
malignant,
ovarian
yes.
tumor, which may be difficult during pregnancy because the uterus might come in the way. And secondly, the imaging.
Imaging
techniques,
is, yes, sir.
we prefer to use non-ionizing imaging.
Yes.
For example, you can use the ultrasonography scan, or if
MRI.
in doubt, you can use MRI scan.
MRI, sir.
Again, when you are using MRI scan, better not to use contrast.
Yes, sir.
Gadolinium
Gadolinium is
even
contract.
though it is said that it is not going to harm the fetus, generally speaking, contrast is not recommended during pregnancy. So what we can do is, instead of using contrast, we can use what is called as diffusion-weighted imaging.
Images.
Diffusion-weighted MRI scan, which is also a good way to differentiate a benign tumor from malignant ovarian tumor.
Yes, sir. The
So an
point.
important message for us is that CA15-3, what we use for breast cancer, and CA125, what we use for ovarian cancer, and AFP, what you use for germ cell tumors, are all raised in pregnancy, and therefore not as useful as in a non-pregnant patient for a suspected cancer. So we need to be very careful in interpreting these values.
Yes. The question 5 is
Dr. Govindraj.
Govindraj, the onco-imaging, sir. What are the imaging modalities available and how do we choose which one to use and how to balance the impact of radiation on fetus? Sir answered it, but again, we want to.
Just like in any other non-pregnant patients, all modalities are available. The thing is, we have got radiation producing modalities and non-radiation producing modalities. Like ultrasound, for example, is one of the best modalities which is not producing any harm, not causing any harm because it is non-ionizing radiation. Now, the limitation of that is it cannot be used for staging, imaging deep structures, for example, deep retroperitoneum and all those things very difficult. And also pelvic tumors very difficult. So, next modality available is MRI. As you said, MRI actually gadolinium is actually contraindicated in pregnancy except in late trimester. Maybe after 32, 36 weeks, just before delivery, yeah, we can do that, but it's immaterial. Contraindicated. Do it in first and second trimester of pregnancy. You cannot do gadolinium. Yeah, MRI also gives us a lot of options. Like diffusion weighted sequence is one of the options for whole body screening. So which can give an appearance of a PET image, where the basically the diffusion weighted sequence is based on the concept that tumors are cellular, and there will be a lot of water movement restrictions. Okay, so now diffusion is an imaging modality where it measures the movement of Brownian motion of water molecules. Now, because the cellularity of the tumor, the fluid movement is restricted, so that is diffusion is restricted. So that is the concept of DWI or diffusion-oriented sequence. That is a very good modality for screening or scanning the whole body in cancer patients. That is one thing. Mammography, for example, generally not indicated, mainly because one, during pregnancy, the breast is very dense and the sensitivity of mammography is very, very poor when it is dense breast. Second thing, radiation. So some people can argue that you can put, lead and do it, but having said that, because the dense breast during pregnancy, the sensitivity becomes very less, so your risk and benefits are not going to be matched. So ultrasound again is very good, even for identifying pregnancy-associated breast cancer, because it is a non-ionizing radiation, very high resolution imaging is okay. We can address by doing biopsy also using the ultrasound guidance. So these are some of the modalities, and CT and PET-CT is generally contraindicated. CT is also generally contraindicated for imaging of the abdomen particularly.
Yeah, we are going to come to this. I've got questions reserved for Dr. Supriya and Dr. Rekha. They are going to get their own
fetal surveillance
questions at that particular time. Diagnosis also you are going to get it.
Yes.
Okay, so now we have decided that PET scan is not going to be that useful. The impact of ionizing radiation of the fetus varies depending on the gestation and the radiation dosage. That is very important. Now, what we should never forget is that the majority of the imaging results in a very small radiation dose to the fetus. Because what we are talking about is not a direct exposure, but a scatter radiation that is going to go to the fetus. And that most of the time is quite safe. And it is, after with an abdominal shielding, it is very feasible. Now, personally, I have not used as such for a cancer, but we have used it for doing a cholangiogram during pregnancy, where we have to really give high doses to the fetus. But again, you could see in that list there that most of the time the dose radiation exposure to the fetus is quite less.
Yes.
So here I just wanted to add one thing. We have all these modalities. Of course, the basic concept is LR principle. Something called LR, that's as low as reasonably achievable. So you should make sure that the radiation exposure is extremely less or reasonably less.
Absolutely. So that's one point that we definitely need to keep in mind. Coming to the treatment options and considerations, we have basically 4 types of treatments. We'll be going to our panelists asking what are those treatments: the chemotherapy, the radiation therapy, the surgery, and the targeted therapy and immunotherapy. This is what we are going to use during pregnancy also. So with this, we go to first question goes again back to Dr. Bhatna. What are the considerations for chemotherapy during pregnancy?
First trimester, definitely chemotherapy
Yes.
is contraindicated. And it's considered that chemotherapy may be given during second trimester and the third trimester. It's generally supposed to be safer during second trimester and third trimester, but it has got its own consequences also. It is going to cause IUGR, it is going to cause, sometimes it may cause preterm labor, and antepartum hemorrhage chances are higher with chemotherapy. Patient may develop bone marrow suppression, and febrile neutropenia is also can happen with chemotherapy. So definitely chances of preterm labor are much higher with chemotherapy. But second trimester and third trimester, if chemotherapy has to be given, then you have to give.
Yes, sir.
Absolutely. There are 2 or 3 small principles that we need to remember. Is that in pregnancy, the blood volume is more. So the dose of the drug that you give, the concentration will be less. Hence, we may need an alteration in the dose. The second important principle is before delivering her, hopefully stop the chemotherapy at least for 3 weeks. So that when she delivers, you are avoiding a puerperal sepsis from coming in. So these 2 principles we need to keep in mind. The third, of course, would be after delivery. Certain chemotherapeutic drugs, breastfeeding is not allowed. But by and large, for most of the chemotherapy drugs, breastfeeding can be allowed because the amount of milk secretion of the drug is very little.
Yes. Question number 7. What are the consideration for radiotherapies? What's up?
For you.
Vishwanath sir.
Yeah, I'm not a radiation oncologist, but I'm a medical oncologist. But generally, radiation, as all of us know, is contraindicated during pregnancy. And even when it comes to any kind of surgery, for instance, choosing between breast conservative surgery and mastectomy, you tend to go for mastectomy where you can try to avoid radiation. Those kind of situations. So generally, as far as possible, radiation is definitely contraindicated.
Yes.
And even with the newer modalities of treatment, whatever proton, whatever you say, there are very high doses of radiation. Radiation strictly is contraindicated.
Absolutely. What the fetus can tolerate is 50 CGY. As long as the radiotherapy sticks with the 50 CGY, nothing is going to happen to the fetus. But most of the radiotherapy requires a dose of 3,000 to 7,000 CGY. So obviously there is going to be an effect. The good point is the fetus is unlikely to be exposed to the full maternal dose. If I'm giving 3,000 CGY to the mother, the fetus is not going to receive 3,000 CGY. So there is a small protection factor there. And people have even tried doing an ECV because ultimately it is the brain that is important. So supposing I have to give radiation to the upper abdomen, people have done ECV so that the breech comes up and the head goes down, so that when you give a radiotherapy, the head of the fetus is protected. So people have tried all kinds of things. Personally, I have no experience with doing a ECV for radiotherapy, but they have done it.
So definitely radiotherapy is contraindicated during pregnancy. Now coming to question number 8. Chaitra. What are the considerations for surgery in cancer in pregnancy?
So the beauty about surgery is that it's not really contraindicated in any of the trimesters per se. Chemo or radiotherapy or immunotherapy, you do have contraindications. So surgery has been done in pregnancy even for other conditions. So anesthetic considerations and surgical considerations, we're okay to go ahead with surgery if required. So basically the surgical options, either a conservative surgery or a full-fledged surgery, depending on the stage of the cancer, we need to decide. It should be a multidisciplinary team and a decision-making process. So either in case of breast cancer, one of the most common cancers, complete mastectomy can be done, or even a local lumpectomy. Whereas if you're looking at other ovarian cancer, the cervical cancers, basically staging laparotomy can be done. Laparoscopy can also be done. If it is a localized disease, even laparoscopy with low abdominal pressures, we can go ahead and do the procedure. So surgery per se is one of the options that we can do. First trimester, generally we try to avoid surgery. Second trimester is most ideal time to go ahead with surgery. Again, preferably if the diagnosis is after 22 weeks, try to postpone the surgery postpartum.
Yeah, that's
absolutely. I think Chaitra, you have covered all that aspects very well. Now, the next question again goes to Dr. Vishwanath. What are the considerations for targeted
therapy and immunotherapy?
Yeah, the landscape of medical oncology has significantly changed. It's no longer cytotoxic drugs. We have wonderful targeted therapies and immunotherapies. And if you look at all these drugs, they're all very new. The data is, there's paucity of data and very small studies, say 100 patients, 200 patients, they're trying immunotherapy. But again, immunotherapy, as we know, it's got a lot of autoimmune side effects. So generally, we try to avoid these drugs. And even hormone therapy, tamoxifen is contraindicated. And even the targeted therapies like trastuzumab is strictly contraindicated. So again, the safety of any of these drugs, there's very little data to comment about the safety. And as far as possible to avoid.
Can be used. Supposing I have a choice between using a chemotherapy versus immunotherapy.
So chemotherapy in second trimester, like Bhavna sir said, there is data for anthracyclines like epirubicin, adriamycin. Vaccines are to be used with caution, but at least these anthracyclines are not can be used because it's to the test of time for several years.
Absolutely.
But when it comes to newer drugs, we don't have much data, so we not.
So use with caution any of the newer drugs that have come in because we don't have adequate data about its effect on the fetus. Yes, now Dr. Supriya comes in.
What is the impact of therapy on fetal health?
Can I just take a minute and go?
You could cover whatever you'd like because you've got a monitoring intervention, everything you got.
No, talking about diagnosis of pelvic.
Yes, you please include everything.
I've followed IOTA, that is the international.
Yeah,
analysis, and I think they have a great.
That holds good in pregnancy also.
Yes, they have a great workup to distinguish between benign and malignant. So that's an anti-workup in itself, which will tell us whether it's benign or whether it's borderline, stage 1, stage 2, whether it's stage 2. Second is to answer your question about cervical. Mr. Kevin, obviously the sensitizing factor for you will be the lady and continuous spotting. So in that case, I would say that because the pregnancy changes, the cervix can be very well seen and scanned. So when you put on color Doppler and you see this intense color, normally the cervix will only be mildly vascular. But when you see an intense color, say blue clot, you don't see the borders, then you will just miss out on the cancer. Now coming to
impact on fetal health.
Because I think I'm sad to say, but cancer affects in both ways. One is the disease process per se, and second is the treatment of cancer.
Yes.
So the disease process per se can start right from the beginning. So which means in the rating scan itself, you can get, because these patients are more prone to miscarriages. Because of all the changes that happen. So look out for prognostic factors for miscarriage. If she's being treated for pelvic cancer, then look out for the presence of an ectopic pregnancy. So coming to the first trimester, yes, dating is very important. And as we just covered dating, but I'd like to repeat, I think in our scenario, dating at 7 weeks is much better because of the CRL challenges in 12 weeks. So dating is extremely important in order to know when to time therapy and when to time the events. Or how to manage during the pregnancy. So coming to the first trimester scan, it's all about scan. There is no role for NIPT, there is no role for serum markers. So all about scan again, if she's not received chemotherapy, then there's less chances that the baby will be affected. But here again, because of pregnancy changes, the placenta you can have an impaired placentation. So then again, uterine artery is important. Now coming to the second trimester scan, I would think that even if pregnancy, even if chemotherapy is coming later, there's no literature that says that 100% overlaps. They say very rare. So I would rather concentrate on the rare and do a detailed scan. Now the organ systems that are likely to be affected for chemotherapy and radiotherapy is the CNS, then it's the heart, the limbs. These are challenges because in CNS, microcephaly is supposed to be a
very common one.
malformation, and microcephaly can only be picked up in the third trimester. So how do you sensitize yourself is when you see a HC at the 5th centile, you don't call that microcephaly, but then call it again 4 weeks later. And if there's a drop factor, if it's still not reached 3rd centile, call it again and only less than 3rd centile. But less than 3rd centile will happen only in the 2nd trimester. Coming to the other challenges are, they say limb defects. Yes, clubfoot is obvious, absence of a segment is obvious. But what chemotherapy gives rise to is hypoplasia, which is difficult to pick up. So all these things would call for a second anomaly scan. So you do one at 20 weeks and you do one at 24 weeks. And of course, this is a high-risk patient, so you will have to do a growth scan and a Doppler every 4 weeks.
Every 4 weeks. I think you have brought up point beautifully that we need to follow up this patient with a scan every 4 weeks and warn the relatives that there could be developing anomalies. Just because the fetus is normal at 20 or 24 weeks doesn't mean that the fetus is going to be normal all the time.
Test like if it is an ovarian cancer, you do the assessment of the
aorta, yes.
during the pregnancy.
Yeah, that's why I mentioned. I mentioned.
Yes,
She mentioned it.
She mentioned it. The only thing important to remember is that maternal fetal medicine people do not get always only a single trouble. There will be cancer, and to the cancer, preeclampsia, FGR, all that will be added. So it is not that just I'm treating a simple cancer patient. I have to treat preeclampsia also, I have to treat FGR also, and then look after the cancer also. So it always comes multiple troubles.
And whenever there's a diagnostic dilemma, I think 2nd trimester is ideal. You can just open and do a unilateral adenectomy and send it for histopathology. If at all we have a diagnostic dilemma on
I know I'm kind of pulling the matter too long. I'll give it away. I think the challenge is first trimester you can see.
Yeah.
And 2nd trimester, I think the way to go forward is to turn the lady to a side.
Yes.
Turn the lady to a side and then
The next question to Dr. Rekha.
Rekha, madam, what are the delivery considerations?
As Dr. Bhakna said, the early pregnancy is definitely a contraindication. We have missed that period, patient has come to a stage of late 2nd trimester or in 3rd trimester. As Dr. Prakash Mehta said, definitely we during delivery we have a lot of complications expecting, like maybe not just the cancer aspects.
we're expecting other problems as hypertension, IUGR, all that. And sometimes we may be in a state of doing Angiogenic preterm delivery for her because we want her to be relieved of that. And maybe the family itself sometimes requires that mother is more important for us than of this baby. So this is a situation where it can be, we can consider as early preterm or late preterm. All of us know that early preterm is very challenging situation. We may not have the baby in hand, and counseling is very, very important in these cases. Late preterm, yes, we have to consider the antinatal steroids and magnesium sulfate, etc. That is one thing. Then second thing is, as you said, it is 1 to 3 weeks of chemotherapy when you plan the delivery. Of course, some deliveries you can't plan. Vaginal delivery is more preferred.
Except in advanced cancer cervix.
For the cesarean. Cesarean with malignancy with pregnancy. The indication for cesarean section is only when there is an obstruction there below, bigger tumors like cervical tumor, anorectal tumors. So the passage is obstructed. These are the cases where you
not only the obstruction, it can cause dissemination also of the cells. Yes.
So these are the reasons where you opt for cesarean section. Otherwise, you will opt for vaginal delivery in these cases. Another thing, you have to monitor her CBC, the neutrophilia, neutrophil count and platelets should not drop below 50,000. Another important thing. And it's a multidisciplinary practice. You have to involve the oncologist for her, and some mothers and the relatives are very much concerned whether this cancer will spread to my baby also. So this also comes in part of counseling. We have to tell them it is extremely rare. Though, but probably we have to send her to the fetal, pediatric oncologist where they will tell about the fetal cancers, explain to them the psychology and the psychotherapy.
We are coming to that.
Yeah, so these things, because when you take her for delivery, probably these are things she has to go through. And check the placenta.
Placenta, yes, rightly said, madam.
Yes, another important thing, because the placental
meds they have found.
Yes, though it may be a primary stage.
We are coming to that.
Yeah, but I don't know what you're going to cover, so it's part of delivery.
Yes, well said, madam.
Yeah. Yeah, very nicely put up in a nutshell. One thing we need to remember is that keep in touch with the milk bank. Because this baby will need breast milk from a milk bank.
Yes.
So find out where a milk bank is available nearest to you so that the patient can use the services of that milk bank.
So this is for you, sir, Vishwanath sir. How do you handle the psychological? This is
psychosocial and emotional aspect
impact because of cancer.
Patients have cancer during pregnancy.
Yes.
So multiple factors, multiple variables. So we have to look at the type of cancer, the stage of cancer, and again, what trimester and what is the modality of treatment.
I know, Dr. Vishwanath, what happens the moment you tell the patient you have a cancer, they don't, whether it's stage 1 or stage 4, the psychological impact comes in.
The sooner we involve the psychological, the counselors, the onco-psychologists who are trained with counseling these patients.
Absolutely.
It's very important to drive home the point that, it's probably an early stage disease, it's curable. Once we're talking about metastasis, again, we have to start talking about termination.
Yes.
And things will go in a different direction. So it's a multifactorial, multiple factors are involved, and depending on the stage, type of cancer, we have, and which trimester we have to address these things.
One thing that is definitely
postpartum period, she has to have.
Sorry.
Postpartum period, we have to be careful about the thrombotic release.
Absolutely. The most important thing we need to remember is that anxiety and depression are very common in these pregnant patients. We need to be sure that they are looked after. And the second important point is that the amount of psychologically suffering that the pregnant patient has, same cancer in a non-pregnant state, the psychological suffering is much lesser. Because here the concern for what's going to happen to a baby, who will look after the baby if I die, and those kind of questions start coming into the patient's mind. So a very good psychological support, like I said, there are onco-psychologists available who will train, will tell them everything in detail, and that has to be looked into.
Then what are the ethical and legal considerations?
What kind of problems you think ethically and legally?
Legal.
You are
a
lawyer, medicine person as a wife, so that's why I chose you.
Fine. See, fortunately in India, the woman doesn't have major legal implications. because she can decide for the baby and she can decide for herself. As far as the doctor is concerned, it's both ethical and legal. So we have to be answerable to both the mother and the fetus. So most important, as far as the doctor is concerned, informed consent is very essential, because whatever we do, we are doing in the best interest of the baby as well as the mother. So we have to explain everything in detail to the patient about whether it's imaging modality or treatment option or termination of pregnancy or whatever. So we need to be explaining it very clearly to the patient, and patient has to make an informed choice. That is one very important aspect of legal aspect actually. The ethical aspect is for the mother, it's very difficult because she's in the society of ours, she's obliged to take care of the baby, and she cannot be selfish to say that treat me first, let the baby alone. But at the same time, there are so many constraints about treating the mother, treating the baby, and not forgetting the mother. So this is a social dilemma that the mother goes through. But having said that, I think the onco-psychologists definitely they'll be of major help in that scenario, and we should actually have counseling to the entire family. It's not the woman who's going to do the decision for the entire treatment. But having said that, as a professional, as a doctor, all said and done, if you have to choose between the two, it should be the mother that you have to safeguard.
Absolutely. There is one very important concept that we need to keep in mind, and that is wrongful birth. The fetus gets some defect, and that baby, when it grows up, can sue you, saying that why was I not terminated? Why was a wrongful birth allowed? Why am I suffering in my life? So that concept we need to keep in mind. The mother has given the consent. The father has given the consent. But it is ultimately the fetus which is born later who can sue you. That why was I made to be born in this world? So that concept definitely we need to keep in mind. And like Dr. Govindra rightly said, you have to involve the partner. The partner requires a lot of counseling because he is going to be burdened with a baby. He does not know how long a wife lasts. I've got a very interesting case of a rectal carcinoma where we picked it up when she was 18 weeks pregnant. We went on telling her, look, now we need to terminate because rectal cancer, and it was an advanced stage. But she said, even if I die, I don't care. I want a baby. We could take her up to 32 weeks, and at 32 weeks, I did a cesarean section on her, and within 10 days, the mother was dead. But she was very insistent that I want a baby. So those kind of situations, that as obstetricians, what happens is we have a transference reaction with our patients. Possibly you would have delivered this girl for all you know. Now she develops cancer and now she's pregnant. So it's very easy to say that we are not going to get involved with the patient's decision, but what about your own conscience and your own mind? Because you know your patient so well that there could be an ethical dilemma in your mind. Am I doing the right thing or am I doing the wrong thing? Next.
Yes. What are the important aspects in postpartum care and breastfeeding? This is for Dr. Chaitra.
So we already discussed postpartum. There is at least a 7-fold increase in the risk of venous thromboembolism. So prophylaxis is important. We need to know there is a 42-fold increase in risk of maternal deaths in these patients compared to the general population. So that also is a huge number we need to counsel and take care of. In addition, if we have to talk about breastfeeding is permissible post. Yeah. But basically, technically, it might be challenging post-surgery or post-radiotherapy for breastfeeding. So milk banks, as Sir said, have to be accessible and women have to be counseled about this. Additionally, in post-op care, like placental metastasis and then follow-up of the neonate in case of any dissemination, all these things have to be taken care of. And psychological support, you can't undermine the ecosystem.
I think this is the last. Does metastasis happen to placenta?
Dr. Supriya, for you, does metastasis occur to placenta? Okay.
Fetus is less than 0.01% and placenta is 0.1 to 0.2%. So the point is how to look for metastasis. Anyway, we examine the placenta routinely. In the second and third trimester, the placenta is high.
I would expect you to pick up on scan when there's the metastasis.
No, that's not going on. How will I pick up? Is I look at placenta in the second and third trimester is hypoechoic. So in place of that, if I see a hypoechoic area or I say heterogeneous area, then I'm going to be worried. Next one, I will put on Doppler. And for cancer, because of neogenesis, then it's very vascular. But if it is undergone necrosis, you already get peripheral vascular. Now, my question to you all is, if I report metastasis, how is it going to differ? What difference are going to
What difference?
How is it going?
Management, course of pregnancy.
Management. Who would like to add, our medical oncologist?
No, because what is adding stress?
No, okay, Bhasna would like to add.
Metastasis to placenta I have never seen. Metastasis to fetus also I have never seen.
Fetus.
Absolutely.
It's extremely rare. Cervical cancer, for example, cervical cancer, invades it to the placenta, it's going to abort.
Absolutely.
It's not going to continue with the pregnancy. So, I think
The only cancer that commonly, not commonly also, that rarely commonly goes to the placenta is malignant melanoma, which fortunately we don't have that many cases in India. It's mostly the white race that gets the more of melanomas. So we are a little bit saved in that. And a very important point with the placenta is that the trophoblastic tissue is somehow more resistant to malignant cells as compared to normal tissue. And second one, there is a lot of immune rejection of these cells, the malignant cells. So the malignant cells gets destroyed by the trophoblast. And that is why possibly we are not seeing the placenta, because placenta is very rich in circulation. If the malignancy can go to liver, if it can go to brain, it can go to the lungs. Why would it spare an organ which is very rich in blood? It should have got in metastasis. It does not get metastasis only because of the trophoblast.
Only twins with the molar, I think we should do a good follow-up.
That's for choriocarcinoma. It's a totally different cup of tea.
Cup of tea.
Totally different cup of tea. Sorry?
Did I miss a brownie? Did I miss a point? Did I miss a point?
No, yes. No, I'm saying if the metastasis possibly like chorioangioma, you may be able to pick up something.
Yes, the question.
No, you wouldn't be able to differentiate. All you would be able to tell me is yes, there is a mass there.
Yes, the question is how is the survivorship and long-term outcome?
Dr. Govindraj.
Difficult question.
Okay, we can both. You have got two people here, both can answer.
Yeah. First and foremost thing is, of course, it entirely depends upon the type of cancer, the organ that is involved, and the stage of the cancer.
Absolutely.
I can just explain it with one example, like for example, breast cancer, which I feel is relatively more common compared to all other pregnancy-associated cancers. Picking up is very difficult. They can present very late. However, if you pick it up early, the prognosis is almost as good as any other non-pregnant early breast cancer. So pregnancy per se may not change the outcome of the cancer. Only thing is it's about the difficulty in identifying those things.
Absolutely.
That is the most important aspect.
Would you like to add anything?
And probably the optimal treatment, whether it was given during pregnancy, that also may change the outcomes. For example, say HER2 positive disease, trastuzumab is contraindicated, such a situation. Otherwise, I think like Dr. Govindrajan said, I don't think.
Absolutely agreed. Only one question goes to Chaitra because she's maternal fetal medicine. What about the future? She had cancer, we have treated it. Future pregnancies, how will you counsel her? Let's say she had a breast cancer or a cervical cancer. It has been treated properly. She's now cancer-free. She's asking doctor, when do I get pregnant? What can I expect when I get pregnant?
Clear interval is what is usually advised. And of course, fertility preservation in that period of time.
That fertility no, she's okay.
She has undergone treatment, everything.
Let's say you've got a lumpectomy or
everything.
So long as she's under surveillance and disease free, she can plan for the next pregnancy.
yes, what would you tell her? The family is very.
The cancer will recur or worsen.
Cancer will recur. Will it come again? Does my cancer worsen if I get pregnant or I don't get pregnant?
Breast cancer, which you are
Any cancer, any cancer.
No, those who are taking hormonal therapy, I think like tamoxifen or letrozole,
yes,
they cannot get pregnant.
They cannot get pregnant.
So you have to stop the therapy.
Yes,
and when trial is there, then you can say we will try.
So there was a recent trial called positive trial.
Yes.
So the patients
Absolutely.
So they have to take it for at least 2 years, and there's a 3-month washout period before the patient they start conceiving. So that's the plan. So 2 years and then followed by 3 months of washout, and then you can advise for conceiving.
So after a tamoxifen, you need to give a washout period
There are some case reports that again recurrence has happened even after the.
Yeah, recurrence could always come in, just
Yeah.
as it comes in a non-pregnant
Yeah,
patient,
yes.
it could come in a pregnant patient
Yes,
also.
pregnant.
Dr. Vaishnath, again for you,
Can you
some little bit about the
research and advancement?
research, advancements, what is happening in the field of cancer treatment?
So, lots of things are happening, very exciting times to be in medical oncology, immunotherapy, targeted therapy. We are able to give magic bullets, treat lung cancer, make stage 4 patients live longer, good quality of life. And immunotherapy has now become a blanket therapy for most cancers. And we are having a very good overall survival with even stage 4 cancers. Not only that, it's all boiling down to what we call as precision oncology these days. We are able to do what is called next generation sequencing and cell-free DNA, even for say during pregnancy, we're able to do cell-free DNA in the by just looking at the circulating tumor cells, we can say that the patient has cancer, and then based on biomarkers, what we can detect by NGS, we're able to target those particular mutations with magic bullets or oral pills.
So the mantra is personalized medicine. So you need to do that. Now, next question to Dr. Rekha. It's a favorite topic, I suppose.
Yeah, fertility preservation. What is the role? How did it?
And how do you preserve?
Fertility.
What is the role and how do you preserve it?
Yes. Fertility preservation definitely has a role. Probably this question is little different compared to our topic on cancer and pregnancy, because fertility preservation has no role.
Yeah,
non-pregnant.
So considering that, fertility preservation definitely has a role, because detection of cancer in an early age has increased, or getting mother becomes late, the pregnancy age is postponed. So whatever reasons, that is not going to the cause of or the scope of fertility preservation. We do certain things for the fertility preservation, in the sense, once we make a diagnosis, definitely after counseling all this, I'm not talking about a male fertility preservation here, because I presume that it is meant only for the female population. So in females, one is we do what is called as a double stimulation. That in a cycle, we stimulate in the follicular phase and we give some gap, and then we stimulate in the luteal phase. There are many studies which say that the egg retrieval quality and quantity is more. Of course, there are not many papers say that it is better in the luteal phase compared to follicular phase. So that is one what we do. And suppose she does not have a partner, we preserve, the cryopreservation of the eggs. If she has a partner or married, there is an embryo preservation we do. Nowadays, the embryo preservation or the egg preservation retrieval, that's a post cryopreservation. When you thaw, the retrieval rate is almost the same, even if it is a oocyte preservation. So it is egg or the embryo preservation is one thing what we do. The second thing what we do is GnRH agonist we give, but that is not the proper treatment. It is just to bide some time so that everything is under suppression. And that's the second thing. The third thing what we do is we take the ovarian cortical tissue in chunks, and we again cryopreserve that. Instead of the egg or the embryo, this is the ovarian cortical tissue, and once everything is done, we put it back.
Ovarian cortical preservation, how much success rate you have had?
It is much lesser. No, there are
much lesser, much lesser.
20%. I think the experience here in India is much limited.
Yes.
Very limited,
That's why
sir. Very limited.
I did not put it in the first place. But since he asked all the options, I have to tell you. And after that, when we do the put it back, one should be very careful if it is ovarian cancer, because you don't know what you have taken out and what you are putting in, and chances of recurrence. And that is very important when you do that. And sometimes
for ovarian cancer.
Yes, the pelvic radiation field, when they do the ovarian transposition position, so that ovaries are away from the field of this thing. So these are all the treatment options. But when we give we do the embryo transfer. When we do the embryo transfer, we should be careful about the estrogen-dependent tumors, because especially when the FET cycles, that is frozen embryo transfer cycles, we prepare the endometrium with HRT. In those cases, we do give a high doses, especially in these cases who had pelvic irradiation, the endometrium has gone into almost atrophy, does not respond. So automatically increase the doses of our estrogen, oral or the gel. So if it's an estrogen-dependent tumor, again, one has to be careful in that aspect. And when you transfer the embryo, suppose it is a case of borderline tumor, early tumor of endometrium, or it's a ATPR, you would have given progesterone, etc. And you have to make very sure that the malignancy is totally wiped out, and then only you take the biopsy or the Fetal and make sure that it is all totally gone, and then you give the HRT treatment, and then you transfer the embryos.
I think very clearly told as to what we do and when we do. Only just one point I would like to emphasize is that there are certain cancers which have more than 80% of infertility rate. So those cancers are the one where you definitely need to offer your patient fertility preservation. And the common ones that we generally see is the Hodgkin's lymphoma and Ewing sarcoma. So we keep getting patients with Hodgkin's lymphoma quite often. Young girls get it. You definitely need to do a fertility preservation for them. The other ones which are very low risk, like 20%, like acute lymphoblastic leukemia or Wilms tumor or retinoblastoma, even if you don't offer fertility preservation, it should still be okay, because even spontaneously 80% conception rate is going to be there. But these set of cancers where there is 80% infertility rate, you need to definitely offer them a fertility preservation. And Dr. Rekha has already corrected this.
Summarize.
Yes, so I'll also give you a chance. She has already covered all this, and we were asked about the success rates. So these are the various success rates for this tissue, the ovarian tissue cryopreservation. All over the world, a 30 to 40% success rate has been identified, compared to a mature oocyte cryopreservation where there is a 50% success rate. So it is that when you have got nothing in your hand, do ovarian tissue cryopreservation, you may be able to give her a baby. Okay, now Chaitra, you would like to add anything?
One point is ovarian stimulation for these patients. Like we will do a random start protocol, not really wait for a follicular phase or a luteal phase. Just start off immediately so that the duration before the actual treatment starts is short. And second thing is we can add letrozole so that the E3 levels are kept quite low.
Now remember, the fertility treatment of this patient is a little complicated, and this patient is better sent to an infertility consultant who can give her a much better chance of getting a baby, rather than we trying to waste time over trying to get her pregnant.
Yes. The final message, repeated presentation with the pain should be considered as a red flag, needing thorough assessment during pregnancy. Thrombosis, especially migratory or in unusual location, we should inspect fully. All patients with headache should get full neurological examination. Investigation should proceed in the same manner and time scale as for that non-pregnant woman. If there is a specific risk to the fetus, discussion of potential risk and benefits should be held. Depending on the location and stage of the cancer, options of management may include either termination and prompt initiation of treatment, usually for that advanced cancer, surgery, chemotherapy, or radiotherapy during pregnancy, a delay of therapy until the postpartum period, like sometimes early cervical cancer, we do delay. For women with the cancer, advise or postponement of pregnancy, and contraception also, it is individualized. Thank you, sir.
So if anyone is desirous of life, be open in mind and heart. Don't tell her, don't even try for a pregnancy. Please don't ever tell that. If she is desirous, it is our duty to support her to get a pregnancy. And this is one of the cancer patients who is with a baby. Thank you very much, our panelists. You have been excellent in your deliberations. And thank you to the audience.
Thank you.
Thank you. Thank you very much, sir. Thank you to all the panelists.
Yes. ಹೌದೌದು.
I'd like to invite our Sir Dr. Prakash Mehta and Madam Dr. Revati to as chairpersons to the dais. Our next stop. Our next stop is by our invited speaker, Dr. Yi Ping Teo. We are absolutely thrilled to welcome Dr. Yi, a distinguished expert in chemical pathology and metabolic medicine, who is joining us virtually from We're absolutely thrilled to welcome Dr. Yi, a distinguished expert in chemical pathology and metabolic medicine. She joined us virtually from UK. She serves as consultant and clinical lead at Betsy Cadwallader University, Health Board in North Wales, and has contributed extensively to this field, with 16 peer-reviewed publications and chapters in international textbooks on dyslipidemia and biochemistry. She's a respected member of several leading scientific societies across Europe, and her participation adds immense value to our meeting. Dr. Teo, we're truly grateful for your time and presence online today. Thank you very much for joining us.
Thank you. Thank you very much. I hope you can hear me. And thank you for the kind introduction and the invitation to speak in this conference. A little bit about myself. I'm originally from Malaysia and I did my MBBS degree in Australia in University of Melbourne. I then trained as a physician first, finishing an MRCP in UK before taking on training, subspecialty training in metabolic medicine and chemical pathology, and then spent the next 6 years training in the chemical pathology side. I have been a consultant chemical pathologist in a lovely part of UK known as North Wales. And I've been here for about 16 years. So I am very, very grateful for the kind invitation. Now, I'm also conscious that I will try and keep my talk to the 15-minute time slot given. So for this afternoon, I'm just sort of briefly go through preeclampsia because you have had a lot of distinguished speakers already talking around preeclampsia. But I'm going to focus on UK guidelines. UK is one of the first countries across in the world to actually have formal national guidelines for PLGF testing and how it applies in UK clinical practice. So go through a couple of evidence-based papers on how this is being utilized in the actual clinical scenario itself. Then I'm going to share with you my personal experience of how we managed to get a business case approval for the use of triage PLGF meter in our North Wales cohort of patients. And finally, a little bit on the laboratory aspects of the triage PLGF analyzer. I'll make sure that the slides are available by the sponsors here. So I'll go through some of it quite quickly. Now, I do not have to tell you this particular audience about preeclampsia because you guys knows everything about it. Now, specifically, it does affect around 3% of single-term pregnancy. And before I did this talk, I looked at the prevalence of preeclampsia in the South Asian community. And it is higher than the Western community. Looking at preeclampsia prevalence rate around 5 to 8% of all South Asian pregnancy. Now we know that this is associated with a significant maternal and fetal morbidity. People still die from this, and across the world, every year 70,000 maternal deaths are due to preeclampsia and its complications, and 500,000 of fetal deaths as well. So this is a condition that kills not just one life, but 2 lives here. And if we have additional biomarkers that can help us to identify this condition and closely monitor the patients, then this is a price worth paying for. So this is from the International Society of Study of Hypertension Pregnancy from the guidelines from 2021 and defines preeclampsia as hypertension developing after 20 weeks of gestation with one or more of the new onset below, either evidence of proteinuria, evidence of maternal organ dysfunction, including AKI, HELP syndrome, and any hematological complications, including DIC, or evidence of fetal growth restriction. Now, specifically under this criteria, you'll notice that proteinuria is no longer a compulsory criteria, but it's still very, very useful in the setting. If you do find patient with hypertension, is just to do a urine dipstick. The problem with that is that it is not a very useful marker. It's not very sensitive. Many conditions will result in evidence of proteinuria. And although some sites are still asking for 24-hour urine collections, it is extremely cumbersome, and the majority of the time, it is inaccurate as well, because you most likely have a young mother with children and asking this person to actually go and collect the urine bottles and then returning back 24 hours later to make sure that every single urine goes into it. It's not going to be very useful. So this is the problem with the proteinuria, is that it's a useful screening marker, but you need something else to help you to risk stratify your patient's presentation. And why are we interested in this? Again, to this audience, you know the complications of the preeclampsia to the mother and the baby. And we are also becoming aware of, not just during the pregnancy or after delivery, but we are being aware of the long-term cardiovascular complications these patients will have many years down the line. These patients run the risk of higher risk of heart disease, higher risk of developing ischemic stroke, and also higher risk of developing chronic kidney disease as well. So early identification is very important. So what is the underlying preeclampsia pathophysiology? You heard from the speaker, Professor Kenneth Chen from US, about the two-stage model. It's the same thing I've demonstrated on this diagram here. You need two stages here. The first one is some sort of abnormal placenta development. It can be either due to underlying genetics, higher risk in family members who have had previous preeclampsia, environmental, immune, and also metabolic as well. Patients with a higher risk of the diabetes or underlying chronic hypertension will have a higher risk of abnormal placentation. And what it requires is then abnormal trophoblast development, which then results in a reduction of spiral blood flow to the placenta, and ultimately results in placental ischemia. And with the placental ischemia, this is what starts triggering the biomarkers here. So when you have underlying placental ischemia here, you have a production of two separate types of biomarkers. Biomarkers that will be known as anti-angiogenesis. So they are anti-formation of blood vessels, and this will include the soluble FLT1. So that is soluble FMS like tyrosine kinase 1 marker, or you got SFLT1, and soluble endothelin. So they will tend to be much higher levels in your patients with preeclampsia. Conversely, two other biomarkers that will be much lower in preeclamptic patients, and these include placenta growth factor, PLGF, and vascular endothelial growth factor, VEGF. And it is on the basis of this talk that we are focusing on PLGF here. Okay. So what is PLGF here? It stands for placental growth factor. It was first discovered in 1991 by an Italian scientist, Dr. Maria Persico, on the basis of X-ray crystallography. And what she managed to do was to purify and clone the PLGF molecule itself. And she also, at the same time, identified the receptors where PLGF will bind to. And this consists of both VEGF, vascular endothelial growth factor, receptor 1, and also FMS-like tyrosine kinase 1 receptor. They act as receptors for PLGF. The PLGF gene is located in chromosome 14 and importantly encodes 4 isoforms of PLGF. So because there are 4 different isoforms, it is important that when you're looking at laboratory testing for PLGF, not each of the actual setting platforms are different because you're looking at different sites of the isoforms. So the main isoforms are PLGF 1 and 2. Now, we do know that in patients with preeclampsia, main thing to remember is that the PLGF levels will be low. And this forms the basis of how we diagnose this group of patients using the biomarker. Now, this is a nice slide that shows to you the actual normal PLGF concentration in a normal pregnancy. You see that the levels starts rising within about the first trimester, but not much. And then it quickly goes up and rises very high and peaks almost at around 32 weeks of gestation before falls down slightly again. Now, this is the actual graph of a normal pregnant PLGF level population. Now, against this is that in someone with preeclampsia, you can see that the levels barely go up. And this forms the basis of the differentiation between normal pregnancy versus pregnancy that is at risk of preeclampsia. What the PLGF here plays a central role in the healthy pregnancy itself. So as I mentioned before, a low level is associated with complications of pregnancy. We have to look at the different types of assays that the laboratories offer. Currently, there are four different platforms, and there's only one which is a triage PLGF assay that measures the uncomplex bioavailable form. And what is important here is the uncomplex PLGF, which is not linked to the soluble FLT, and hence you only need one test. You do not need two tests like the ratio test here. So what are the clinical guidance and evidence out there? Now, you heard a very comprehensive outline on guidelines given by Professor Anne-Marie Hennessy just now. And these are some of the international guidelines available. I'm going to focus more on the UK NICE guidance here. But at the same time, it's very similar to the ICIT guidelines on the guidance here, and similar to the Society of Canada, Obs and Gynae Canada, and the actual SOMAN, which is the Society of Obstetric Medicine of Australia and New Zealand here. So what do we do in UK? Now, UK, the NICE guidance, NICE here stands for National Institute for Health and Care Excellence. NICE is a governmental regulatory body that looks at doing different using evidence-based medicine to introduce guidelines to make sure that any of the existence of it will add on to making sure that its safety is priority, but at the same time, cost effectiveness of each of the intervention, whether this is drugs or diagnostic equipment, will be important for the population. So in 2019, before COVID, NICE had a very comprehensive review of the diagnosis and management of hypertension in pregnancy. And this can be found on the online link here. At the same time, 2 years later, they have also updated the diagnostic guidance on PLGF-based testing to help diagnose suspected preterm preeclampsia. As far as I know, NICE is the only set of guidelines regulatory body across the world that look at evaluating each individual PLGF test that is available and make recommendations on their suitability. So this is what NICE says in their diagnostic guidance, which was initially published in 2016, updated in 2022. PLGF-based testing is recommended to help to rule in or rule out preeclampsia in people between 20 weeks and 36 weeks of pregnancy. It evaluated 4 different PLGF tests available, 2 of which are the Delphia. Delphia requires a big laboratory platform. So Delphia has either PLGF standalone testing or the ratio, which is SFLT1 PLGF ratio. The other big group would be the Roche Cobas Laxis immunoassay platform, again looking at the ratio. And on a standalone here is the triage PLGF test. And the unique thing about triage across compared to the other 2 of this platform is that triage is what we call point of care testing. It's a very small footprint and easily used in laboratories where their main immunoassay platforms are not Roche or Perkin-Elmer, which is the Delphia one. Okay. And what NICE guidance says is that they evaluated all 3 meters And they're very, very similar. We'll notice that the cutoff threshold is different. The triage one cutoff is 100 picograms per mil. The Delphia one also measure PLGF, but remember what I say about the different isoforms. Their cutoffs is different at 150 picograms per mil. So obviously, there will be like specific protocols on the utility of each of these. Whereas the Roche, the ratio itself, the cutoff is less than 38 as a normal level. All three shows reasonably good sensitivity, but the triage sensitivity is 96% compared to the Roche 80%. But what is more important probably for all three and for the utility of this test is that it's a very strong negative predictive value. All three compares very similarly, 98% for triage. The Roche one is 99% and the Delphia is 97%. Now, the utility of negative predictive value here is that if your patient has got a normal level, then it is useful as a rule-out test. And for the purpose of this talk, so remember that use the test in a setting where you can safely keep the patient at home and you do not need to monitor the patient that frequently. So use it as a rule-out test more than anything. And then there are relevant studies that actually supports the use. So for the triage is Pelican and Parrot, which I will detail a little bit more in further slides. And for the Roche one's Prognosis, Inspire, and the Delphia was Compact. So this is a Pelican study which looked at the diagnostic accuracy of the triage PLGF in women with suspected preeclampsia. Now, it was published in 2013 by Lucy Chappell, who's main investigator in the maternity units in King's College in London. They look at, this is a prospective observations cohort study that looked at 7 maternity units in UK at a group of around 287 women presenting with suspected preeclampsia between the weeks of 20 to 36 weeks of gestation. And using the cutoff of PLGF more or equals to 100 picograms per mil, they could work out that the sensitivity of this cutoff is very good at 96%. And the negative predictive value was as high as 97.5%. So it means that if you have someone with a PLGF level of over 100, you're more likely to see that this patient can be safely managed in the community, does not need an inpatient admission. Now, a few years later, in 2019, so this is 6 years later, Kate Duhigg, which again is another investigator based in Manchester and also with King's College in London, published the Parrot trial. And Parrot trial is a randomized controlled trial, but uses what's called step wedge cluster randomized controlled trial. And what it does is that it compares the utility of PLGF in the same group of investigators. Initially, they are blinded to the PLGF measurements, and then subsequently, they are reviewed. They are actually given the PLGF measurements and see whether their decision-making process has any difference. So it's a very clever trial. It looks at 11 teaching hospitals in UK and significantly evaluated over 1,000 women. Gestational age is again between 20 to 36 weeks. So initially, all units have concealed PLGF measure, meaning that they measured PLGF levels in these units, in these patients, but the investigators didn't know about the results until much later after delivery. But then every few weeks, one of the groups will have the PLGF results reviewed to them, and they can do it live. And they work across the 11 units there. And what it shows is that when compared to concealed PLGF, the reviewed group actually has 64% faster diagnosis. So if they knew the PLGF results or their patient, they can make the diagnosis of preeclampsia 64% faster compared to if they didn't have that results. And also it resulted in 20% fewer adverse events in the maternal side. It doesn't change the perinatal outcome, which is reassuring because it means that babies are not needing to be delivered any earlier, even with the results being available. So that is the case. And this is the actual management algorithm, and it's useful. I think the sponsors will have this in their sites. So we are looking at similar to a traffic light colors: green, amber, and red. So green, you can go; amber, you need to start stopping your car; and red, you stop. Okay. Green one refers to normal results. So PLGF of 100 and above normal. So this group of patients, despite having preeclampsia signs and symptoms, can continue safely with usual management. You still need to observe that. The intermediate one would be levels between 12 to 100. So these are abnormal results. In this group of patients, you need to consider increased surveillance. Not necessarily all of them will need inpatient admission, but it means that you have to monitor them more frequently, and they advocate that you at least measure the blood pressure at least twice a week, test for proteinuria for each of the visit, do your full bloods, UNEs, FBC, liver function, etc. Okay, and also arrange for fetal ultrasound. The small group of patients that are PLGF levels are less than 12. Now, this is highly, highly abnormal. If you do see any of this, you do need to actually look carefully at the patient. Patient always likely to require inpatient admission. And from our study and from our trial here, we have noticed that the moment that the patient's results is less than 12, it's almost like they will require delivery within days of the diagnosis there. So this is a summary of the three trials that is available: Pelican, Parrot 1, and Parrot 2. Parrot 2 came out last year. And again, it looked at confirming the sensitivity of the test is pretty good, varies between 95% to 96%. And the negative predictive value, again, varies between 97 to 99%. Okay. Well, what about our own experience? Why am I here talking to you? It's because we are one of the earliest sites in UK outside the clinical trial sites to actually implement PLGF testing in our hospital. Now, this is our hospital, Wrexham Miller Hospital. It's one of 3 hospitals in North Wales. The drivers for this is during the COVID pandemic. Now, as with a lot of new tests and new technology, you have to balance business case for that, because none of this is free. You have to balance that. Looking at it's not just saving the patient, but also the hospital has to be convinced that you are saving money for them. Otherwise, they're not likely to introduce the test for you. So during the COVID pandemic in early 2020, at that time, this is before the introduction of COVID vaccine in 2021. Maternity patients are absolutely fearful coming to the hospital. They have got young children. They do not want to actually abandon children at home. And they also knew that if they were to admit to the hospital, they have higher chance of catching COVID from other patients. And moreover, our hospital do not have enough beds for maternity care, because a lot of the hospital beds are taken up with severely ill COVID patients. However, we do know that pregnancy progresses, people still have to provide delivery services, and on average, over the 3 hospitals in North Wales, we estimated that around 3,000 maternity deliveries, of which around 678 women per annum is likely to require inpatient stay as a result of the preeclampsia. So this follows the back of the NICE guidance in 2016 on PLGF testing. And also, after the COVID pandemic was announced, the Royal College of Obs and Gynae recommended the use of PLGF testing to help plan decisions for diagnosis. And that's one of the major drivers for us to get the okay from Royal College to say that, right, this is a very useful test for you guys to start considering. So we put in this business case in September 2020, myself and Dr. Linda Verhees, which is a clinical lead for obstetric service across in North Wales. And what we did do was, I won't bore you the fine details of the numbers, but what we could demonstrate from a business case is that we could demonstrate cost savings around £260,000 per year if we were to introduce this test, because it can be offset from the reduced inpatient admissions. Now, if we calculate that to Indian rupees, it's about 27 million rupees in terms of savings of done in our region itself. When the business case was approved, then we had the actual challenge of looking at what platform to use, which one. There are at least NICE has recommended 3 of these. So which one did we go for? Now, the advantage of Triage is that it's a small standalone little analyzer. And because our site, or 3 sites, our immunoassay platform in the laboratory is not Roche, we use as Bachman. Then in order to implement the Roche ratio, we're going to have a massive analyzer in our hospital. laboratory site, and that's not going to happen. So that's probably one of the major driver for us. Turnaround time for triage is a little bit shorter compared to the Roche, and also because this one tests only one test rather than two tests, it was also cheaper as well. So the actual, this was our protocol to use. PLGF testing is indicated in pregnant women between 20 to 34 weeks, those presenting with hypertension, evidence of proteinuria with PCRs between 30 to 50 milligrams per millimole, or worsening chronic hypertension in existing renal diabetic patient. Over a 6-month period, we utilized 32 of these testing in the cases. From here, we then did an audit to see what was the outcome of it, whether the test helps our clinical decision-making process. So of the 32 cases where PLGF results were available, 14 of these levels were over 100. So they are normal and they do not need to come in as an inpatient. 4 of these were very, very abnormal. I'll come to that a little bit in the next few slides. And 14 of that required further closer surveillance. Okay. So for the normal ones, the 14 patients, all of these patients had normal term deliveries. 5 still needed to come in for admission, but this was because of absent EDF and earlier delivery, and also some of it were persistent symptomatic blood pressure control. No patient had preeclampsia at the final delivery stage. With the ones between 12 to 99, so these are the low-level ones, which is deemed as abnormal and considered positive. Preeclampsia cannot be ruled out, and in this group of patients, increased surveillance was actually done. And of the 14 patients, 4 had to come in because of small for gestational age babies. And of the 14 patients, 5 actually needed cesarean section again due to obstetric indications. So what about the last group? Now, this is a smaller group, and luckily it's a smaller group because all of them have very, very abnormal presentation and outcome, okay? So they're looking at PLGF levels of less than 12. When you do get this level, this is very abnormal, and patients do need to come in for further monitoring and also early delivery. Of the 4 cases that we did, 1 presented with severe fetal growth restriction, third centile, and HELP syndrome. Second had, although the fetal growth was normal, a severe preeclampsia requiring magnesium sulfate infusion in the second patient. A third one, again, very similar to the first one, severe fetal growth restriction, third centile, and preeclampsia was superimposed. And then the 4th one unfortunately had HELP syndrome development as well. All 4 of these patients, the babies, were delivered basically within a few days of the initial presentation. Okay, 31 weeks came in, 32 weeks came in. This one is a high BMI of 50, and although was diagnosed at 27 weeks, could held on until 32 weeks before delivery was needed. Okay. So summary for our pilot project funding was that during that 6-month period, we used PLGF tests mainly to rule out any of the normal patients with levels above 100 picograms per ml. Patient is safe to go home. We do not need to keep the patient in for monitoring. Patients with levels of less than 12 needed urgent admission and very close monitoring. Okay. How does it work with the business managers now? Because we have to demonstrate that during that pilot that we are definitely saving money. So we calculated that for each of the inpatient stay, even if it was just a 36-hour stay, it was going to cost us £518 per bed. Over the 6-month trial, when we costed the actual cost for delivering the test itself, we could demonstrate a savings of 34,480, equivalent to around 3.6 million rupees during that 6-month pilot scheme. So I think that this will be my last slide now. Little bit on the Triage Meter Pro. It's a very small little instrument. You're looking at 8.5 inches long, 6.5 inches wide, and about 2.5 inches high. So it's a tiny little meter that you can put anywhere around the actual laboratory the footprint itself. And I know that even in smaller hospitals, you always, even if you've got a larger hospital, a larger laboratory where you send away a lot of your blood samples, there will always be a satellite lab in your smaller hospital that at least to spin down the samples and send it all across. Something like this can fit into it very well. It requires only a small amount of EDTA plasma. Specifically for this one is you do need to centrifuge the sample. So you can't have this meter next to a patient unless you've got a centrifuge next to a patient as well. So it does need to centrifuge the sample for about 10 minutes. And it is interfaced with most of the laboratory platform. So results, it's important is that it is available in 15 minutes time, okay? And quite simple, you add the EDTA plasma into it once you've spawned the sample, put it through and results are 15 minutes. And the advantage of this is that in settings where you may need to do this for only once or twice a week rather than every day, from the laboratory point of view, you save costs because you do not have to do the quality control on a daily basis. And it has got an optimal QC, but that is built into the system itself. Okay, I think. So last slide here, quick look at what is the actual cutoff again. Rate less than 12, highly abnormal. This is important to very closely monitor your patient. But the significance of using this test is a ruling out sign. Any levels over 100 picograms per ml is normal, and your patient can at least stay in at their own house before they need to come into the hospital. Thank you for listening. I'll stop sharing and take questions.
Before I hand over this mic to the chairperson of this session, Dr. Jyotika, I just wanted to ask you one question. What is the positive predictive value of this test? You were talking about the negative predictive value, which was as high as 98%.
Positive predictive value is not very good. Remember that this test utility is mainly to rule out, not rule in. So the positive predictive value varies between 40 to 60% depending on which study you look at. So even if the test say is less than 100, not necessarily your patient have preeclampsia. So you always have to balance the cutoff. With any test, you have to have a level where you use a cutoff. If your main aim is to rule out the condition, then you're going to set the level at where it's safe to rule it out. But the price to pay is that you may have people with positive results that may ultimately not require a lot of active management. So the important test is that it's not a test to actually expedite the need for delivery. The delivery of the baby still depends on other factors.
Yes, I mean, we've been using this test and we are pretty convinced that less than 12 will probably indicate those individuals who are likely to be delivered in the next 2 weeks, and more than 100 has a high negative predictive value of 98. The gray zone is between 12 and 100, and that's a big range. So there is where we may have to kind of put in surveillance protocols to identify how we're going to manage these patients and how long they're going to remain pregnant. So this is something that we really have to look at, and thank you so much for your lecture.
Thank you.
Hope to do this in the future as well. Dr. Jyotika, do you want to ask a question?
How does this compare with?
First of all, thank you very much for, this is Dr. Prakash Mehta. Thank you very much for being with us today. And you have been very much interested in being with us since morning, and we made you wait for quite some time. I really apologize for that because morning we had a little bit of technical glitch. That's why we were delayed. So thank you very much, and we are hoping to have you on some of our other programs in future.
So ma'am has a question.
Just one question.
One more question for you.
Yeah. How does this test compare with SLED PLGF ratio? Just in the beginning.
Yes, what she said is
Would you please repeat again that how does this test compare with SLED PLGF? I know you told us, but the audience would like to listen once more.
Okay, they are for the UK. The NICE guidance recommended 3 different platforms, 3 different versions of manufacturer. You can either be the Delphia Express, which is a big laboratory automated platform, or the Roche again uses the ratio, or the triage, which is a small one. Now, which one you choose, you got to work collaboratively with your laboratory. If your laboratory already have a Roche platform, it's there and you are able to get the samples across and can turn it around, then obviously then go for the ratio, because the Roche has a good task for the SFL S-split 1 to PLGF ratio, and that will be very useful. However, if your laboratory does not have PerkinElmer, Delphia, or Roche as an automated immunoassay system, then you can't really ask them to go and just have this, because there's no way that they can supply it. And this is where the advantage of triage is, because it's a very small little meter, literally the size of this. And if they can actually bring it into the lab, into the satellite lab, and to do that.
The specific question is, how does the negative and the positive predictive values compare with the ratio? So, as
very similar, very similar. I think I've got a slide that I'm.
Yes, the negative predictive value is comparable with the ratio. So, madam, if you're looking at the negative predictive value, it could be as high as 98%. But the positive predictive value of the ratio for the next 2 weeks is about 60%. But here the positive predictive value may not be all that good, but it serves as a rule out test and it's a POC. So we still benefit by having this test for ruling out in our situations. But if you have a test which is working for less than 12, it would still be beneficial, because these are the individuals who probably will develop severe disease in the next 2 weeks. Thank you.
So
thank you.
very much once again for being with us. I hope to see you in future sometimes.
Thank you.
Thank you.
Thank you. Thank you. Thank you.
Thank you very much. I call upon Dr. Srimati, who led the scientific paper and poster committee with such efficiency and dedication. Jyotika, please stay. Prakash sir, please come up on the dais. Jyotika ma'am, please come up on the dais. To give away the prize winners, their gifts.
I got to present also.
No, sir.
No, it's not fair. It's not fair. 10 minutes for super please.
Present, sir.
Yeah, they have to present now. It is not fair. You promised them.
Okay, fine. So, shall we call upon Pavani? Is she here?
Pavani, are you there?
Yeah. So we'll ask them to finish quickly.
There are 2 minutes. No?
2 minutes.
4 minutes. Right?
So, I mean, shall I announce the winners first and then?
Yes.
Yeah, I'll announce the winners. So we would request the prize winners to do a very brief presentation. No introduction, just a case summary. Okay, very brief. So I thank SMFMI and Prakash Mehta sir for having given us the opportunity for doing the abstract presentations review. We had a total of 21 abstracts which were submitted through Google Forms, out of which 10 were selected for papers, 11 were selected for posters, of which special mention I need to make 3 undergraduate students in the 3rd year did their presentations, which was really commendable, setting a big round of applause to those students, and of course their mentor, Prakash Mehta sir. All presentations were judged online on Zoom. We did it on April 15th and April 17th. We had judges, Dr. Jyotika Desai ma'am, Manisha Kumar, Dr. Jayanti, Dr. Padmaja, Dr. Malini, and Kasturi Donimal. Many thanks to all the judges who did the job online for us, taking out their precious time. So thank you very much to the judges. So for the free papers, before I announce the winners, I want to make a special mention of Dr. Malini Sakyogla from Fernandez Hospital, who is an F&B trainer herself, but it was really very commendable. It was very humbling of her to come and present a paper on delta glucose values in OGTT. It was really a great gesture on her behalf, because she presented on behalf of a student who wasn't able to present. So many thanks to Dr. Malini. So of course, now the prize winners, Dr. Shravani from Baptist Hospital for winning the 2nd prize. Anyway, she's going to be presenting her paper. This is unraveling the interplay effect of preeclampsia on perinatal outcomes. Then we had the 1st prize going to Fernandez Hospital, Dr. Priyanka, on her paper on cancer and pregnancy. It was a fantastic study over a 10-year period of 40 patients with cancer before and during pregnancy. Many congratulations to both the prize winners. And with regards to the posters, I will have to definitely mention our own Dr. Anu Joseph, who presented a poster on extralobar pulmonary sequestration. Many thanks, Anu, for enlightening us on this condition. It was really very nice of you to come forward and do this poster presentation. Of course, we cannot be giving a prize to our own member, so a special mention to Dr. Anu. In terms of the best poster is Dr. Varsha from Rangadore Memorial Hospital, who presented on Schmitter syndrome, Art Twist, the Unseen Path of Schmitter syndrome, a case report. And a special prize for the undergraduates who presented. Of course, all three did a great job, Pavani, Pavitra, Naman. But of course, we had to give only one prize, and that prize went to Dr. Pavani. She presented a strategic management of severe RH isoimmunization with a posterior placenta, and she's from Ramaya International Medical School under the mentorship of Prakash Mehta, sir. So that finishes the prize winners list. So we would request the prize winners first, Pavani, next Varsha, then Shravani, and then Dr. Priyanka to come and present their posters and papers. A very brief presentation, please, so that we can know what your cases were about. Yeah.
Or if their abstracts are there, you can just put their abstracts.
No, let them come on the stage.
It'll be nice for them to. No, and we have got the presentations as well. Yeah, come, Dr. Pavani, come.
Pavani, come.
Good evening, everyone. Like ma'am mentioned, I'm Pavni, a third year MBBS student. So basically, this is a case of severe RH isoimmunization, which is complicated by posterior placenta. She was a 27-year-old primary gravida with O negative type of blood, and her husband was AB positive. Her ICT was positive at dilution of about 1:128 at around 17 weeks of gestation, which kept on increasing. Along with this, the ultrasound also revealed a posterior placenta, indicating challenging the conventional transfusions that we do. Also, her MCA PSV values were very high at about 62.7 centimeter per second. So firstly, the normal intrauterine intravascular transfusion was attempted, but it was very challenging. So it had to be, we couldn't continue with the procedure. To buy some time, she was started on IVIG therapy, of course, after informed consent. And at around 29 weeks, the transfusion was attempted again, but only cordocentesis was possible, which revealed hemoglobin of about 10.6 grams per deciliter. Later, an intraperitoneal approach was resorted to. 65 ml of O negative packed cells with a hematocrit of about 89% was successfully delivered into the fetal peritoneal cavity. There was no complications after the procedure. The fetal heart rate was stable and there was no evidence of bleeding. The conclusion is that IVIG therapy can effectively temporize in cases where immediate transfusion is challenging, and intraperitoneal transfusion still remains valuable when umbilical access is compromised. The baby was delivered. Actually, the plan was to deliver at about 37 weeks, but the patient came with premature rupture of membrane, so the baby was delivered at 34 weeks. Right now, both the baby and mother are healthy.
Many congratulations, Dr. Pavani, and request Jyotika ma'am and Prakash Mehta sir to give the poster prize.
Next is you.
Congratulations, and I hope you probably take a career after Oration. Congratulations. So next we have Dr. Varsha, who is going to present a poster on Schmitter syndrome.
Good afternoon. Presenting heart twist, the unseen path of Shimiter syndrome, under the guidance of Dr. Srimati Raman, Dr. Savita Shirodkar, and Dr. Lata Venkatram. Shimiter syndrome is a variant of pulmonary anomalous pulmonary venous return, in which the right lung is drained by the right pulmonary veins that connect anomalously to the inferior vena cava. The affected lung, which is usually the right lung, is usually hypoplastic with abnormal bronchial anatomy. Other cardiac defects are commonly seen and often include hypoplasia of the left heart or the aorta. The incidence of Shimiter is 2 in 1 lakh in live-born infants. The term Shimiter represents a radiographic appearance of an anomalous venous drainage, which is likened to the silhouette of an oriental sword. Here we are presenting a case of a 30-year-old gravida 4 abortion 3 at 12 weeks of gestation, who, with IVF conception, who was booked at Rangodara Memorial Hospital with 12 years of non-consanguineous marriage with no significant family history. The NT scan showed the cardia in the right hemithorax with a differential diagnosis of Shimiter, left diaphragmatic hernia, or evolving left lung masses. She had no other comorbidities and was on low-dose aspirin and folic acid. The couple were counseled about the findings and they wanted to wait for further scans. The TIFA scan at 20 weeks shows right lung hypoplasia with pseudo-dextrocardia with partial anomalous pulmonary venous drainage with the Shimiter vein. The couple were recounseled of the condition and they opted for medical termination of pregnancy at 23 weeks. So the most important pointer for prenatal diagnosis of Shimiter is an abnormal position of the heart in the thorax with a right-sided mediastinal shift. In such cases, a thorough search for the abnormal pulmonary venous drainage is warranted in order to establish the diagnosis and also to differentiate other causes of dextroposition. The prognosis usually depends on the presence of associated major anomalies and any need for neonatal intervention. Thank you, sir.
Congratulations, Dr. Rasha. And first, Shobhika ma'am, please honor her. Next, I request Dr. Shravani to come and present a paper. A brief summary with the methods and the outcomes, please. Thank you.
You have already downloaded it. No, where is it?
Stop sharing that.
Best of
Yeah, just share. Yeah, I'll make it.
Good afternoon, everyone. My paper is all about the unraveling the interplay of both preeclampsia and GDM. As we know, both are the common public health concern. The presence of preeclampsia increases the adverse outcome in women with the GDM. So we wanted to know the perinatal outcome percent, whether they both conditions coexist, and also to see whether the glycemic control will affect the outcome. Aim of my study is primarily to explore the effect of preeclampsia and perinatal outcome in women with a GDM and to determine the impact of glycemic control on rate of preeclampsia. Secondly, to examine the combined effect of GDM and preeclampsia and long-term health outcome over a 5-year follow-up. This is our methodology. We conducted this study, prospective cohort study, for 6 years in Bangalore Baptist Hospital. We had a total 2,150 GDM cases. We divided them into GDM alone, 2,039 cases we have. GDM plus preeclampsia, we have 111 cases. Excluded women with over DM and chronic hypertension. This is our methodology, what we follow in our hospital. When we see the results, the trend is increased from the past 6 years. Age more than 35 years is a significant factor. However, parity is not significant. Pre-pregnancy BMI is significant factor. When we see the treatment modality, when compared to diet and insulin, women using a metformin has a lesser incidence of preeclampsia. And when we see the maternal outcome, majority of outcome were significantly associated with when both conditions are coexisting than with GDM alone. The same follow with neonatal outcome. And when compare the self-monitoring versus periodic follow-up, self-monitoring group has a lesser incidence of hypertensive disorder of pregnancy than periodic follow-up. When we see the secondly follow-up for the 5 years period, we found that there is a higher risk of developing chronic hypertension in the combined group than compared to GDM alone, and such statistical significance not exist with type 2 diabetes. Thank you. I'd like to thank you, my mentors, Dr. Rajni sir and Satya ma'am.
Thank you, Dr. Shravan. I request Jyotika ma'am to give her the prize.
That is for the next one.
Next, we request Dr. Priyanka Maniji from Carnatas Hospital to present a paper, the first prize winning paper. Many congratulations, Dr. Priyanka, on cancer in pregnancy. I think it's very befitting that it follows the panel which was done by sir.
Good evening, everyone. My topic is cancer and pregnancy, maternal and fetal outcomes. It was conducted over a period of 10 years from 2014 to 24. It included both mothers with cancer diagnosed during pregnancy and also the cancer survivors. So, coming to cancer diagnosed during pregnancy, there were 12 women with cancer diagnosed during pregnancy in my study. 3 were having breast cancer. One of them was diagnosed at 16 weeks and she received 2 cycles of chemotherapy. And 2 were renal cell carcinomas and 2 were leukemias. And 2 mothers were diagnosed, one with GE junction tumor and other with hypopharyngeal carcinoma, and they both presented with refractory hyperemesis. And 3 mothers among this cohort received treatment during pregnancy, and 5 were terminated for cancer. Preterm, they were terminated because of cancer during pregnancy. Coming to pregnancy in cancer survivors, 26 women with 31 pregnancies were included in this cohort, and there were 5 twin pregnancies, most common being Hodgkin's lymphoma followed by papillary carcinoma of thyroid. And they received all kinds of treatment, and the time interval between the conception and the treatment is 2 years. And FGR accounts for 13% in these cases, whereas preterm delivery and LSCS were done only for obstetric indications. So, so the conclusion of my study is cancer in pregnancy is manageable with multidisciplinary care. Chemotherapy can be safely administered after first trimester, and these mothers need frequent growth surveillance to detect fetal growth restriction. Thank you. Thank you, Dr. Tara, and thank you, Dr. Malini, for training me.
Yeah, we miss Tara ma'am in the conference here. Thank you, Dr. Priyanka. That was an excellent presentation and befittingly is getting the first prize. I request Jyotika ma'am as well, along with Dr. Prakash Mehta sir, to give it. Jyotika ma'am was the judge for this particular paper.
The first prize that we are giving is the book that we have released this morning.
I thank Prakash Mehta sir, Revati, as well as FMI, and Akshita for having an abstract presentation, and of course the backdrop authors who have helped us.
Yeah, we have to thank Dr. Srimati. She has, of course, I think a little bit of help from Anu, definitely. Has done this poster presentation very nicely and to the satisfaction of everybody. Thank you, Dr. Srimati, for doing all the work. Thank you.
Good evening, everyone.
Good evening.
Yes, sir. Good evening. Good evening, everyone. I'm going to be giving the vote of thanks. It is indeed a great privilege and honor to deliver the vote of thanks at the conclusion of this enriching academic session. First and foremost, we extend our heartfelt gratitude to our esteemed speakers for generously sharing their time, their expertise, and insights in the field of maternal fetal medicine. The perspectives shared over these 2 days have significantly enhanced our understanding and inspired us to continue our academic journey with renewed enthusiasm and commitment. It is truly heartwarming to witness the widespread acceptance and support that this event has garnered, with delegates joining us not only from across the country but also from across the world. We are delighted to see the growing footprint of SMFI across India and beyond. We express our sincere thanks to Dr. Prakash Mehta, whose visionary leadership, unwavering support, and constant guidance have brought us to this milestone. Our heartfelt appreciation also goes to Dr. Revati, whose tireless efforts and dedication have been instrumental in the exponential growth of SMFMI. We are especially grateful to her for encouraging all of us to actively contribute to the Society's academic endeavors and for giving us the opportunity to be part of this vibrant community. We would also like to thank Dr. Smita, our treasurer, for her continued support and contribution towards the smooth functioning and financial stewardship of SMFMI. We are privileged to have had the support of our distinguished international advisors, Professor Sosh Rana, Professor Kenneth Chen, and national advisors, Dr. Kamini Rao and Dr. Ramurthy, whose involvement added immense value to this event. A special word of thanks to all our national and international speakers who share their wealth of knowledge and contributed to the success of this academic gathering. We would also like to express our sincere appreciation to Dr. Srimati, who led the scientific paper and poster committee with remarkable dedication and efficiency. Her efforts ensured that the academic rigor and success of this important segment of this event was maintained. Our heartfelt appreciation goes to the executive committee members and the core committee members of the SMFMI, whose dedication, hard work, and passion have been the backbone of this event. We would also like to recognize Dr. Meghna Srinath, who holds a master's in translational research from Mount Sinai, USA. Despite working virtually, she has made significant contributions, including authoring a chapter, and continues to be an asset to the SMFMI team. A very special mention must be made of our behind-the-scenes champions, our SMFMI office staff, especially Mr. Raj Gopal, whose meticulous attention to detail and tireless efforts ensure that every aspect of this event ran seamlessly. Your commitment and dedication truly reflect the spirit of excellence that defines our society. We gratefully acknowledge the support of our sponsors, particularly Fetal Ortho, Sun Pharma, Samya Incorporated, Shield Healthcare, Mayors Vitabiotics, Diagnostica Span, Neon Naturals, Lalimer Life Sciences for their generous partnership. We also extend our sincere thanks to the BMGH management, the auditorium team, audiovisual and IT teams, the volunteers from BMGH, and Mrs. Nadia for their invaluable support and coordination in helping us deliver a smooth and successful event. Finally, to all the delegates who participated so enthusiastically, thank you for your presence, your attention, and your active engagement. And let us take forward the knowledge and the insights that we've gained here and apply them meaningfully in our own clinical practice to better serve our patients and to save lives. thank you once again for being a part of this event and for making it a resounding success. Thank you.